السلام عليكم.
السلام عليكم يا دكتور.
زي الحال؟ ايه النور ده؟
اهلا اهلا، صباح الفل.
I am ready.
اوكي.
احنا لسه ما بدأناش.
We are waiting مريم. فاديني
طيب جميل.
وهنبتدي باذن الله.
ان شاء الله.
Hello, Dr. Abrak.
اهلا
Actually,
وسهلا
we want to welcome
مريم.
Professor Abubakar as he is the honorary president of the hub. And now we will give you a brief speech about uh, American Association with our beloved Professor Abubakar Nashawi.
Can we start?
Yes, Doctor, we can start now.
Yes, I would like to thank the American Association for kind invitation for this prestigious meeting. This is not the first time. American Association for Continuous Medical Education is an international organization that provides continuous medical education program for physicians through theoretical and hands-on workshop. American Association is registered organization with 3 main offices, including United States, Egypt, and United Arab Emirates. American Association offers training, event management, and consultation for physicians. Our services are offered globally, and they are pioneer in providing the international continuous medical education. We will today address a very important subject or important field, the high-risk pregnancy. And the first speaker to be introduced, Mariam.
She will introduce the company, and thank you.
Hello, Dr. Abubakar. Thanks very much for this amazing speech. Professor Abubakar Nashar, he is honorary president of Pregnancy-Related Complication Hub. And now we will start our speech with the Chief Executive Officer, Professor Dr. Nagwan Al-Muhandis. And then we will start our informative lecture. Thank you, Professor Abubakar, and for sure we can wait to hear from you.
Okay. I have to start, Mariam.
With the lecture and your interesting topics.
Thank you, Dr. أبو بكر. حضرتك سامعني يا دكتور؟
سامع حضرتك، اتفضلي.
اهلا اهلا يا دكتور. انا just thank you so much for this amazing introduction for American Association, and thank you so much for being here. Actually, you support our free hub since the last year, and you do a lot of effort, and a lot of you give a lot of opinion and answering for different questions. Thanks so much for the past and the new, inshallah, and wishing you best of luck. I want to introduce myself. I'm Nagwan Al-Muhandis, Dr. Nagwan Al-Muhandis, General Manager for American Association for the Middle East and North Africa, the MENA region. I'm here to introduce with my colleagues our 5th series of free gynecological hub, and wishing you all the best. Actually, dear doctors and professors, American Association are welcoming all of you in our 5th series of free online gynecological hub. And as you know, this our aim to create this hub in order to add value to your specialty and be a guide, one of your guide in your career. And I want from my here now I just want to thank our professors, Dr. Professor Abubakar Nashar, for accepting being the honorary president for this hub. And I want to thank all of you to attending this hub, and want to thank our professors, them whom do a lot of effort and allocate time to introduce this free hub with American Association. Thank you, Dr. Abubakar Nashar, for your all effort. And thank you, Dr. Hisham Arab, for the first time with American Association, and wishing be for long, inshallah. And thank you, Professor Tiago. Thanks, Professor Ik. And thanks, Professor Walid Basyouni. Thank you, Professor Ahmed Sulaiman. By the way, Dr. Ahmed Sulaiman, he's a nephrologist, and I think he will add great value for for his opinion, gynecological matter. Thanks, Professor Dr. Mohammed Sulaiman. Thanks, Dr. Rahab. She's my friend. Okay. Thanks, Dr. Haneen. She is Dr. Haneen Abd Jabbar. She is the daughter of our Professor Dr. Hassan Abd Jabbar. And thanks, Dr. Ibrahim Fauzi. He is our support in different forces in American Association. And wishing you all the best of luck. And we will start now our hub. And if there any question, anything related to the hub, related to the organization, we will be pleased to answer all these questions. Thank you. Good luck.
Thank you, Dr. Nagwan Al-Mohandes, the Chief Executive Officer of American Association. And now you will start know more about American Association with a short video about American Association, and we'll know more who is American Association, accreditation, cooperation, and finally we'll know the service of American Association.
Hello and welcome everyone. I'm Dr. Mariam Riz. I'm a medical coordinator and a trainer here in American Association. Today, I'll give you a brief introduction about American Association in addition to where our offices, accreditation, cooperation, and finally, I'll speak more about our services. So let's start. American Association is an international educational organization that is specialized and provides continuous medical education for all healthcare providers all over the world by providing them theoretical part 30% and hands-on 70%. Not only that, but also training, event, consultation for the physician. We consider the pioneer in international continuous medical education. We are working through our offices in USA in Delaware, in addition to UAE in Dubai, also here in Egypt in Cairo. Also, we will open our new offices in KSA and Jordan, Brazil. This is our certified registered document related to our offices in Delaware. So let's move to the most important part, accreditation. We took full accreditation from American Association of Continuing Medical Education that's located in San Francisco. In addition, we consider the regional office of American Association of Continuing Medical Education here in the MENA region, which include Middle East and North of Africa. Also, we took full accreditation from Accreditation Council for Continuing Medical Education that found in 1981, one of the most reputable accreditors that has high standard of continuous medical education, and we took this accreditation from them in that located in the USA in Chicago. In addition, accreditation from the Dubai Health Authority and National Quality Institute that certified that we are training center. Not only that, but also we took two accreditation, two ISOs, one ISO 9001 in quality management system and ISO 21001 in training and education. We consider 1 out of 5 organizations that took this ISO 21001 in training and education. So, to sum up all these points, we are working through strategy. We are not working haphazardly, as we have scientific program, and this scientific program is checked and reviewed from our scientific committees that located in the USA that make sure and guarantee that we are working through the latest update and the latest guideline. Finally, all these scientific programs are introduced by our certified professional trainer through the latest update in the latest guideline. All these points increase from our credibility. So, what's the American Association vision? We seek to be the nationally and internationally the leader of continuous medical education. Why American Association was created? American Association was created for healthcare professional continuous development. As in, you notice something, your development is our concern. We put this slogan under our logo. Your development is our concern. So here's some question about what is the continuous medical education, CME? It's the educational process to renew the clinical knowledge and the practical skills for healthcare professionals. Why? To support their community. As in 1991, WHO tried to define what is the standard of continuous medical education. Finally, it's found meets the local community needs. So here in American Association, we meet the local and the medical community need by providing them professional practical medical training in addition to the latest update in academic medical training. We finish now with American Association, where our offices, also our accreditation. Let's move to most important point, our cooperations. We made huge cooperation nationally and internationally. We made national cooperation with UNFPA, United Nations Population Fund, in addition to WHO, World Health Organization here in Egypt, and Egyptian Ministry of Health. Not only that, but also Saudi Society of Cosmetic Gynecology, Brazilian Academy of Cosmetic Gynecology, World Society of Cosmetic Gynecology, International Menopausal Society, Bahia Foundation, Iraq Medical Association, Jordan Medical Association. All these cooperation make us so credible, and this is some picture of our cooperations. Let's move to the last point here, our service. What does American Association offer for healthcare professional development? We are a leader in a different specialty like obstetric gynecology, dermatology, surgery, and internal medicine. But now I'll speak more about obstetric and gynecology. We offer aesthetic gynecology professional diploma. We trained more than 5,000 doctors, and this is some picture of graduate doctors. Also, we offer infertility and IVF professional diploma. We trained more than 1,700 doctors from all over the world, and this is some picture of graduated doctors. In addition to obstetric gynecology ultrasound professional diploma, we train more than 1,600 doctors. Obstetric gynecology placenta accreta spectrum professional diploma, we train more than 500 doctors. Family planning professional diploma, we train more than 400 doctors. Bleeding and pregnancy professional diploma, actually it's a new diploma that we offer here in American Association, so you can ask more about it for all medical representatives. So while you're waiting for ask about this diploma, bleeding and pregnancy, I'm sure it will be interest about this diploma. Let's move to another specialty, surgery. We made a lot of professional diploma like laparoscopy, colposcopy, hysteroscopy, and we trained more than 100 doctors in each diploma with one of the most reputable doctors and professors in the field. Finally, actually, here in American Association, we are not only offer diplomas, but also we offer something called conferences. We are the leader in aesthetic gynecology conference here in the Middle East. We train more than 5,000 doctors around the 4 years. Aesthetic gynecology is one of the most important science that sheds a light one of female intimate problem, like shape, function, and performance. Not only shape as anyone can expect when here aesthetic gynecology conference, no, but we are focusing more about function and performance. See some picture of our international conferences through the past 4 years. The journey started from 2020, the year of coronavirus. A lot of doctors come. We expect only 250, but actually there is a huge number from doctors that are so passionate for this field. So in the first year, attend more than 550 doctors. And gain 27 national and international speaker, 21 informative lecture, 21 workshop, 20 sponsored, and this is some picture of attendees, and this is some picture of a reputable scientific committee. In 2021, we made the second international conference of aesthetic gynecology, attended more than 800 doctors from all over the world, and this is some picture of huge attendees. Attend more than 51 national and international speakers, 51 informative lecture, 21 workshop, and 41 sponsor. And this scientific committee, actually we made something called re-release. What the mean of re-release? After finishing the conference, there's some doctors can't attend the conference, so we give them a golden chance and re-release aesthetic gynecology again in another time on Zoom. So anyone didn't attend the first time can attend the second time virtual on Zoom. Let's see what happened in 2020. Actually, after finishing the huge success of the 2021 Aesthetic Gynecology Conference, we made the third annual event in 2022, attend more than 1,000 doctors from all over the world, and actually gain more and advanced topics in the field of aesthetic gynecology. Also, we make something called electronic magazine. What the mean of that? Electronic magazine, it's soft copies that gather all topics in lecture that actually have discussed in the conference to can make all people available to have soft copy with all lecture to remember what happened in aesthetic gynecology and can read again about any information that get your interest in the conference. Also, in 2023, we made our fourth international conference of aesthetic gynecology. Actually, it was awesome conference that got over the world internationally. So let's see what happened in 2023. Aesthetic Gynecology Conference, Female Intimate and Pelvic Health Conference.
Welcome all, dear. This is Hathor, the goddess of infertility, beauty and happiness in ancient Egyptian, to have been chosen as a symbol for aesthetic gynecology. It gives me great pleasure and honor to be here with you today at the 4th Annual Aesthetic Gynecology Conference by American Association in Egypt's land. Welcome all professors and doctors from all over the world. We hope that the conference will be productive and different.
From the beginning of the history, women's health is widely debated.
Some think it's about facial or physical appearance, while others focus on intelligence.
However, American Association believes that a woman's overall health is vital for her beauty.
That's why the American Association merged health and beauty in the aesthetic gynecology field.
Since 2017, American Association has shaped the future of the aesthetic gynecology by raising awareness and empowering women.
And now, American Association are proud. Welcome you to the 4th AGC 2023.
The 4th Annual Event AGC 2023. Female Intimate and Pelvic Health.
And that's what happened in 2023. Actually, attended more than 55 legends from all over the world, 58 informative lectures, 60 sponsors, and 25 educational video demonstration. And this is some picture of attendees. And there's a huge Egyptian icon actually attended the conference in 2023. And this is some picture of them. Also, American Association sees the future of aesthetic gynecology, and there is homogeneous between the electronic robots and the international speakers from all over the world. Finally, we reach to the final part in our presentation, hubs. What the meaning of hubs? Actually, it's another service that American Association offers for all healthcare professionals around the world. It's online webinar, free online webinar on Zoom. We made here in American Association 8 hours or maybe less, maybe more, according to the hubs that you will attend, that gather international speakers from all over the world. Actually, we made a lot of hubs related to obstetric and gynecology field, like gynecological hub. We made the gynecological minimal access surgery hub that include laparoscopy, hysteroscopy, colposcopy, attended more than 2,500 viewers. And this is a picture of the online free webinar that on Zoom was the most reputable speaker. Actually, we made another hub called the Fetal Medicine Hub, attended more than 2,300 viewers. Infertility and the arts, IUI, IVF, and EXI attended more than 2,500 viewers. Incontinence Hub attended more than 2,100 viewers. And this is the best moment of American Association. This is some picture of graduate doctors and international speakers from all over the world. And this is a YouTube channel. If you press the live section here, you will find all hubs that should meet your interest for free, and you can also get your attendance certificate, so you will gain knowledge in addition to attendance certificate and the latest update and the latest guideline in your field for free. Just follow us in our American Association website, in addition to our social media platforms like Facebook, LinkedIn, and Instagram. There is all of this here for free from American Association. Don't forget, your development is our concern. I'm so happy to be here with you today. I'm Dr. Mariam Riz, medical coordinator and a trainer. See you soon in another professional diplomas.
Hello and welcome everyone. And now we will start our informative lecture with the first lecture with Dr. Haneen Abdul Jabbar. She is a consultant of obstetric gynecology, infertility and IVF, laparoscopic surgery, King Faisal Hospital, Jeddah, with one of the most informative lecture about renal disease in pregnancy from gynecological perspective. So let's start with Dr. Haneen.
So I'm Dr. Haneen Hassan Abdul Jabbar, consultant obstetrics and gynecology. My subspecialty is in reproductive endocrinology and infertility. Today I'll be talking with you and sharing some information about renal disease in pregnancy. So what we're going to talk about today is urinary tract infection, acute pyelonephritis, chronic renal disease, and pregnancy after renal transplant. So what happens usually in pregnancy? The kidneys usually increase in size, the GFR increases and the plasma flow increases. There is a decrease in the creatinine and the urea, and then there is a vesico-urethral reflux. Urinary tract infection, the most common cause is bacterial, and a lot of women get affected with UTIs during pregnancy. Usually, asymptomatic bacteriuria is the most common cause. Most common organism that causes urinary tract infection is E. coli. Asymptomatic bacteriuria is more common in African American and in multipara patients. 5 to 7% occur in pregnancy. The recurrence rate is about 30%, and 25% develop symptomatic infection. Usually the complications is to the pregnancy, so it can cause preterm labor, it can cause low birth weight, it can cause hypertension, anemia, and sometimes they may develop pyelonephritis if they're not treated correctly. The treatment usually is nitrofurantoin, 100 milligrams for 10 days. Usually it's once daily regimen. Single dose of amoxicillin 3 grams or ampicillin 2 grams, and that's given IV. If treatment fails and the patient still complains of symptoms, then we can give nitrofurantoin for 21 days. And usually we do give suppression nitrofurantoin at HS until the end of pregnancy if recurrence occur. Acute pyelonephritis affects about 4 in 100 patients. Usually the symptoms are fever, frequency, flank pain, chills, anorexia, and nausea. The most common cause of the pyelonephritis is E. coli, and it accounts for 70 to 80%. Klebsiella accounts for 3 to 5%, Enterobacter 3 to 5%, and then the group B streptococci that causes about 10% of the infections. Usually the complications that are related to pyelonephritis are renal dysfunction, ARDS, endotoxins that can cause hemolysis, and this can lead to anemia. Usually the treatment, the patient needs admission for hydration, acetaminophen to decrease or to control the fever. Usually we do blood cultures, urine culture, and we do check the renal function. Antibiotics to be started. Cause policy. When we say a renal impairment, usually we're looking at usually the complications. 15% will have impaired renal function, 50% worsening of proteinuria. That's why it's very important to check the protein urea prior to pregnancy, and it should be less than 1 gram. 12% will have hypertension and complications related to hypertension. This can cause preterm labor. It can cause IUFD, which is stillbirth, and it can cause IUGR, which is a small baby, and anemia secondary to hemolysis. Dialysis during pregnancy, usually 60% will have hemodialysis, 40% will do peritoneal dialysis. The risks of dialysis, it increases the pregnancy loss in pregnancy or late. So if it's early, it can cause miscarriage, and late, it can cause stillbirth. It does cause preterm labor and can cause placental abruption, which is an obstetrical emergency, and it can cause sepsis and infection. So what happens after renal transplant? Usually there is an increased risk of preterm labor, low birth weight, IUGR, preeclampsia, and pregnancy loss, whether it's early in the pregnancy or late in the pregnancy. Usually we do have to watch for signs of infection and diabetes, especially in the patients that are immunosuppressed. Usually after renal transplant, the patients will be on immunomodulators and prednisone, and that is immunosuppression. Rejection rate is usually 3%. Of course, when treating a patient with renal transplant, it has to be a multidisciplinary team approach. So you do have the obstetrician, you do have the nephrologist, you do have the nutritionist, and you do have the ID consultants on board with you, and the endocrine. So what do we do prior to pregnancy? Usually they have to have a stable disease for 2 years at least. Stable disease, meaning there's no signs of rejection, there's no signs of worsening of renal function or proteinuria anomalies. The creatinine should be less than 200 milligrams per deciliter, minimal proteinuria or none, and there's no evidence of rejection. So what do we do if this happens? Usually we treat the bacteriuria if recurrent and treat it until the end of pregnancy. Usually we do hepatic and renal profile. We do check the CBC, screen for cytomegalovirus and toxoplasmosis and TORCH infections. We do drug levels for cephalosporin, screen for diabetes. If the creatinine is high, then we do need to rule out rejection. We need to rule out nephrotoxicity from the drugs. We need to check for signs and symptoms of preeclampsia, and we do need to rule out pyelonephritis. Thank you. My talk was a very short talk about the renal disease in pregnancy. I will be more than happy to take any questions or if there's any comments on my presentation. Thank you so much.
Thank you, Dr. Haneen, for this informative lecture from renal disease from gynecological perspective. And now we will continue our series of informative lecture with our honorary president, Professor Abu Bakr Nashar. He will give us one of the most important topics about recurrent pregnancy loss and preterm labor. Professor Abu Bakr Nashar, Professor of Obstetric Gynecology, Faculty of Medicine, Banha University, and also he is the president of one of the Clinical Society of Obstetric and Gynecology, member of the Egyptian Board of Fertility and Sterility Society. I'll let you now with Professor, our beloved Professor Abu Bakr Nashar, to start our lecture.
Thanks a lot again. My voice is clear. Everything is clear. The My slides are clear. Mariam.
Doctor, yes, everything is clear. We can start now.
So we'll discuss recurrent pregnancy loss. What is new? And to know what is new, we should go to the recent guidelines of the Royal College in 2022 and the ISHRI guidelines in 2023. I have the honor to be one of the international reviewers of the ISHRI guidelines, and I will address the following. I will address 5 items. Number 1, what is the definition of recurrent pregnancy loss? What are the risk factors? How to investigate and how to treat? Let us start by the definition. The definition of the ISHRI and the Royal College are not the same. For the ISHRI, defines the pregnancy loss, we should have a serum or urine HCG positive. And we should include the chemical pregnancy. And we know what is meant by the chemical pregnancy. Chemical pregnancy, if we have the pregnancy test is positive, but there is no gestational sac. And not include the ectopic pregnancy and molar pregnancy. So to define the recurrent pregnancy loss, we should address what is meant by pregnancy loss, what is meant by recurrence, what is it consecutive or repeated or not, and what is the weeks of gestation. Regarding the Royal College defines the pregnancy loss, intrauterine pregnancy should be confirmed by ultrasound or histology. That's to say, they are not including the chemical pregnancy. And the recurrence. The definition of recurrence is different also. In ISHRI, after 2 is enough, while the Royal College 3. Regarding both, there is an agreement, consecutive or non-consecutive, and there is agreement regarding the weeks of gestation up to 24 weeks. The risk factors of recurrent pregnancy loss are 8. Number 1, epidemiological, anatomical, endocrine, thrombophilia. Immunological, infections, increased sperm DNA fragmentation, and genetic. And please, we will address them in the same sequence. Let us start discussing these risk factors. But before going to the risk factors, we should know the best classification of these causes. The best classification of these causes into possible and doubtful. Possible when there is a strong correlation between the cause and the miscarriage. But doubtful causes when there is a weak correlation between the cause and miscarriage. So the first risk factors, which is epidemiological factor, as we see here, age, advancing maternal age and advancing maternal age will increase the risk of miscarriage. And the lowest incidence between 20 and 35 and rapidly increase after the age of 40. The lifestyle factor, the excess caffeine, for the issue it is unclear, but for the Royal College, yes, excess caffeine will increase the risk of recurrent pregnancy loss, and it is not recommended to have more than 2 to 3 cups of coffee per day. The smoking, yes, it will increase, and the excess alcohol will increase the risk of recurrent pregnancy loss. Consanguinity. According to the Royal College, it is not, there is no increase in recurrent pregnancy loss if there is a consanguinity between the husband and the wife. The body mass index, if it is less than 20 or if it is more than 25, it has a negative effect. For the environmental and the chemical and exposure dietary intake, all of this, we have no enough studies for this. Stress, there is no evidence stress as a cause of recurrent pregnancy loss, but it may be an association. There is a difference between association and causation. The second risk factor, which is anatomical, and this can be classified into congenital and acquired. Congenital uterine malformation will increase the risk especially septate and bicornuate uterus. Acquired fibroid, polyp, adhesion. It is uncertain due to limitation of the studies and the methodological quality, but cervical incompetence is a strong cause for increased the recurrent pregnancy loss in the second trimester. What is new? The ISHRI in 2023 added adenomyosis as a cause of recurrent pregnancy loss, and we should exclude adenomyosis in every case of recurrent pregnancy loss. The third is endocrine factor, which account for 5% of cause of recurrent pregnancy loss. Uncontrolled diabetes mellitus, uncontrolled thyroid disease, uncontrolled, but controlled has no effect on the pregnancy loss. Subclinical hypothyroidism, thyroid autoantibodies, hyperprolactinemia, and polycystic ovary syndrome, all of these will increase the risk of recurrent pregnancy loss. For luteal phase defect, there is insufficient evidence to support its role in recurrent pregnancy loss. What is about vitamin D deficiency? According to the Royal College, yes, high prevalence of insufficiency or even deficiency is a cause of recurrent pregnancy loss, and this is what is mentioned in the Royal College. Vitamin D is a possible cause of recurrent pregnancy loss, and the treatment is vitamin D supplementation. Thrombophilia. We have two types of thrombophilia. We have acquired and we have inherited. And there is no doubt acquired thrombophilia, that's to say antiphospholipid syndrome, will increase the risk of recurrent pregnancy loss. But for the inherited, there is no increase. According to the ISHRI, there is no increase. But according to the Royal College, we have 3 types of thrombophilia. Factor 5, Leiden mutation. Factor 2, protein S. If we have a miscarriage in the second trimester, we should look for only these. But according to the ISHRI, there is no need to investigate for the inherited thrombophilia. And even if you find it, no need to treat it. We want to lay stress that hyperhemocystinemia, protein C deficiency, antithrombin 3, all of these are not a cause of recurrent pregnancy loss, and we should not look for it. The immunological, there is insufficient evidence to support it has no role in recurrent pregnancy loss. Infections, bacterial vaginosis, chronic endometritis, insufficient evidence to support its role. The increased sperm DNA fragmentation, yes, it will increase the risk of recurrent pregnancy loss. Regarding genetic constitute 25% of the causes, and we have the chromosomal abnormalities of the parents, which is found in 5% of the couples, and we have the embryonic chromosomal abnormalities, which is found in 50% of the couples. So now, what is the investigation to be done? Taking a history and the examination is important because it will tailor our investigation. And as we mentioned, we have 8 risk factors, and we will address every one. Let us start with addressing the epidemiologic factor. We should assess the lifestyle factor, smoking, alcohol, exercise, and the body weight. The second factor, which is anatomical, and it is recommended to do 3D ultrasonography. Any patient with recurrent pregnancy loss, the 3D ultrasonography is highly indicated because it has a high sensitivity and specificity, and it can differentiate between the septum and the bicornuate uterus. But if 3D ultrasonography is not available, what are we going to do? To do hysterosalpingiography? No. In this condition, the sonohysterography is recommended. Recently, the ISHRI recommended to do the ultrasonography to diagnose or to exclude adenomyosis. The third factor, which is endocrine, and it is recommended to do TSH and thyroid peroxidase antibodies. And if the TSH or the thyroid peroxidase antibodies are abnormal, it should be followed up by the T4 testing. It is not recommended to assess for polycystic syndrome. It is not recommended to do fasting insulin or fasting blood sugar. It is not recommended to ask for prolactin. It is not recommended to ask for ovarian reserve testing. It is not recommending to investigate for luteal phase insufficiency or androgen testing, or it is not recommended to ask for vitamin D determination or LH testing. All of these are not recommended according to the ISHRI guideline. The fourth, which is thrombophilia, the acquired one, which is antiphospholipid syndrome, yes, we should recommend and we should ask for diagnosis or to exclude antiphospholipid syndrome. And as we know, antiphospholipid syndrome is diagnosed, we should have one clinical criteria and one lab criteria. And the two positive tests at least 12 weeks apart for either lupus anticoagulant, anticardiolipin, or the anti-beta-2 glycoprotein 1 antibodies. ANA or the anti-nuclear antibodies could be considered because, as we know, we have two types of antiphospholipid syndrome. We have the primary and secondary antiphospholipid syndrome. What's about the inherited thrombophilia? There is a disagreement between the ISHRI and the Royal College. The ISHRI not recommending to determine the for the inherited thrombophilia because there is no or weak association between the recurrent pregnancy loss and the inherited thrombophilia. But according to the Royal College, if we have a second trimester miscarriage, we should ask for factor V Leiden mutation, factor 2, which is the prothrombin gene mutation, and the protein S deficiency. Homocysteine is not recommended according to the Royal College and according to the ISHRI guidelines. The fifth risk factor, which is the immunological screening. Only the anti-nuclear antibody testing could be considered only for explanation. And all of other immunological tests are not recommended. What's about infection? As we mentioned, there is a weak correlation, and that's why don't screen for infection as a cause of recurrent pregnancy loss. Assessment of sperm DNA fragmentation. It can be considered according to the ISHRI, but the Royal College not recommending to screen for the sperm DNA fragmentation because it's found that we have no effective treatment for increased sperm DNA fragmentation. The genetic, and this is the last one, we mentioned that we have 8 risk factors for recurrent pregnancy loss. The cytogenic analysis of the product of conception, according to the ISHRI, only to be considered after the third loss. And it is not routinely recommended, but it could be performed only for explanation. While, on the other hand, the Royal College recommended it should be performed. And for the parenteral peripheral blood karyotyping, again, the ISHRI recommending not to be done, while the Royal College, no, it should be performed. So this is regarding the definition, this is regarding the risk factors, regarding the investigation, what to do and what not to do, and what is the discrepancy between the Royal College and the ISHRI, what is the treatment. The Royal College in 2022 recommended a graded model of care and early individualized care. That's to say, if we have one miscarriage, we should give the patient information and we should give the patient support. After 2 miscarriage, just to do the initial investigation. And after 3 miscarriage, no, all the full series of evidence should be done. So the Royal College only investigates the patient for a full investigation after 3 miscarriage, not like the ISHRI, which recommending it to be done after 2 miscarriage. Again, as we mentioned, we have 8 risk factors, and we addressed it in investigation, and in the treatment, we will address it in the same sequence. That's to say, the epidemiological risk factor. We should advise lifestyle modification, but we have no randomized controlled studies. We ask them to stop smoking, minimize the caffeine, and less, it should be less than 200 milligram per day, and you minimize alcohol, less than 3 drinks per week, and to get the appropriate body mass index. This is the first factor, which is the epidemiological risk factor. What is about the second risk factor, which is the anatomical? Let us go to the congenital. Really, I am convinced, and I am recommending the guidelines of the Royal College. For the septum, it should be resection of the septum should be considered. This is the last recommendation of should be individualized. For the fibroid, for the endometrial polyp, for the intramural fibroid, according to the Royal College, it should be individualized. Just to say, we will assess the other factors for the with a fibroid. If the fibroid is symptomatizing or not, what is the size of the fibroid, what is the site of the fibroid, and so on. Regarding the cervical, incompetence, again, I am recommending the Royal College guidelines. We have 2 indications, either ultrasound indication or history indication. If we have a cervical length less than 2.5 centimeter with one or more second trimester or preterm labor, it is a valid indication for cervical circulation. But if we have 3 mid-trimester miscarriage and or preterm labor, whatever the length of the cervix, is a sound indication for cervical circulation. What is about the endocrinology? Of course, if there is overt hypothyroidism, we should treat it with thyroxine. And if we have euthyroxine, the patient is euthyroid, but the antibodies are positive, there is no indication to give eltroxin. There is no need to treat, and this we will discuss this in detail in the next lecture, inshallah. For the subclinical hypothyroidism, again, I am in agreement with the Royal College. If the thyroxine is, if the TSH is more than 4, we should give thyroxine. But below 4, there is no need to give thyroxine. Regarding if there is a deficiency or insufficiency of vitamin D supplementation is indicated. If there is hyperprolactinemia, we should give treatment, but other treatment not advised. If there is luteal phase insufficiency, if there is polycystic ovary syndrome, there is insufficient evidence to give metformin in the polycystic ovary syndrome to prevent recurrent pregnancy loss. If we have a thyroid peroxidase antibody positive and or subclinical hypothyroidism, it is recommended to follow up the patient during pregnancy, because this patient is in high risk to get hypothyroidism during pregnancy. What is about the thrombophilia? Of course, antiphospholipid syndrome should be treated, and the treatment is low dose aspirin plus heparin. And starting before conception, any antiphospholipid antibodies should take low dose aspirin for life. And the heparin should be started when the pregnancy test is positive, and there is no difference in efficacy between and the safety between the low molecular weight heparin and the unfractionated heparin, and we should start at the positive pregnancy test. What is about inherited thrombophilia? As we mentioned, there is a discrepancy between the Royal College and the ISHRI guidelines. If we are following the guidelines of the Royal College, if we have a second trimester pregnancy and any one of these are positive, the factor 5 Leiden mutation, the factor 2 gene mutation, the protein S deficiency, the treatment should be individualized, and in this condition, we can give heparin. Hyperhemocystinemia, there is no data or there is inconsistent data, but if it is present, the recommendation of the Royal College to be treated. How to be treated? By folic acid. Folic acid is the treatment of choice according to the Royal College. And this may be a high risk of thromboembolism, and that's why low molecular weight heparin and aspirin is indicated when the patient gets pregnant. Immunotherapy should not be advised at all. It doesn't improve the life birth rate, and all the methods of immunotherapy are not recommended. The intravenous immunoglobulin, the intralipid therapy, endometrial scratching, all of these are not recommended. What's about the increased sperm DNA fragmentation? As we mentioned, the Royal College don't recommend the detection of the sperm DNA fragmentation, but the ISHRI recommending it. If it is high, that's to say if it is more than 15, in this condition, we should look for the underlying etiology. Underlying etiology like the varicocele, like the genitourinary tract infection, lifestyle modification, stop smoking, stop alcohol, weight loss to get the appropriate body mass index, and the normal exercise pattern. Oral antioxidant for the treatment of increased sperm DNA fragmentation has not been shown to improve the chance of live birth. In the past, it was recommended to do Tisa-Exa, but nowadays it is not recommended. It is not recommended for Tisa-Exa in case of increased sperm DNA fragmentation, because there is no evidence also to support the selection by physiological Exa. According to the Royal College, don't treat the genetic factors, the abnormal parental karyotyping. We should refer for genetic test in this condition, and the pre-implantation genetic diagnosis IVF not recommended. What is the treatment of unexplained recurrent miscarriage or recurrent pregnancy loss? The unexplained recurrent pregnancy loss constitutes about 50% or even 70% of causes. We do all the basic investigation and we didn't find any cause. In this condition, we have no evidence-based treatment. And if we don't have any evidence-based treatment, we should start with the low risk, with the simple treatment, with the cheap treatment. And the only recommended are 3: lifestyle modification, tender love and care, and progesterone. And all of these are ineffective. Aspirin, heparin, combined therapy, HCG, HMG, immunotherapy. All of these are not recommended. Let us go to the guidelines of the Royal College supporting the use of vaginal progesterone to improve the live birth rate if we have 3 recurrent pregnancy loss and vaginal blood loss in the subsequent pregnancy. It is very important because in many cases we have unexplained recurrent pregnancy loss. And this is a very nice systematic review and the meta-analysis done in 25 randomized controlled trials, and it found that there is no significant difference in the live birth rate when we are using low molecular weight heparin of no value at all, the intravenous immunoglobulin, the leukocyte immune therapy, and the only treatment was progesterone. But there is a very important point in giving progesterone, we should start in the luteal phase, not after the occurrence of the pregnancy. Because according to this, if we start after the pregnancy, the progesterone has no effect. To come to the conclusion, investigation after 2 recurrent pregnancy loss according to the ESHRI, and after 3 recurrent pregnancy loss according to the Royal College. Number 1, 3D ultrasonography or sonohysterography of if the 3D ultrasonography is not available. TSH and thyroid peroxidase antibodies. Number 3, antiphospholipid antibodies. We can consider. What's the meaning of consider? We can do it or not. We can consider sperm DNA fragmentation testing according to the ESHRI, or if we have a second trimester miscarriage, we can consider factor V Leiden mutation, factor 2 prothrombin gene mutation, and the protein S after 3 repeated miscarriage. For investigation after 3 miscarriage, karyotyping according to the Royal College. For the treatment, if we have symptoms, submucous fibroid, severe intrauterine adhesion, hysteroscopic surgery, if there is cervical incompetence, cervical cerclage, if there is a subclinical hypothyroidism, L-tyroxine, when the TSH is more than 4, antiphospholipid syndrome should be treated with low-dose aspirin and heparin. Sperm DNA fragmentation according to the ESHRI to identify the cause and to treat it. Lifestyle modification, factor V Leiden, factor 2 gene mutation, and protein S after 3 miscarriage, heparin is indicated. If there is a karyotyping abnormalities, we should refer the patient to clinical gene test. I think this is the last slide. I would like to thank your listening, and if there is any questions, I am happy to answer it. I will go to the, yes, there is a lot of questions here, and one question is about the role of progesterone. We mentioned it. If we have 3 miscarriage, right? We can give progesterone, and we should start in the luteal phase and not after the end of after the start of the pregnancy. Another question about the role of Clexane. Yes, we mentioned the role of Clexane. Clexane is low molecular weight heparin, and it's only indicated if we have antiphospholipid syndrome. We should start when the pregnancy test is positive, but to give Clexane in unexplained recurrent pregnancy loss is not recommended. Another question about yes. Thank you, doctor. Thank you, prof. Thanks, American Association. Yes, about the role of steroid in treatment of recurrent pregnancy loss has no role. And we mentioned the immunological factors, no role of the immunological factors in causation of recurrent pregnancy loss. I think this is all the questions to be answered. If there is any, yes, one question here, if the patient has polycystic syndrome and early pregnancy loss, we mentioned that, yes, polycystic syndrome increases the risk of recurrent pregnancy loss. But in the past, metformin was given according to an observational study. But according to the randomized controlled study, metformin has no role in decreasing the rate of recurrent pregnancy loss. Yes, very nice questions. He mentioned how to explain the role of progesterone only in the luteal phase. Yes, because to start late, that's to say after occurrence of pregnancy, the mechanisms of progesterone will be less, and we should start in the luteal phase, not after occurrence of the pregnancy, because maybe what occur, it cannot be reversed. Another question, role of very nice question, Doctora. Role of torch in investigation of recurrent pregnancy. It has no role. By torch, the toxoplasmosis cause only single miscarriage and not repeated miscarriage. And after this single miscarriage, the patient will get immunity. Toxoplasmosis is like rubella, and to cause miscarriage, it should be primary, early infection in the current pregnancy. Any case of TSH4, we give thyroxine even not. Yes. بيسأل بالنسبة if we have TSH more than 4 to give التروxin. We will discuss this in the next lecture, inshallah. The role of methyl folate. There is no difference between methyl folate and folic acid, right? And this is the guidelines. Woman with arcuate uterus. Arcuate uterus is not a cause of recurrent pregnancy loss. And as we know, according to the new classification of the ISHRI, arcuate uterus has been removed from the classification. Hypothyroidism we'll discuss in detail. What is this? Can we get this lecture? Yes. Dr. الفقي. ايه تاني? What's else? Yes, we will get the lecture inshallah. Dr. Sarah Hassan Muhammad. After 3 miscarriage and we have no cause, we mentioned how to treat the unexplained recurrent pregnancy loss. We have 3. Number 1, in progesterone, lifestyle modification, and tender love and care, which is a psychological treatment. No, it is not unexplained infertility. There is no role of low molecular weight heparin. بيقول دكتورة إحسان ممكن ترشيح كتاب؟ حاضر، هنعمل كتاب إن شاء الله. أحد يكتب لي رد الدكتور أبو بكر على الطرش. الصوت راح مني. الدكتورة yes, there is no indication to investigate for toxoplasmosis or احنا عندنا الطرش التوكسوبلازموزيس كمان بسم الله الرحمن الرحيم المايكو السيتوميجالو فيروس. Don't screen for it, please. Don't screen for herpes, right? Prednisone is not effective in recurrent pregnancy loss. Thanks a lot, doctor. Arcuate uterus interfere with implantation or ovum? No. I think this is the end, and thanks a lot for your attention. And if you please, why progesterone has no role after we mentioned this? Yes. One question about the role of myoinositol. Myoinositol is still experimental, and there is no difference between myoinositol and metformin. What is else? I think all of this. Thank you, doctor. Thank you, prof. So I think we came to the end of this lecture, and I will meet you after the next lecture, inshallah. Mariam, Doctora Mariam, where are you?
Hello, doctor. Thank you, Dr. Abu Bakr. I'm here. Thank you, Dr. Abu Bakr, for this informative lecture. Actually, all of us get interested from your valuable comment and valuable insight. And now we will start our lecture with our beloved Professor Tiago Firas. Professor Tiago, consultant in obstetric and gynecology, Harvard Medical School, associate professor, faculty of medicine of University of Porto. Hello, Dr. Tiago. Actually, it's an honor to have you in Pregnancy-Related Complication Hub, and it's an honor to speak about one of the most important topics, preeclampsia and eclampsia in pregnancy. It's an honor for American Association to have Professor Atiego Firas for the first time here in Scientific Committee, and I let you with this informative lecture with Professor Tiago. Hello, Professor Tiago.
Hello, hello.
Can you hear me?
Yes, yes.
Mariam, would you?
Hello, Professor Abubakar. We can hear you.
Because I have a presentation after 1 hour. So please, if I can, the next speaker, I will be happy. If you
For
please.
sure, Doctor. Okay, great. There's no problem. After finishing Dr. Tiago, you can start.
Thank you.
Thank you. So, good afternoon. It's really a pleasure to be here and to be able to present such an important topic in our daily activity, such as preeclampsia and eclampsia. So, as it was mentioned earlier, I'm Tiago Ferraz. I'm from Portugal. I'm currently working at Al Salama Hospital in Jeddah. And our scope for today, so for this 20-minute lecture, we will be focusing on preeclampsia and eclampsia. And the idea is not only to go through the definitions, because we think you have been through it many times, but also to focus on the updates and how we manage and the struggles that we face on a daily basis with our patients. So the scope will be basically discussing how preeclampsia and eclampsia can be managed and what are the tools that we have at our disposal in the last 2 to 3 years, and some take-home messages for all of us to retain. So as we know, preeclampsia is one of the major leading causes of maternal and perinatal mortality, with a prevalence of about 4 to 5%, and 2% of them, they ended up as developing eclampsia seizures, so developing eclampsia. We know preeclampsia is associated with high risk of iatrogenic preterm delivery, fetal growth restriction, and it's one of the main causes of maternal mortality and morbidity. We know there are short-term complications in terms of neonate and fetal complications, and also long-term complications. So it's our role as obstetricians and focusing on this high-risk pregnancy situation to try to avoid some of these short-term or long-term complications. And sometimes most of them is just to balance the best time for delivery, because we know this is the only way of actually treating hypertensive disorders of pregnancy. So talking about definitions, and it changed somehow in the last 10 years. There are different definitions around the world. The one of the main, we all know it's a disease that has almost always hypertension and almost always proteinuria, but this is not always the case. So we can have preeclampsia without hypertension, we can have preeclampsia without proteinuria, but most of the times, and this is what I want you to keep in mind, we will have a patient with hypertension and proteinuria. The way we define hypertension is, as you all know, a systolic blood pressure of more than 140 and a systolic blood pressure of more than 90. Proteinuria, we all studied many years ago that we defined proteinuria in preeclamptic patients and eclamptic patients with a 24-hour urine sample. So now, and according to the recent NICE guidelines from UK, we don't need to wait 24 hours to have proteinuria or to define proteinuria in pregnancy, but a protein creatinine ratio of at least 0.3 milligrams per deciliter or 30 milligrams per millimole can actually do the job. So we will be faster in diagnosing patients with a suspected preeclampsia. So defining is basically hypertension with a new onset proteinuria after 20 weeks. We know that. But in some cases, we found out that there is a broad spectrum of symptoms and signs. Most of them, they are non-specific. So we can have hypertensive patients without proteinuria, but if we have one of these following criteria, we can actually make the diagnosis of preeclampsia. Of course, there are changes between the societies, and the NICE guidelines, they don't consider the uteroplacental dysfunction as one of the criteria to diagnose preeclampsia. But if we go to the International Federation, we actually still have the uteroplacental dysfunction, like fetal growth restriction, that can actually make the help make us the diagnosis. So it's not part of, in most of the societies, of the criteria to diagnose preeclampsia, but actually it's part of the spectrum. Regarding preeclampsia with severe fissure, we all know that the criteria, they stay the same, but we have a severe range hypertensive patient, so more than 160 or 110. And the other criteria, one of them, it can be proteinuria or thrombocytopenia, impaired liver function, so it's all there. So why we develop preeclampsia? So we know there's imbalance. This is the overall idea in the last 20-25 years. There's an imbalance between angiogenic and anti-angiogenic factors. Of course, not all patients, they are related the same way. So it depends on our genetics, environmental, how we react, how are our inflammatory agents. So it's actually quite interesting. But overall, it's the remodeling of the spiral arteries that will do the job. So this imbalance between angiogenic and anti-angiogenic factors will change the remodeling of the spiral arteries and will change the perfusion of the placenta and cause disease. When we have a patient that has a history of preeclampsia or even a primary gravida, one of our ideas is how we identify women that have higher risk of developing preeclampsia. So we want to find these 5% of patients, 4 to 5% of patients that will actually develop the disease. Of course, we can rely on risk factors such as previous history, family history, chronic hypertension, diabetes, obesity. But what happens if we have a patient that actually doesn't have any risk factor, but still might develop the disease? So we have some markers, and the ASPRE trial in 2017 and published in 2019 actually showed that early in pregnancy, in the first trimester, if we use some ultrasound markers and biochemical markers, and if we identify these high-risk patients and we can actually treat them with aspirin 100 to 150, we can actually reduce the risk of having preeclampsia. And this was confirmed last year in a big study, in a real clinical setup in Spain, where early in pregnancy, in the first trimester, using medical history and ultrasound and biochemical markers in the first trimester, the researchers, they were able to identify women at high risk, treat them with aspirin, and the result is we were able to reduce more than 50 to 60% the risk of developing preterm preeclampsia and early preeclampsia. So this is quite remarkable and came to confirm the results from the ASPRE trial 7 years ago. But if we don't have the tools, and not in all our hospitals, we might not have the ability to perform ultrasound to all the patients in the first trimester, or even to do the uterine artery Doppler flows, or to rely on biochemical markers such as PAP-A or placental growth factor. So we might need to rely only on the medical history of the patient. And this is also very important. NICE guidelines, they definitely propose that we should use the risk factors that are in this table, high risk factors or moderate risk factors, and to actually treat patients with aspirin, because this will actually reduce the risk of preeclampsia in the same way. Very interesting, last month in the New England Journal of Medicine, we have also a very interesting result. It's a 2 randomized trial, so the level of evidence is quite high for considering the supplementation of calcium, and only with 500 milligrams, as opposed to what the World Health Organization was proposing with more than 1,500, so 3 times more. But giving only 500 milligrams in patients with low intake of calcium actually reduces the risk of preeclampsia and preterm birth. So this is very important in our clinical practice, because this comes to confirm that by giving calcium, even in low doses, can actually reduce the risk of having preeclampsia. So what can we do when we have a patient with a suspected or even with a confirmed preeclampsia diagnosis? Definitely, in all setups, we should admit these patients to perform a full initial assessment. This is very important. It can take 6 hours, 8 hours, 12 hours, 24 hours. It depends on our hospitals. And severe range of hypertension, definitely these patients should be admitted in high dependence units. And we should all ask for help with the attending obstetrician or more senior physician to help better manage these situations. So what do we do to these patients when they come to our hospital or our clinics or our emergencies? We should run tests. After a thorough clinical examination to check for the gestational age, we should do blood tests like a CBC and some liver function, kidney function, coagulation studies, and we should do a protein creatinine urine ratio, because this will give us an idea of what we are dealing and what is the severity of what we are dealing. Also, we should have, if available in our hospitals, and some of the hospitals it's available, especially here in the Middle East, the ratio of angiogenic and anti-angiogenic. And I will talk later about what is the importance of this. We should have an admission CTG and an ultrasound scan for all of these patients to address the fetal well-being. Most important, and I always stress on this, is to document our plan for this patient and to share this decision and this plan with the family. One of the major updates that we have in the last 2 to 3 years is how to control blood pressure in these patients. Some of these patients, they have chronic hypertension. Some of these patients, they are newly diagnosed with hypertension because they are developing a gestational hypertension or a preeclampsia without severe features. So the overall and take-home message is we need to be aggressive in the blood pressure control. So we don't need and we should treat blood pressure only when we are in the severe range, whether we have a chronic hypertensive patient or a preeclampsia without severe features. So we should be aggressive, and especially in patients newly diagnosed. And our target is 135 to 85. And these are the latest information that we have. Which drugs we should use to control blood pressure? In this order: labetalol, nifedipine, and methyldopa are the best ways to control blood pressure in most of these patients. So when we have a patient with a suspected preeclampsia or preeclampsia without severe features, according to the EPITA trial almost 7 years ago, it's quite evident that we should induce labor if this patient is more than 37 weeks. There is a balance between prematurity, so we are not talking about prematurity anymore, but there is a balance of deteriorating the maternal condition. So if we have a patient with preeclampsia without severe features, we should induce labor if more than 37 weeks. And we should perform expectant management. This means that patients less than 37 weeks, we should hold our decision and we should balance between maternal and fetal outcomes. So patients with less than 34 weeks, we should definitely do expectant management in patients with preeclampsia without severe features, and the delivery should be only advised if there are other conditions like PROM, like premature rupture of membranes, fetal growth restriction, or oligohydramnios. And this decision should be based on obstetrical condition. If we have a patient between 34 and 36 and 6 days, then this decision should be also consider the family opinion, the availability of resources in our NICU, the availability of resources in our hospital, and depending on also on the maternal and fetal condition. The most cumbersome situation is when we find a patient with a preeclampsia without severe features and between 24 weeks and 33 weeks and 6 days. These are the most challenging cases because we know that, as we discussed before, we are talking about the spectrum of a disorder. So most patients with preeclampsia without severe features, if given enough time, they will develop preeclampsia with severe features or even end up in an eclampsia or a HELLP syndrome. So we need to identify whom among patients with preeclampsia without severe features will end up needing more resources. And this is where the ratio FLT1 PLGF is very important, because this ratio will allow us to predict the risk of progression of the disease within 2 weeks. And this will allow us to objectively focus on the most important resources for this patient, because if the patient has a ratio above 38 or 40, the chances of adverse maternal or neonatal outcomes are less than 3%. But if the patient has a ratio of more than 38, then the chances of adverse maternal outcomes are much higher. So the risk of progression for severe disease is much higher. So this is a very important tool to help us manage our decisions. So as I just mentioned before, it allows the identification of women at risk for imminent delivery. Also, we can use, and the NICE guidelines from last year, they are very clear about it. We should use along with the ratio, some prediction models that will allow us to further enhance our management. So if we have a full Pierce like this risk prediction model that we can use at any time during pregnancy, along with our biochemical data, this will allow us to focus on those patients that we are actually more worried about. So as a summary, this is very important. The ratio helps us to rule out preeclampsia, because if we suspect a patient of having preeclampsia, but the blood tests are not really accurate, or the blood pressure is on and off, by having a ratio of less than 38 actually rules out preeclampsia and the risk of developing within 1 week. But also, if the ratio is more than 38, it will allow us to rule in short-term risk of adverse outcomes. So we are including those patients that have actually higher risk of developing severe preeclampsia. So as a summary for preeclampsia without severe features, we should induce labor if more than 37 weeks. If less than 37 weeks, we should focus on expectant management. And if we can use the ratio or any other risk prediction model that is available online, like the full Pierce, we should focus on the expectant management. And the expectant management is using antenatal steroids for fetal lung maturation, magnesium sulfate for fetal neuroprotection, the fluid intake balance, blood pressure monitoring at least every 4 hours or every 6 hours, and some fetal well-being, blood ultrasound and a CTG. So when we discuss preeclampsia with severe features, the things change a little bit. So if we have a patient with severe hypertension range with any other of the criteria that it's mentioned here, that it's the same like for the diagnosis, then we should induce labor, and we should be more aggressive in the management. We should induce labor if a patient is more than 34 weeks, and the expectant management is an option, but only for up to 48 hours, to allow us for a cycle of steroids, for a cycle of magnesium sulfate for seizure prophylaxis or for fetal neuroprotection when less than 32 weeks, and to allow us for a blood pressure monitoring and control. Again, we should use risk prediction models. We should use the ratio, because this will allow us to identify women at higher risk of adverse outcomes. We should admit these patients in high dependent units to allow us for the measures that I mentioned before. But this delivery the delivery of these patients should be delivered deferred for 48 hours, and with less than 34 weeks, if a patient has a premature rupture of membrane, low platelet counts, a fetal growth restriction. So we should not defer more than 48 hours if we have this condition. How to treat the severe hypertension range in these patients? This is a very useful table that I use all the time from the American College. It's available in the American Journal of Obstetrics, and it's color coded, so it's very easy to implement and to have in our guidelines. It addresses how we should use labetalol, hydralazine, and nifedipine to control the severe range hypertension. Also, this is part of our standing orders here in our department, how we could use magnesium sulfate for seizures prophylaxis and even for fetal neuroprotection. I will not go. But I wanted to bring to all of you one workflow that I find very useful. It's available on UpToDate on the timing of delivery in women with preeclampsia. So this is not a risk prediction model, but actually it's quite helpful. So if we have a patient with a preeclampsia and the gestational age is more than 37, the guidelines are very clear. We should deliver this patient. We should not wait. But if the patient is not more than 37 weeks, but we have severe disease, then we need to know what is the gestational age. So if we have a severe disease and the patient is pre-viable, then we should discuss this with a couple, because the termination of pregnancy before 24 weeks, it's an option. If the patient is more than 34 weeks with severe disease, we should deliver also. But between 24 and 34, as we mentioned before, we need to address other risk factors. What are the benefits of inducing labor at 28, 29? Do we have availability of an ICU? Do we have availability of an ICU at 28, at 32, at 34? So it is our role as obstetricians to try to balance as much as possible the timing of delivery. In terms of eclampsia management, there's no major updates in the last year. We know it's a convulsive manifestation of preeclampsia. The key principles to manage eclampsia is to prevent and to do maternal support, to prevent maternal hypoxia, to treat hypertension, to allow for the termination of seizures, to prevent recurrent seizures, and to evaluate prompt delivery, because we know this is what will treat the condition. So expectant management in eclampsia is unreasonable. We should go for immediate therapy with magnesium sulfate, because this will allow us to reduce the time, the length of the seizure, and to prevent the recurrence in more than half of the cases. And we should know how to manage the pathological CTG, and we should consider if we go for induction of labor or cesarean delivery. It's important to know that eclampsia management doesn't mean cesarean section. And in the postpartum, most of these patients, they will get better. But in the first 2-3 days, because of the reabsorption of the third space fluid, we can have a degradation of the hypertension and some of the biochemical markers. So we should focus on this patient. Some of the take-home messages that I want to finalize this presentation are some of the updates that we have in the last 2-3 years. So please try to implement in your hospital a routine first trimester combined screening for preeclampsia. This will actually be very helpful, because you will be able to guide those that need to use aspirin to reduce the risk of preeclampsia in more than 50 to 60%. So by implementing a routine first trimester screening for preeclampsia will be quite beneficial, especially in setups where the prevalence of preeclampsia is higher. Also, try to implement the use of FLT1 PLGF ratio in your hospital, because this will allow you to better plan the delivery of patients with a suspected preeclampsia, or even to control how you can better plan this delivery. Also, be aggressive in the way you manage blood pressure in patients with chronic hypertension or in patients with preeclampsia. So be aggressive, try to control the blood pressure as much as possible. We know it will not reduce adverse outcomes, but it will reduce the chances of the patient having severe hypertension. And so it will reduce the chances of the patient developing stroke, for instance. And keep in mind always to use magnesium sulfate for fetal neuroprotection in patients less than 32 weeks. Another important information, be aware that this is a disease that has 5% of prevalence be aware of the risk factors, that treatment is to deliver the patient, and the timing of delivery is a balance between the gestational age and the severity of maternal and fetal condition. Be prepared as a team in your hospital, in your department, perform simulation drills for eclampsia seizures, have a toolbox kit available to manage preeclampsia with severe features and eclampsia, and make sure that you monitor the blood pressure for these patients for 72 hours in the postpartum. That's all. Thank you. This is a picture from my city, Porto, in Portugal. I was aware that you have some questions. I think I answered most of them. One of the questions was about the early prediction, how we can prevent preeclampsia from happening. So we know this. So this is another the slide that I showed before. So it's clear that performing a routine first trimester combined screening based on the medical history, on biochemical like PAP-A and placental growth factor and the uterine artery Doppler flow, and by giving aspirin to these patients, we are actually preventing them from developing preterm preeclampsia and early preeclampsia in more than 50 to 60%. Also, by using this table that is available in the NICE guidelines from UK from last year, if we don't have the means to use biochemical markers or uterine artery Doppler flowmetry, then just by relying on the medical history of the patient and giving them aspirin, we can actually reduce the risk of preeclampsia in high-risk patients. Also, calcium supplementation, as from last month in the New England Journal, it will also help us to reduce the risk of developing preeclampsia. But if we have a patient with preeclampsia, we want to know which patients will actually need more attention from our side, from our critical care unit. So make sure to try to use the ratio of FLT1 placenta and the PLGF, and use risk prediction models that are available online, like the full PEERS. It's based in Vancouver, Canada. And because this will actually help you to rule out and to rule in. There was another question about how to manage ascites with preeclampsia. It's a common finding. It's very important to know. It's a common finding. Most of us, I'm sure most of you, when you go and do a cesarean section in a patient with a preeclampsia, I'm sure all of you have seen some ascites or some transudate that you see in the peritoneal cavity. So it's quite a common fact. And there's the incidence in the studies, the studies are very old. There's no much, we don't have a lot of case reports. But there massive ascites in preeclampsia happen normally in the antenatal period. And there is no different pathogenesis for the ascites. Basically, we have an endothelial dysfunction with reduced intravascular oncotic pressure. So I would not recommend to manage differently patients with preeclampsia with or without ascites, as long as we exclude other causes of ascites like liver disease, portal hypertension, or cancer. So as long as we excluded these most common causes of ascites, then we should not manage it differently. Thank you. I don't know if there are any other questions.
Hello, Dr. Chego. Thank us for this amazing and informative lecture. There's some question in chat box. If you get it all, if anyone have any question for Dr. Chego, just write in the chat box, and Dr. Chego here with us, and it's a big chance and a big opportunity to know more about his knowledge. If you want anything.
So what I see, there is a question from to discuss about the use of magnesium citrate. There's no purpose to use magnesium citrate. The use is magnesium sulfate. So I know there's a lot of formulations, but what we should use is IV magnesium sulfate. using other pharmacological principles of magnesium will not be beneficial to reduce the risk of seizures in preeclampsia. Can we use methyl-dopa in preeclampsia? Yes, we can use. It's not recommended, but especially in patients, I would recommend to use labetalol and nifedipine. And if you use both of them, and then if you still have severe range of hypertension, then you can use hydralazine. But if the patient is already in methyl-dopa, I would not change it. But it's not a recommendation as a first line or even as a second line. So be aware of that. I would recommend to use first labetalol and then nifedipine. Yeah, I will make these slides available to everyone, so there's no worries about that. And the dose of magnesium sulfate, it's also in the slide. There's no differences in this dose, whether for seizure prophylaxis or for fetal neuroprotection when we are using them in patients less than 32 weeks. So normally we have a loading dose of 4 grams in 20 minutes, and then for the next 24 hours we use it normally 1 to 2 grams, and we should see how the reflexes, how the respiratory rate, and what is the magnesemia of this patient. So the dose is roughly the same as in all the guidelines. Thank you. I think you are mute. I think you are mute. I cannot listen.
Hello, sorry, I was muted. Yeah,
Yes.
I know that.
So the role of aspirin from the first day of pregnancy. I have a last
Can you hear me
question
now?
here. Yes. So there's a question about the role of aspirin from the first day of pregnancy. That's a good question. If I would prefer that we use any drug, any pharmaceutical formulation, if we have actually an indication. So unless this patient that who you are talking about, Dr. Nuzrin, is actually a high-risk patient already and you know her, yes, you can recommend her to start aspirin from the first day or as soon as she finds out that she's pregnant. But the most important thing is that once the patient visits us and attends our office, is to address the risk factors with the patient and give her the medication. The guidelines are quite clear, normally between 11 up to 16 weeks. But if you want to start before 11 weeks, especially if you know the history of the patient, then yes, you can start from the first day. I don't think there is any negative impact of using aspirin, even in the conception period. One of the most important things is that we don't need to stop aspirin at 36 weeks. The latest studies is we are stopping aspirin on the day of the delivery. So, and there is no higher risk of bleeding during the delivery, whether it is a vaginal or a cesarean section. So there's no need to be any more afraid than to use aspirin from 36 weeks on. Why the cases of preeclampsia and eclampsia decrease nowadays? Well, I think it depends. I don't know if the incidence is decreasing. Let's try to say that we are doing a good job. So I think the overall idea is that the use of aspirin is quite global now. It's quite spread. And as we saw in the studies, even in patients with moderate risk factors, So that are not really high risk patients, but even if they use aspirin, we are reducing slightly the risk of developing preeclampsia. So maybe that's one of the reasons why we may be subjectively thinking that the risk is reducing. But I think it depends on the country and the region, on the demography of the patient, on the prevalence of obesity and hypertension. So it's quite sparse. Can we use aspirin and enoxaparin? Yeah, we can use aspirin and enoxaparin, but not to treat or prevent preeclampsia. The use of aspirin and enoxaparin has very clear indication in patients with acquired thrombophilias or with hereditary thrombophilia. So it's not related specifically with preeclampsia. There's no role of low molecular weight heparin in the treatment or in reducing the risk of preeclampsia. So the studies, they say the body mass index, the higher the body mass index, the higher risk of hypertensive disorders of pregnancy. Of course, these are populational studies. When we have a patient in front of us, any patient can develop eclampsia seizures. So even lean patients in fit women, they can develop eclampsia. So, but there's no populational studies that address that the reduced BMI is linked with eclampsia. I think it's a case by case. Any other question? Thank you.
Thanks, Dr. Tiago, for this informative lecture. Actually, I'm speechless now, as there's no words can describe how much it was interactive. And actually, there is a lot of doctors appreciate you in chat box. It was an honor to have you in pregnancy-related complication hub. And now we will continue our informative lecture with Professor. Bye-bye, Dr. Tiago. With Professor Abu Bakr Nashar. He will switch with Dr. Walid, and he will give his lecture about thyroid dysfunction in pregnancy. Hello, Professor Abu Bakr Nashar. Do you hear me? If you hear me and everything is stable, just confirm with me.
Yes. Thanks, Dr. Mariam. Next lecture will be on hypothyroidism during pregnancy. Because the time allocated for me is only 20 minutes, we will go direct to this subject, and just to have a hint about the physiological changes during pregnancy. During pregnancy, there is a relative iodine deficiency, and this is attributed to the increase the maternal iodine requirements, and also due to the increase in the iodine excretion in urine. We will summarize the physiological changes in the thyroid function test. As we see here, there is no change in the TSH, the free T4, the total testosterone, the free T3, but there is an increase in the total T3, and there is increase in the total T4. This is the summary of the thyroid function test during normal pregnancy. And as we mentioned, and as we will know, the commonest cause of hypothyroidism during pregnancy is iodine deficiency. And that's why the Royal College recommended a daily dietary intake of iodine ranging from 200 to 150 microgram per day for the pregnant and also for the lactating woman, or even for the woman planning a pregnancy. And the source of iodine supplementation may be from our food, which is rich in iodide, or the daily oral 150 microgram iodine as potassium iodide. And the timing of iodine supplementation should start 3 months in advance of pregnancy or as soon as possible in pregnancy. It is very important to know the fetal thyroid function. The fetal thyroid function development doesn't begin until 12 weeks. During the first trimester, the fetus is depending on the maternal T4. And the maternal T4 crosses the placenta. And this exclusively before 12 weeks and partially after that. And as we know, the normal fetal neurologic development is very important. And the maternal hypothyroidism may be detrimental to the fetal development if not detected very early in gestation. We should detect it and we should start in the first trimester. The preconceptional optimization of T4 is important. So don't allow. One of the job of the preconceptional counseling or preconceptional clinic is to adjust, to optimize the T4 therapy before conception. The second question to be raised, to screen or not to screen for hypothyroidism. We should screen all patients or infertile patients. Please ask for TSH, especially if there is ovulatory disorder. It is mandatory to screen for TSH. Also, in the menstrual disorders, we should ask for TSH. Also, for repeated miscarriage. As we mentioned, it is mandatory not only to do the TSH, but also the thyroid peroxidase antibodies. Also, if the patient is suffering from type 1 diabetes. Also, if there is hyperprolactinemia. So we have 5 indications for screening of TSH: infertility, menstrual disorders, repeated miscarriage, type 1 diabetes, and hyperprolactinemia. What is about the pregnant lady? Are we going to screen for thyroid function? We have 2 types of screening. We have the routine or the universal or the mass screening. And we have the other type, which is selective screening. For routine or universal, it is not recommended to screen for the subclinical hypothyroidism, and also for thyroid autoantibodies, it is not recommended. But selective screening is recommended. Let us go to the American College in 2021. If there is a family or personal history of thyroid disease, we should screen. If there is type 1 diabetes, we should screen. Or if there is any suspicion of thyroid disease, we should screen. Or if there is a history of thyroid therapy, postpartum thyroiditis, autoimmune disorder. Recently, the Royal College in 2023 added, if there is a previous late pregnancy loss, even if it is 1, and also in cases of systemic lupus erythematosus, and added also if there is cardiac dysrhythmia. All of these we should screen for thyroid function. But the answer to be, it is indicated. So what we will ask, according to ASRAM, we should ask for TSH as a first line screening to assess the thyroid status in pregnancy. But according to the recent Royal College, we should screen for both simultaneously in the same time for TSH and for free T4. And this is algorithm of the American College of Obstetrician and Gynecologists in 2021 with TSH. And if the TSH is normal, it is euthyroid, but TSH, if it is abnormal, we should check for T4. So it is not simultaneously like the Royal College. And if the free T4 is below the normal, it is overt hypothyroidism. If the T4 is normal, it is subclinical hypothyroidism. The other point to be discussed, what incidence and the types of hypothyroidism. It is much more common in women than men. And it's common with a family history, and that's why it is recommended to screen if there is a family history of hypothyroidism. We have, what are the types? We have the overt hypothyroidism, and we have the subclinical hypothyroidism. The overt hypothyroidism treatment is required to prevent the serious damage to the fetus. While in the subclinical hypothyroidism, treatment may be indicated and may not. And we will discuss this in detail. And this is how to differentiate between the overt hypothyroidism or the clinical hypothyroidism, the subclinical hypothyroidism, and a rare condition called isolated hypothyroxinemia. How to differentiate? The TSH is elevated in overt, the free T4 is decreased, T3 is decreased, it is associated with adverse effect, and the treatment is recommended. The subclinical, only the TSH is elevated, while the T3 and the T4 are normal and may be associated with adverse effect. And that's why eltroxin is indicated if the thyroid peroxidase antibodies is positive. The isolated hypothyroxinemia, the only abnormality is decreased the free T4. And in this condition, no treatment is given. The pathogenesis and the causes of hypothyroidism, as I mentioned, iodine deficiency is the most common cause all over the world. احنا بنتكلم, we are talking about the world. And that's why the recommendation of iodine supplementation. The second cause is Hashimoto thyroiditis. It is also called chronic autoimmune thyroiditis, and it is the most common cause in developed countries. Hashimoto thyroiditis or chronic autoimmune thyroiditis is characterized by anti-thyroid antibodies, thyroid anti-microsomal antibodies, and anti-thyroglobulin antibodies. Both iodine deficiency and Hashimoto thyroiditis are associated with goiter. And there are two subtypes of Hashimoto thyroiditis. We have atrophic one, and we have the Hashimoto thyroiditis, which is a combination of autoimmune thyroiditis and goiter. We have what's called iatrogenic thyroiditis. I am the cause. The doctor is the cause of this, which occur after radiotherapy for Graves' disease, which occur after thyroidectomy, and which occur after drugs like the lithium, iodine, or antithyroid drugs. And another cause, it's called transient hypothyroidism. And we have two types of transient hypothyroidism, the subacute thyroiditis and the postpartum thyroiditis. And that's why we will follow our patient after delivery, and we will see how to follow up her. We should keep in mind the drugs that inhibit absorption of thyroid medication. Ferrous sulfate, sacravate, antacids. And we should keep in mind, we should not give these drugs within 4 hours of thyroid medication, because it will inhibit the absorption of thyroid medication. And that's why we should make a spacing between these drugs and the thyroid medication. What are the clinical picture? We have symptoms in the form of fatigue, weight gain, muscle cramp, hair loss, and we have signs: dry skin, carpal tunnel syndrome, bradycardia, periorbital edema, and all of this according to the severity of the condition. But looking for these features are common in normal pregnancy. In normal pregnancy, there is fatigue, there is constipation, there is weight gain, there is fluid retention, it may be physiological goiter during pregnancy, and even carpal tunnel syndrome. But in pregnancy, there is no dry skin, there is no bradycardia. On the other hand, there is tachycardia, and so on. What are the lab tests requested in this condition? For clinical hypothyroidism, we will find elevated TSH level, and according to the Royal College, the upper limit of normal range is 4 milli-unit per liter. Low levels of free T4 and low levels of free T3, and thyroid antibodies may be present or may not. It is only present in about 30% of population, and the presence of thyroid antibodies will confirm our diagnosis, but it is not essential for diagnosis. We will find elevated TSH and low levels of free T4 and free T3. What is the effect of pregnancy on hypothyroidism? And also we'll discuss what is the effect of hypothyroidism on pregnancy. Pregnancy will increase the thyroxine dose in about 1/4 of the woman, and this we should keep in mind. And we will see the recommendation: if there is a patient with hypothyroidism, we should increase the dose of L-tyroxine. The dose should be increased in early pregnancy, and this is due to inadequate replacement prior to pregnancy. It may be due to this, but most don't need to decrease their dose again postpartum. This, by following up, it was found that most don't need to decrease their dose again postpartum. Poor compliance. There is TSH with a normal free T4. This is what occurring during the pregnancy, or what is the effect of pregnancy on hypothyroidism. The other side of the coin, what is the effect of hypothyroidism on pregnancy? This explains the 3 types of hypothyroidism: the overt, the subclinical, and the isolated hypothyroxinemia. And this is the effect on the fetus, and this is the effect on the mother. The clinical hypothyroidism is associated with preterm delivery, low birth weight, and the miscarriage. And the maternal effect outcome: anemia, placental abruption, postpartum hemorrhage, and gestational hypertension, all are increased in, if untreated, condition of clinical hypothyroidism. For the subclinical hypothyroidism, prematurity, fetal and neonatal death, gestation diabetes, preeclampsia, premature rupture of the membrane. And for the rare type, which is isolated hypothyroxemia, low birth weight, psychological impairment, placental abruption, and adverse metabolic phenotype. We should keep in mind what's mentioned at the beginning of the lecture. The fetus is dependent on the maternal thyroid hormone until 12 weeks, until the autonomous fetal thyroid function. The fetal thyroid don't function before 12 weeks. And so this is the effect of hypothyroidism on pregnancy. We will continue. Even postpartum may occur maternal thyroid dysfunction and may occur hemorrhage in clinical hypothyroidism. And the medication, as we mentioned in the previous talk. Maternal and neonatal complication of hypothyroidism in pregnancy. This is the study found, yes, the difference between clinical and subclinical only in the prevalence, in the incidence of complication. The incidence of complication in clinical hypothyroidism is more prevalent than in subclinical hypothyroidism. And as I mentioned, the untreated overt hypothyroidism, this also affects the intellectual function, and it will reduce the intelligent quotient, and it will affect also the neurodevelopmental condition in the offspring. And severe maternal iodine deficiency will lead to permanent brain damage and neurological cretinism. And we know the manifestation of the cretinism, the deaf mutism, the spastic motor disorders, and hypothyroidism in the children. So this raises the importance of adequate replacement therapy and who are euthyroid at the beginning of pregnancy. And if there is adequate replacement therapy, the maternal and the fetal outcome is usually good and unaffected by hypothyroidism. But it should be effective, and it should be as early as possible as we can. Just a hint about what is meant by congenital hypothyroidism. Congenital hypothyroidism is due to severe iodine deficiency, and this will lead to neurologic impairment and mental retardation. If the condition is left untreated, congenital cretinism will occur. So the next, how to treat. Let us go, because there is no agreement between the different societies regarding the treatment. For the for the first condition, the clinical hypothyroidism, there is agreement, it should be treated. But for subclinical hypothyroidism, there is no agreement. And according to the American Thyroid Association, treatment is recommended if there is a positive thyroid peroxidase antibodies, and for the Endocrine Society, treatment is recommended for all cases of subclinical hypothyroidism. And for the European Thyroid Association, the recommendation of the treatment, the Eltroxin would appear to have a potential benefit which overweights the potential risk, and that's why it is recommended. For the isolated hypothyroxemia, as we mentioned, there is no recommendation for treatment. What's the treatment? The treatment is thyroxine. Is thyroxine safe during pregnancy? Yes, thyroxine is safe during pregnancy and lactation. Why? Because there is minimal or little thyroxine will cross the placenta. And the dose of thyroxine should be given as a single dose before breakfast. Let us see what we will, or what's the regimen of thyroxine therapy in the different conditions of hypothyroidism. Let us start by patients who were on thyroxine therapy before pregnancy. It is well known as a hypothyroidism, and now, and she is on L-thyroxine, and she came to me. In this condition, it is recommended to increase the dose by 1/3. In subclinical hypothyroidism, and I want to start the treatment is 1 microgram per kilogram per day, or to give 25 to 50 microgram per day. If we have a normal thyroid function, but only positive thyroid antibody, there is no recommendation to give thyroxine. If we have a new diagnosed hypothyroidism, I discovered the case for the first time, thyroxine should be started immediately. And provided there is no history of heart disease, it is very important to take the history and to exclude the patient is not a cardiac disease. The dose is 100 microgram, the starting dose. And if there is a history of cardiovascular disease, we should decrease the dose. What is the dose? The standard dose is 1.6 microgram per kilogram per day. And how to adjust the dose? Adjust the dose according to the TSH. And this table explains what are the increment, how to increase and when. If there is the TSH is below 2.5, there is no increment in the dosage. But if it is more than from 5 to 10, we should increase the dose by 50 and so on. Giving L-thyroxine, it should be monitored. And the monitoring by TSH, which should be every 4 weeks according to the American College. But again, the Royal College recommended to monitor the patient with TSH and also free T4. Once euthyroid state has been achieved, we should monitor the patient every trimester. And what are the objectives? We will give round the figure for the objective or for our goal. In the first trimester, around 2.5 milli international unit per liter. Second trimester, to be less than 3 milli international per liter. For the third trimester, less than 3.5 milli international unit per liter, according to the American Association of Clinical Endocrine. So, first trimester below 2.5, second trimester below 3, third trimester below 3.5. The postpartum follow-up is important. And according to the Royal College guidelines, the recent one, the patient returned to the preconceptional dose 2 weeks. I increase the dose during pregnancy. And I will continue with the same dose for 2 weeks. And after that, I will return to the preconceptional dose. In a woman not taking thyroxine preconceptional, she was not taking. Stop the L-thyroxine after delivery. And thyroid function should be determined 6 weeks postpartum. Women with autoimmune thyroid disease, are at a high risk to develop postpartum thyroiditis. And that's why we should continue monitoring of the thyroid function for at least 6 months. 6 months, not 6 weeks. So with women with autoimmune thyroid disease, we should monitor the patient for at least 6 months after delivery because she is a high risk for developing postpartum thyroiditis. Just a hint about neonatal or fetal hypothyroidism. It is very rare. Hypothyroidism. It is due to the transplacental passage of the TSH receptor blocking antibodies. And only it accounts for 2% of the cases of congenital hypothyroidism. These antibodies are more common in women with atrophic rather than the Hashimoto thyroiditis. And the diagnosis may be suspected in the presence of fetal goiter. Thanks to the Egyptian government, all the units in Egypt have their TSH measurement by the HEAL-BIC neonatal screening test. To come to the conclusion, the incidence of hypothyroidism is much more common in women than in men, and common in those with a family history of hypothyroidism. Iodine deficiency is the most common cause all over the world, but in developed world, the Hashimoto is the commonest cause. Many features are common in normal pregnancy. The features of hypothyroidism is similar to the features of normal pregnancy. Subclinical hypothyroidism, the patient is asymptomatic. She is not complaining of symptoms, but TSH is elevated while T4 and T3 are normal. During a pregnancy will increase the dose of thyroxine in 1/4 of women. Untreated hypothyroidism is associated with an increased risk of miscarriage and fetal loss. Treatment with thyroxine in subclinical hypothyroidism may be considered, especially if there is thyroid antibodies. I think this is the last. Thanks a lot. If there is any questions, I am happy to answer. Yes, Dr. Mariam, where are you? We will see if there is any questions or not.
Hello, Dr. Abubakr. Everything is clear, I think, and thanks for this amazing lecture. It has very new knowledge and latest updates. And actually, thank you for this informative lecture. And if anyone has any question, just send in the chat box and take the chance that Professor Abubakr with us now. If there's not, just tell us also. There's a lot of appreciation, Doctor, here in the chat box. A lot of people thank you for this amazing lecture.
Yes,
all participants, thank you.
Information, very nice, but there is no questions at all. So everything was clear. Thanks a lot. Thanks a lot, Dr. Mariam. Thanks, American Association for Continuous Medical Education, and I'm happy to share in any activities in the future, inshallah. Bye-bye. مع السلامة.
Bye-bye. Salam, Dr. Abubakr. Thanks for this participation. And now we will continue our series of information with Professor Walid. Professor Walid Bassiouni, Professor of Obstetric Gynecology, Ain Shams University, high-risk pregnancy and gynecological consultant. And now he will discuss with us. Hello. And now he will discuss with us one of the most important topics about placenta accreta.
Dr. Mariam, I want to welcome Dr. Hisham Arab. He just joined.
Doctor. The mic with you.
Yes, please, Dr. Hisham. I think you muted him. Would you please?
الله
Dr.
يخليك
Hisham,
دكتور أبو بكر.
welcome Dr. Hisham Arab. It is
العفو.
nice to see you. How are you, Dr. Hisham?
I'm doing very well. I'm doing very well. Thank you very much
Yes.
for
My
talking.
regards to all of my friends in Saudi Arabia.
Sure, I will.
We are happy to meet together, inshallah.
Inshallah, we're expecting you in May. Inshallah, you are most welcome. Join us. Inshallah, ala khair. Beautiful, beautiful talk. Thank you.
Thank you.
Hello, and now we will start our presentation with Professor Walid Bassiouni, and after finishing this informative lecture, we will have an interesting topic, gestational diabetes, with Professor Hisham Arab. And now I want to welcome Professor Walid. How are you, Dr. Walid? Do you hear me well?
Yes, thank you very much. Thank you, Dr. Mariam. It's really a pleasure.
Okay, Doctor, the stage with you now.
Thank you very much. In order to cut it short, I know we're late a bit, so it's always a pleasure to be with you in this lecture. We're going to speak today about a very important topic, which is placenta accreta and the severe rise of this condition worldwide, not just in Egypt. Of course, in Egypt and in some of our Arab countries where the number of the cesarean sections are increasing markedly over the past years, the rate of cesarean section directly increases the number of cases of placenta accreta, and hence now we see much of the cases that usually in the past, let's say 20 years, were not with this number. So with the rise of the cases, the management has been changeable over the past 10 years. In the start, we used to do radical surgery, which is hysterectomy. And when the number of the cases increased, we had to tailor our management according to the increasing number of cases. And so we have cases where young ages with para 1 cesarean section or para 2 cesarean section, she's less than 30 years, and hence doing a hysterectomy will be a difficult decision for the lady as regards her fertility and as regards her femininity. And since then, we started adopting a conservative management of the condition, which is placenta accreta spectrum. So this is actually one of the sights we don't like to see. When we see a massive blood loss, this patient was a case of placenta accreta, which had a hysterectomy done. She lost more than 10 liters of her blood. These are more than 120 towels soaked with blood. This patient received 15 units of packed RBCs, 10 units of fresh frozen plasma, and thank God she survived the condition without major problems. And this is one of the worst scenarios in this condition. But of course, the patient was alive, and this gives us hope that the better management of these cases will decrease this sight later on. So actually now the placenta accreta is the bête noire of obstetrics. What do we mean by bête noire? Bête noire is the black beast. Previously, the black beast of obstetrics was the occipito-posterior position when we previously had a higher rate of vaginal deliveries. But now, with the increase of cesarean section, placenta accreta now is the black beast of obstetrics. Every obstetrician should have the skills and should have the knowledge to properly diagnose the condition. I don't say to operate upon it, but at least to properly diagnose it in order to be capable of referring to a properly equipped place to operate upon this condition. The current prevailing hypothesis is that it's a defect in the endometrium-myometrial interface. This causes the occurrence of placenta accreta spectrum, typically at the site of a prior hysterotomy or a cesarean section, leading to a failure of normal desidualization in the corresponding uterine area. This allows extravellus trophoblastic infiltration and vellus tissue to develop deeply within the myometrium, including its circulation and to sometimes reaching the surrounding pelvic organs. And this is very important to discriminate between placenta accreta spectrum and malignancy. So placenta accreta spectrum is not malignancy, and hence the condition could be properly managed if you could control the bleeding from the site of the placenta. If the bleeding from the site of the placenta is more than you could control, hence this condition needs proper management in a form of a radical surgery. But if you could control the condition, hence you could do a conservative management of this surgery. So what is the role of research in improving the outcomes? We need better diagnosis. This is very important. We need better surgical outcomes, and we need to primarily prevent the condition by detecting the patients who are susceptible for this condition. So, is placenta accreta a new condition? Actually, no. This paper is from 1931. It was describing a case where he found a case report where this author, D.S. Forster, had a cesarean section done, and he found the case as a case of placenta accreta, and he was saying that this was the first case he sees from this condition. And of course, from the 30s, 1930s till now, over the last 100 years, as we said, the number increased markedly, specifically over the last decade or 20 years, where the cases increased because of the increase in the rate of cesarean section. So the rate of cesarean section is increasing worldwide, while the mean cesarean delivery rate in developed countries is nearly 21%. A World Health Organization survey of more than 120 facilities in 9 Asian countries reported an overrate rate to be around 28%. Actually, in Egypt, the rate is up to 70% and maybe a bit higher. In other countries, it may reach up to 55 or 55 or 60%. So the higher the rate of cesarean section, the more the cases we're going to see from this condition. What about our hospital and Shams University in Cairo, Egypt? We have around 14,000 deliveries per year with a cesarean section rate reaching nearly 60%. And we see around 600 or 700 cases of placenta accreta spectrum per year, which represents around 8% of the cesarean sections per year. So although the impact of placenta accreta of pregnancy outcomes is well described, still there is no randomized trials and very few studies that have examined the management of pregnancies complicated by this disorder. And this actually is accepted because in order to do a proper randomizing and proper trial according to randomization, this needs to be a bit blinded about the results, and this will not be ethical in order to do a procedure that may be life-threatening or cause a mortality or a major morbidity for the patient. And hence, most of the studies upon this condition are just case studies and our cohort studies, and still there is no extensive randomization in order to get the evidence that could back up our management in this condition. So when we're speaking about conservation, what are we speaking about? Are we speaking about conservation of the uterus, or are we speaking about conservation of the fertility, conservation of the baby, or conservation of the life of the patient? So this must be very clear in your mind when you're going to do this procedure. When you're just speaking about conservation of the uterus, this could lead to massive blood loss, and at the end this patient may suffer from severe atonic postpartum hemorrhage, and hence you're going to lose both your uterus and the patient. So what about the fertility? You could leave the uterus, but this uterus could be not functioning later on if you remove a big part of the uterus, or if you do a bilateral tubal ligation later on. So you're not conserving the fertility. What about the baby? And hence the timing of the procedure and the time until you do the cesarean section is very important, from the skin incision to the delivery of the fetus, because sometimes you're going to take more than 30 minutes or 40 minutes in order to reach to the fetus prior to delivery of the fetus in order to properly do hemostasis. Or, and this is the main target, is conserving the life of the patient, and this necessitates that you do the procedure that you know how to do better. So again, as we said, placental advancement is a physical factor secondary to rupture of the myometrium. If on the other hand, this fact depended on an invasive characteristic of the placenta, we'd be able to see a similar percentage of invasions on all sides of the uterus, a phenomenon which has not been observed to date. So again, the placenta accreta spectrum is not a malignancy, and hence the radical or the hysterectomy is not the only method to do the procedure. You're going to do this radical surgery if you could not control the bleeding, but it's not a malignancy. It's a physical fact secondary to rupture of the myometrium. Okay, so all the evidence seems to indicate that if the placental implantation is adequately supplied with blood, the placenta only advances through the myometrial defect, and it does not invade beyond the myometrium and reach to the serosa or the nearby organs. On the contrary, if the placenta does not obtain an adequate vascular supply, the intense release of vascular endothelial growth factors promotes the thickening of the vascular microanastomosis, which is called the new vascularization. And hence, if there is a big defect in the uterus and the placenta needs to reach to a sufficient amount of blood supply to maintain the growth of the placenta throughout the pregnancy, you're going to find that there is a new vascularization that's going to be crossing between the bladder and the uterus. And this new vascularized vessels, which does not have a normal structure, which does not have a normal anatomy, will lead to the excessive blood loss during the cesarean section. Okay? So we need a multidisciplinary team, and this is the most important thing. The main cause of morbidity and mortality is operating upon these patients while you do not have the sufficient skill and the sufficient requirements and blood banking and equipments that could help you during your procedure. So the better the outcome is with the more experienced and more skilled hands that have operated upon this patient, not just 1 or 2 or 3 cases per year, let's say 1 or 2 or 3 cases per week. So the more the cases you see, the more the skills you're going to have in order to be capable of managing this patient. So a multidisciplinary team and delivery in a tertiary care facility improves outcomes and lowers complication rates. So how are you going to diagnose it? Well, actually, the ultrasound is more than enough in order to diagnose this condition. The MRI may be helpful in difficult cases where you could not identify the lower edge of the placenta, specifically if it's a placenta posterior, but the ultrasound is more than enough in diagnosing these conditions with the various forms. Number one, that the placenta is low-lying, reaching to the cervix. The second is the presence of the bridging vessels between the bladder and the placenta, the presence of the lacunae, the loss of the interface between the uterus and the bladder. All of these are criteria that could help you in the diagnosing of placenta accreta spectrum. Of course, the ultrasound criteria have a false positive and false negative in the management or in the diagnosis of this condition, and hence the intraoperative findings are much more important in the method of management of this condition. So the ultrasound, we're going to give you a hint, we're going to give you heads up in order to tell you that this patient has a critical condition, and then intraoperatively, you're going to find if the placenta is actually invading, if the placenta is actually inseparable, if the new vascularization is severe, that the management should be tailored according to each case and according to each condition, according to the findings intraoperative. So what are the methods that we could use to help us in controlling the bleeding? What about interventional radiology? This is very important because the balloon catheterization and arterial embolization was studied in several cases in order to decrease the blood supply of the uterus and the placenta immediately prior to performing the cesarean section. Of course, this needs equipment, needs specialized hospitals, needs hybrid operation theaters in order to have an interventional radiology together with the obstetrician. And unfortunately, the success rate of it in decreasing the blood during the cesarean section is not high because there is a shifting of the blood between the internal iliac and the external iliac anastomosis, and hence the new vascularized vessels may be more engorged with blood when you just simply close the internal iliac artery, the anterior division of it. So actually the internal iliac artery ligation, whether in surgery or the balloon catheterization, was not that helpful in management of these cases, and I'm going to show you some recommendations about this condition later on. This is a team of the interventional radiology in Ain Shams University Hospital. When we had this case that operated upon, they put a balloon catheter inside the internal iliac artery and inflated immediately before the surgery, and then we did the surgery later on. This is a very important paper that puts a very critical role for the medical legal aspects of this condition. It says that all maternal death related to placenta accreta spectrum are preventable. And this is very important. So if you operate upon a case and the patient dies with you, you're going to be asked why did you not take the critical measures in order to improve the outcomes and decrease the possibility of the death of the patient. So if it's not a multidisciplinary team, if you're not in a tertiary hospital, if you did not prepare the proper blood, you're going to be asked medical legally about this condition. And the conclusion of the paper is all maternal death related to placenta accreta spectrum were potentially preventable, and nearly 80% of cases were avoidable by low to moderate complex key interventions. This is very important because the medical legal aspect is very important in this condition. So what about the conservative management? This is the PACRETA Perspective study, one of the studies that was done on the conservative management of placenta accreta, and they actually said that the conservation was successful in decreasing the blood transfusion and the blood loss of the patient. But again, this is with expert hands. This is with people who have worked on this cases for a long time, and it's not the routine. So I could not say for someone who just solved this case once or twice, go do conservation, because if he did so, this patient's going to lose so much blood, and this patient's going to suffer from a major morbidity and even mortality. So what about a specific method of management if you try to leave the placenta inside, and comparison of results following the treatment of placenta accreta with high intensity focused ultrasound followed by hysteroscopic resection. So you're going to leave the placenta inside after the surgery, you're going to do a high focus ultrasound, and then you're going to try to remove the placenta with the hysteroscopic resection. Well, it was successful in some cases, but unfortunately the rate of secondary postpartum hemorrhage and infection was a bit high. So this may be also life saving if you try to leave the placenta in place at the time of cesarean section, but later on you have to do the proper management. So is the short inter-pregnancy interval a cause of placenta accreta spectrum? Well, actually no, because if the duration of the pregnancy after the previous cesarean section is more than 6 months, this does not correlate between the placenta accreta spectrum and occurrence of placenta accreta spectrum and the interval of the interpregnancy. So in patients at risk of placenta accreta spectrum, short pregnancy interval of less than 16 months and even 12 months were not associated with placenta accreta spectrum, even when controlling for number of previous cesarean deliveries and previa. So the short interpregnancy interval was not a cause of placenta accreta. So what about if you're in a severe case where the patient's bleeding and you do not have any of the skills and any of the requirements or the blood available, and you operate on this patient on an emergency base? This was management of a placenta accreta spectrum in low resource setting using a novel dissection-free aorta clamp. Simply, he clamped the aorta. So he closed the aorta with a specific clamp, which decreased the blood going to the area as the method of emergency management until he could do whatever, the hysterectomy or the procedure, in order for the patient not to lose too much blood. And this was done in India, and it was just also a life-saving, but the patients came out with major morbidity in these conditions. Multidisciplinary teams, again, is the main line of action in the management of placenta accreta spectrum disorders. So if you do not have a multidisciplinary team, you should form one. You should have a team that is within a traveling distance for the patient in order to be capable of doing the procedure for the patient with the best skills. So what are the criteria for this center? There must be a universal access to this team. There must be a standard care of plan. There must be radiological expertise to be capable of diagnosing these patients, experienced obstetrician and maternal fetal medicine specialist, surgical expertise for complex surgeries as gynecologic oncology, pelvic surgeon and urogynecologist, anesthesiologist, neonatal intensive care unit and neonatologist, adult intensive care units, massive transfusion capacity, additional surgical expertise, and interventional radiology. Well, actually, not all of them should be available, but at least a major part of them should be available for the condition. This is just a small reminder of the levels of evidence you should have, the systematic reviews. This is the highest level of evidence, followed by randomized controlled trials, then cohort studies, then case control studies, then case series and case reports, and finally the lowest grade of evidence is the editorial and the expert opinion. This is the evidence as regards the management of placenta accreta from various bodies, where the ultrasonography should be the first line for the diagnosis of placenta accreta spectrum from the FIGO, the RCOG, and the International Society of Placenta Accreta spectrum. At the mid-trimester examination for fetal anomaly, all women should be assessed for placenta previa and or accreta, specifically if she's a previous cesarean section. So again, no cases should be missed. If this patient is doing an ultrasound at 22 to 28 weeks, she should be flagged for either a total placenta previa or a low-lying placenta, and she needs to be reassessed again at 32 weeks. So again, you should properly diagnose this condition. The ultrasound signs observed for the diagnosis of placenta accreta spectrum should be described using some standardized protocols. And there's our checklists now for this condition in order to be capable of diagnosing the condition with the criteria that are present, whether the plaquenil, the presence of loss of the interface between the bladder and the placenta, the presence of crossing bridging blood vessels between them. The ultrasound signs observed should be very clear and put in a checklist and standardized. The care plan should include access to blood products, capacity to perform complex pelvic surgery, and intensive care facilities. MRI is not essential for making a prenatal diagnosis of suspected past disorders, but may be useful in evaluating the pelvic extension in areas difficult to be assessed by the ultrasound, specifically the placenta posterior. The scheduled non-emergent delivery is advisable for women with past disorders as it's associated with a reduction in complication related to blood loss between 34 to 37 weeks. And according to the NICU availability, I advise that we operate upon these patients between 36 and 37 weeks in order to decrease the possibility of admission of these babies to the NICU. A midline skin incision should be considered, but it's not a must. If you could do it through a phanestoid skin incision, this could be also present, but you could do the midline skin incision specifically if it's in your first cases and you're still training upon the procedure and you want a better exposure, so it's better to do it via midline skin incision. You should give tranexamic acid, and this is a standardized protocol now. The role of bilateral internal iliac artery ligation at the time of cesarean hysterectomy is currently evident, and hence the role of internal iliac artery ligation is not a power role. In the absence of spontaneous placental separation, the placenta should be left in situ to minimize the blood loss. And this is related also to the skills and the expertise of the operating surgeon, because if you could not remove it completely and if you could not do a proper hysterectomy, then just do not try to separate the placenta, because if you try to separate the placenta, this patient is going to lose too much blood. So you could leave the placenta in situ and then we're going to manage it later on, whatever the type of management. Total hysterectomy with placenta in situ is preferred over subtotal hysterectomy in cases of placenta previa increta or precreta. Leaving the placenta in situ is an option for women who desire to preserve their fertility and agree to continuous long-term monitoring in centers with adequate expertise, of course with the risk of infection and the risk of bleeding. The expletive approach of forcible manual removal of the placenta should be abandoned, and this is highly recommended with all the bodies. Trial to remove the placenta forcibly will lead to a severe blood loss. The use of methotrexate is not recommended until further evidence is available on its efficacy and safety. Preventive surgical or radiological uterine devascularization is not recommended now routinely. There is insufficient evidence to recommend the use of MRI or measuring serum beta-HCG in the follow-up of these patients. So the evidence is not strong enough to recommend routine placement of ureteric stents for all suspected cases of placenta accreta spectrum. And the ureteric stent, well, it may be helpful in some cases, specifically if there may be a excessive blood collaboration between the bladder and the placenta, and hence there may be an injury of the bladder to try to dissect it from the placenta, but it was not sufficient or beneficial in most of the cases. The benefits from the ureteric stent is properly limited to case of precreta with significant invasion. When the extent of the placenta excreta is limited in depth and surface area, uterus-preserving surgery may be appropriate, including partial myometrial resection, and this is the conservative approach, which may be helpful in selected cases in expert hands. Okay. At the time of an elective repeat cesarean section, where both the mother and the baby are stable, it's immediately apparent that placenta praecarita is present and you did not diagnose it properly. You may reclose the patient and transfer it to a tertiary hospital for proper management. So if accidentally you discovered a case of praecarita during your procedure and you did not diagnose it priorly, you may reclose the patient and transfer to a tertiary hospital, which has a low grade of evidence in the RCOG and the International Society of Placenta Accreta Spectrum, but this may be life-saving. This is a map of Egypt in which you have to have at least from 15 to 20 multidisciplinary teams covering all the governments of Egypt, because as I told you, she has to be within a traveling distance to this hospital or to this place. So we have one in Aswan, we have one in Ina, we have one in Minya, we have one in Asyut, we have several multidisciplinary teams in Cairo and in Alexandria and Matruh and in Delta. So this is very important that you have sufficient teams that are capable of management of this condition with the proper skills and proper expertise and the proper equipments. So what about the management of unexpected placenta accreta spectrum in resource poor settings? This is very important because it's very important to properly diagnose the condition priorly. So what if you accidentally discovered it? Actually, the recommendation is if even it's an accidental discovery, you could, as I said, close the patient if you did not separate the placenta and it's not an emergency, or you could be using a video-aided surgeon who has an expertise in this condition, who could help you in taking the decision if you are hesitant about it. So this study was done where they used a video conference in order to help them to take the decision whether to operate on the patient and the method of the operation, whether to do a hysterectomy or a conservative management. Of course, this is not a typical procedure, but this is also a life-saving procedure. So a definitive decision regarding the conservative management or cesarean hysterectomy should be made preoperatively. It should not be left to the decision intraoperative, except if there is a major change in the decision you take intraoperatively. What do we do with the delivery of the hysterectomy? As we said, you could do a phanestoid skin incision or a vertical skin incision, and then you're going to try to deliver the fetus and then close the uterus again, and then try to do a hysterectomy, a supravaginal hysterectomy or obstetric hysterectomy in order to decrease the blood loss from the placental side. Of course, the lower area where you're going to separate the bladder from the uterus is going to suffer from major bleeding, and you have to properly control this bleeding by properly ligating and properly cutting the whether the uterine or the Macken-Rhodes and uterosacral ligaments in order to be capable of controlling this condition. This is our conservative approach in these cases where we had a successful more than, let's say, 500 or 600 cases of conservation in the past couple of 7 or 8 years. And this is the method of conservation we're going to do, where we dissect the bladder downwards and we do a manual separation of the placenta with a rapid cervicoesmical sutures in order to control the bleeding from the placental site, specifically in the lower area. Again, this is not a routine procedure, and it's not an easily reciprocal procedure where you could do it for the first time, for example, at your hospital. So I do not advise everybody to do it, but it's the method we've been using for over more than 500 or 600 cases. So when we do the procedure now, you're going to see that the placenta is reaching to the surface of the uterus with the crossing vessels. This is a case of placenta previa accreta spectrum. Okay, the most important part is properly dissecting the bladder downwards in order to be capable of doing a low incision in the uterus in order to be capable of delivery of the fetus and then management of the bleeding properly. The proper hemostasis may take too much time from us. Actually, in this patient, it took around 30 to 35 minutes in order to be capable of controlling the crossing vessels between the bladder and the uterus. This is now, we're opening through the uterus in order to deliver the baby. You're going to find that this is a transplacental incision. The blood loss is considerable together with the amniotic fluid that's coming out. After we deliver the baby, we're going to extrude the uterus, and then we're going to separate the placenta and then control the bleeders immediately in order to try to properly do hemostasis to decrease the blood loss, which could be more than 1 to 1.5 liters per minute. Now we're going to try to ligate the bleeders in order to control the bleeding from the hemostatic surfaces. We took a Alice forceps and held the cervix in order to control the bleeders that are found from the lower edge of the placenta. This selective hemostasis was the most successful method in order to decrease the blood loss from the placental site, and we did not close the uterus until there was total and proper hemostasis from all the areas. This is the final picture after we finish. The uterus is closed properly. The upper and the lower edges are properly approximated, and there is no bleeding either internally or from the vagina. Of course, the presence of cell salvage is extremely important because the amount of blood that is extricated from the patient, if it could be reused again, this may be very important in decreasing the external blood requirements of the patient. So just one of my colleagues in the UK, he told me that in these patients, they use 1 to 2 units of blood and they depend on the cell salvage in a major way. The long-term reproductive outcomes following the conservative management appear to be suboptimal, but still the data are limited. Although there appears to be an increased risk of developing intrauterine synecdoche, most women who desire another pregnancy are able to conceive are at increased risk of another recurrent placenta accreta. We did a study after the cases where we did conservation, where we did hysteroscopy to assess the uterine cavity, and we found that these patients, actually most of them had a healthy intrauterine cavity. Some of the patients were actually just around 1 or 2 of the patients had a defect in the anterior uterine wall, but it was repaired via laparotomy. To sum it up, ultrasound is the main line of diagnostic measure with a specific checklist that must be present. Refer to a center of excellence fulfilling the specific criteria. Operate upon these cases on an elective base between 35 and 37 weeks. Do what you are trained to do. Cesarean hysterectomy is safer than forcible removal of the placenta. The role of ureteric stents and radiological intervention is still to be assessed. Trial of conservation must be in selected cases with expert surgeons. This is the paper we presented in the Congress, the Royal College in the year 2019 about the conservative management. And this is the multidisciplinary team that you must have working with in Ain Shams University. And this is the research, Masri and Ain Shams Research Institute that is had a major role in the management of hepatitis C and is working with us in decreasing in the research and decreasing the cesarean section rate and in cases with placenta accreta. Thank you very much.
Thank you, Dr. Walid, for this amazing lecture. Actually, has a lot of information. If any question here, if you have any question related to the placenta accreta part, a lot of appreciation and a lot of thanks for you, Dr. Walid, for this amazing lecture. You can follow it in the chat box.
Thank you very much.
Actually, Dr. Walid, it was an honor to have you in American Association Scientific Committee and Pregnancy-Related Complication Hub. For sure, we will have you in upcoming event. It's an honor to have such a great icon like you.
It was a pleasure, Dr. Mariam. Thank you very much. Goodbye.
And now we will anytime. And now we will continue our lecture with one of the most important lecture here about gestational diabetes with one of the biggest icon in case a Professor Hisham Arab. He is Senior Consultant Obstetric Gynecology and Perinatology, Director of Dr. Arab Medical Center, Faculty of Medicine, King Saud University. He will speak with us about one of the most important topics. It's about gestational diabetes. Hello, Professor Hisham. Do you hear me?
Well, hello.
Hello, Dr. Hisham. We are hearing you well.
Okay, very good. Maybe first of all, I'd like to thank American Association and the beautiful team here for organizing such a great hub, which I liked really since the start of it. And I'm sure you're doing a great job by inviting these eminent speakers when they discuss these important topics. I'll share my screen if you allow me. Bismillah ar-Rahman ar-Rahim. Can you see my screen?
Yes, we can see it now, Dr. Hisham.
Very good. Bismillah ar-Rahman ar-Rahim. We're talking about gestational diabetes, but to start with, diabetes in pregnancy has really been a problem that's increasing, whether because we have high number of gestational diabetes, or what we call the pre-pregnancy diabetes. And I put this map here to show you the high incidence or prevalence of GDM in the Gulf region, which including Saudi Arabia and the Gulf area, was going up to something like 20% of all pregnant women. So and this is just to show you why it is on the rise, because maybe number one, we have the decreased age of onset of diabetes in women in general, or increased age of marriage. Women get married at a later age, and we know that after the age of 30, usually the incidence of GDM increasing, or actually having the child at very late age, maybe towards the end of 30s, and obesity. And we all know that obesity is an epidemic, and we have to fight this problem. This diagram here just to illustrate the pre-pregnancy diabetes versus the gestational diabetes, which is really diagnosed. There is an area called pre-existing diabetes that really sometimes is not really a true GDM. This is a woman who hasn't been diagnosed with type 2 diabetes, but really she went into pregnancy, and from the first month she started to show diabetes, and that's why we classify her as more related to the pre-diabetes. And here, just simply in this cartoon to show you the effect of insulin. Insulin is just like a key that will open the channel in the cell where it will take all the glucose in the circulation. So if that key is working properly, more likely we'll have a euglycemia, a normoglycemia. Well, what happens in pregnancy? In fact, we have an organ called placenta, and this actually produces a large amount of hormones that are diabetogenic. Somebody asking why and the placenta produce and hormones that are diabetogenic. Well, because we have a fetus. We need to nourish that baby. So for that purpose, we have to have that, diabetogenic effect with all these HPL hormones, progesterone, and etc., and others. So with that kind of effect, then the pancreas has to be really equipped where it has to really produce maybe more estrogen. Now, we have seen that as a result of this effect, there are some risk factors associated with GDM. And if you're talking about overweight or obesity, lack of physical activity, previous gestation and diabetes in the past, polycystic ovarian syndrome, diabetes, and the immediate family member actually having diabetes, or previous delivery of a baby who is more than 4 kilograms, older maternal age, and genetic or epigenetic environment. So these are with the classic risk factors for gestational diabetes that we all read in the books, on the articles. But remember, no non-risk factor has been seen in about 50% of cases of gestational diabetes. And the reason is because of this problem here related to the insulin. I mean, where the pancreas is working well, okay, to overcome the situation of this hyperglycemia associated with the normal pregnancy. However, there is a problem with the receptor itself of this insulin, and that's why we call the insulin receptor problem or resistance, where this key doesn't turn. And if that doesn't occur, that means the blood sugar remain in the circulation, cause the hyperglycemia. So, as a consequence of gestational diabetes, you can see here, for example, if there is effect on the baby or the newborn, either jaundice, respiratory distress, high birth weight, and prone to obesity in the future, prone to have gestation, they have diabetes in the future, preterm birth, and also type 2 diabetes later in life. You can see from this list, I did not put any congenital anomaly, because congenital anomalies are not associated with gestational diabetes. They're associated with pre-diabetes or somebody who has been type 1 diabetic. Now, what about the mother? The mother, she can be, as a consequence of having gestational diabetes, she become obese in the future and having maybe diabetes in the future. Also, birth trauma because of the big baby, miscarriage of the pregnancy, infection, as we all know, with the blood sugar being high, preterm birth, and preeclampsia, usually associated with gestational diabetes. So when you talk about the fetal-maternal complication in general, I'm talking about the diabetic, whether gestational or not, you can see here the commonest factor is actually the macrosomia. So macrosomia can be seen with GDM and also can be seen with type 1 diabetes if it is not controlled well. And you can see the incidence about the association about 63%. Polyhydramnios with the GDM, cesarean delivery increases again with GDM 56%, preterm delivery 42%, preeclampsia about 20%. And then you talk about respiratory distress problems for the baby, congenital anomalies associated with the type 1 or pregnancy diabetes. And from the neonatal point of view, you can see there is morbidity associated with the preterm birth, as you all know, being small baby and environment complications. Macrosomia, which is a related injury that is can be like brachial plexus injury or shoulder dystocia sequence, cardiomyopathy, and other things related to the hyperbilirubinemia. This is just some of the congenital anomalies that we see because of mothers who come into pregnancy with high blood sugar, whether they are type 1 or type 2. What happens if your blood sugar is too high in the beginning of the pregnancy? The blood actually becomes viscous, and that's why the flow of blood within the placenta during this embryonic formation is reduced or altered. As a result, the organs that taking place for development at that stage can be affected. And there are 3 areas here that you have to think about, which are mainly the congenital heart disease and also the spina bifida or neural tube defects. And number 3, as you can see here, is the cleft palate or lip. Now, There is a problem here whenever you have a patient coming with diabetes that maybe she has been missed. So preconceptional counseling is very important. Any woman who's diabetic and he wants to get pregnant, I always tell her, don't come to me. Go to your doctor, diabetologist. Tell him, fix my blood sugar. I want my blood sugar to be in the normal range, because that's the time when you come to me and I tell you whether to get pregnant immediately or we have to wait till you normalize your blood sugars. So this is a very important way of counseling. Also, you check for other, maybe if she has insulin resistance syndrome with other factors that can be complicating her future or her pregnancy itself. In addition, to look into the how to prepare her for different complications of pregnancy and diabetes. Universal screening. This is how we look for women who are just pregnant, but we want to make sure that they are gestational diabetic or not. And for this reason here, there are two ways of assessing this: either universal, that we test every single pregnant woman, or a specific where we can test only those who had the high risk tendencies, like the list of things, previous big baby and family history of gestational diabetes or diabetic in general. So this is what we call the selective risk factors, that we test only those ones. And now for the universal screening, we all know about the two-step technology or methods that has been applied in the past and has been even recognized by the ECOG till 2022, I think. But then actually, and what do you do in the screening test? And step one, which we do the GCT, the glucose challenge test, where you give actually 50 grams of glucose, test the blood sugar 1 hour after that, whether she had a breakfast or not. Okay, and if it is more than 7.2 millimoles per liter, then she goes for the second step, which is what? Oral GTT, full oral 3 hours GTT done. So this is the old method. This is something that the whole world has left now to do what we call the one-step method, which is really very simple, and it is universal for everybody, usually done in the first visit, regardless when was the first visit she came to you, and ideally between 24 and 48 weeks. And for this, actually, this is what we came as a result of the hypoglycemic and adverse pregnancy outcome study published in 2008, where they say, okay, we give every pregnant woman a 75 gram of glucose, and we do 3 readings, the fasting, and then 1 hour later and 2 hours later. That's it, usually between 24 and 32 weeks. And we have seen that by looking into this, we have really achieved a lot. These are the different numbers, if you are interested to know what kind of threshold you're looking at here for the HAPOT study, which really since 2010 all the world has really adopted fasting of 9 to 2 after taking 75 grams of glucose, 1 hour 180 and 2 hours 153. And if you have only one reading, not like the OGTT, 2 readings, no, here you have only one reading abnormal, then you declassify that patient as being gestational diabetes. So what happens since we establish this one-step technique around the world? There are about 4 RCTs actually. When you put them together, we can see by adopting the one-step technique, we have actually reduced the PET by about 34%, reduced the neonatal hypoglycemia by 48%, reduced the cesarean section by 17%, reducing the NICU admission 51%, reducing the large for babies for days, which is about by 57, almost 60%, reduction in the neonatal mortality 74%, and even less weight gain pregnancy was only 1.3 kilogram. So you can see here that lots of benefit has been achieved because we are doing it universally, number one, and number two, we are taking one reading being abnormal. So more likely we are not going to miss any patient who is going to have gestational diabetes. So, I mean, this is just to show you how the Americans, after seeing all these numbers, they decided to ignore their original thinking of two-step test. And now, since 2020, the Americans are following the rest of the world by doing the one-step approach. And here is just the next few slides talking about the management, because I only have like 20 minutes talk, which is for a big subject. So we're talking about medical nutritional therapy, pharmacological therapy, glycemic monitoring, fetal monitoring by ultrasound, and then planning delivery. So in terms of the approach, usually whenever I have a patient who has abnormal glucose testing in 24 weeks or any time through the one-step approach, what I do, I don't start on treatment. Usually I tell her, go on diet and exercise. So I give her all the instructions of diet and exercise, and just do nothing, come back after 2 weeks. When she come back after 2 weeks, now we have given that body and her system to acquaint with this restricted dieting, and also with the increase of exercise. Then I'll ask for the 4-hour readings, the fasting 2 hours after prandial, to do it on, for example, on 3 or 4 times a week. Come back in 1 or 2 weeks doing these readings. And if I find in any of those readings having blood sugar more than 120 milligrams per deciliter, then usually I start the oral treatment or insulin therapy according to the dose, and especially if she has high fasting or not. Now, in terms of medical nutrition therapy, of course, we have to calculate, how much she needs from calories. There's the dietitians are very good at this, and they can actually look according to the BMI of the patient and her blood sugars. They can calculate the exact calories and how we distribute these calories between breakfast, lunch, and dinner, plus a snack, and also the amount of fibers included, because this is a very important area that help reduce the blood sugar. And very, very important to tell the patient that you have a limited number of kilograms to put on during pregnancy, and this is the recommendations, American recommendations for how much weight gain you put in pregnancy. For a non-diabetic, of course, and lean person, we can say I can put to 12, 14 kilograms, but for somebody who is obese and diabetic, 5 kilograms maybe is enough for her during pregnancy. The larger the amount of blood weight in pregnancy, even in a normal pregnant woman, that will predispose her to developing gestational diabetes during pregnancy. Now, how will we follow these patients antenatally? Of course, we have to see these patients from the beginning and have a proper ultrasound to look for any, first of all, for the growth, to have an exact date, and you should not change the date that you gained at the first trimester. Number 2, do the second trimester scan to rule out for anomalies, and then monthly scans to look for the growth and see whether you're dealing with the macrosomia or not. And finally, you have to do what we call the biophysical profile scoring weekly during after 36 weeks of gestation. Glucose monitoring is very important, which is really, I ask my patient to have this a machine to do a glucometer, and they check the blood sugar or fasting, and then 2 hours postprandial after breakfast, lunch, and dinner. So they have 4 readings a day. They can do it as long as, every day or every other day, no harm. And then you make sure that you have a specific values. You should tell them that they should not really jump or go beyond. For a fasting should be always less than 95, and for postprandial 2 hours it should be 120. So that's the levels that we like to see our patients really hovering around. Now, what do you do if your patient came back with this home glucometer readings with higher readings than what you're expecting? Then you should start her on medication. Now we have the freedom to use the anti-diabetic oral drugs, like metformin, for example, is safe, and for years we have been cautioned about it, but since for the last, I think, 5, 6, 7 years, we have really been assured with many studies coming out to say it's not teratogenic and it can really work beautifully. If you find a patient having a very high blood sugar, fasting blood sugar, or readings very high, then there's a chance here maybe you can go straight to insulin therapy. Sometimes we combine the insulin therapy along with the oral hypoglycemic agents like metformin and others. And here is, I mean, there are many ways of getting in the approach here. For example, this is how you prescribe them the insulin. I mean, usually it depends on the readings that your patient is at. For example, if her reading is more than 200, then you should start with 8 units per day, and then you start giving check her blood sugars. And accordingly, usually we give actually 2/3 of the doses in the morning and 1/3 in the evening. And also you can play with the type of insulin, whether it is NPH or regular, meals. It's really and it's very important to take blood sugars and after postprandial. Now, the risky situation on insulin therapy is really sometimes like nausea and vomiting. Be careful if the patient she took her dose, but then she went to vomit, she lost all the meal, more likely she may go into hypoglycemia. So hypoglycemic episodes is really dangerous for a woman who's pregnant. So be careful when you are following patients with being on insulin. Now, the time for delivery. Well, usually we allow patient to go for 38 to 39 weeks. Now, if she's being really followed very well and she is good patient with good control, you can continue to 40 weeks, not go beyond 40 weeks. But if she's a poor control, then more likely by 38 weeks, you can induce her. And if the baby is actually having weighing more than 4 kilograms estimated fetal weight, then you can go straight for a cesarean section rather than induction of labor. Now, again, if you have a patient in labor who's having high blood sugar, you can really start even insulin at that time. And this is just to show you roughly that you use IV normal saline and you add this level of this amount of insulin according to the blood sugar when she arrived in the morning for the induction of labor, which is something very common we deal with in our delivery room. And post-delivery follow-up is very important because number one, you have to check if she was on insulin, then maybe you cut that dose to half or maybe to stop it. And then you just do her blood sugars 3-4 times a day while she's in hospital, bring her back again and 3-4 days and check blood sugar again. And also the most important thing, if she's GDM, is to bring her at 6 weeks of gestation and do another oral GTT, the new 75-gram dosing with 3 readings, and just to make sure whether this patient actually has resolved her GDM or she became a persistent type 2 diabetic patient. And breastfeeding, we always encourage women who are really having diabetes with to breastfeed, which is really very helpful to her. And finally, ladies and gentlemen, gestation and diabetes is a common problem in Saudi Arabia, at least, and what I'm talking to you about. Risk stratification and screening is essential, and also tight glycemic control is required for optimal maternal and fetal outcome. Patient education is essential to meet these targets, and long-term follow-up actually for the mother and the baby is essential. Sorry I was so quick because I only been given 20 minutes for a huge subject, but I'd like to thank you all. And I want to finish with this very important slide, which is GDM prevention strategies. I think gestation diabetes is a preventable disease. Number one, starting the strategy number one is avoiding obesity. So you always tell the patient before you get pregnant, lose your weight, okay? Be lean and check your even like any cardiometabolic markers. For example, fasting blood sugar, insulin, triglycerides, and HDL, and also become more active with doing increasing exercise. Strategy number two, or step number two, our strategy is universal screening. So that's why we don't really use anymore the selective screening. We use the HAPO recommendations of 2008 by giving 75 gram and 2-3 reading. If one abnormal, we classify her as GDM. And then good glucose monitoring. Of course, we have to bring the patient every 2 weeks, 3 weeks, no problem if she's in a pregnancy, but don't let her go alone. I've seen patients who unfortunately been taking huge amount of insulin and she is putting on weight, unfortunately, and her blood sugar is still playing high. Once I cut down that insulin to even half and told her, just do a little bit of exercise and strict about dieting, she didn't require high doses at all. So the treatment, actually, the core of the treatment here is exercise and dieting. The pharmacological therapy, this is coming in between, and we'd like to minimize that as much as we can to have a healthy mom and child. Thank you very much. Any questions, or shall I answer the questions I received?
Thank you, Dr. Hisham, for this amazing and informative lecture. Actually, it was very informative. I'm speechless. A lot of doctors appreciate you and thank you in the chat box, and all of them actually get interested in your topic. Actually, doctor, it's an honor to have you in this pregnancy-related complication hub. And for sure, it will not be the first communication between each other, and we will cooperate in the future for sure. Thanks, Dr. Hisham.
Thank you very much, Mariam, and thanks to all the American Association team, and I'll be more than happy to join you again. It's really a great platform, and I'd like to congratulate you for this activity. Thank you.
Thank you, Dr. Hisham. Thank you. And now we will take a break for 5 to 10 minutes to take your breath from these amazing lectures and come back with another informative lecture that will be introduced by our beloved Professor Mahmoud Sulaiman about the multiple pregnancy. Actually, it's a so interesting topic, so don't miss. It's just only a break for 5 to 10 minutes, not more.
دورة الاستاتيك جاينيكولوجي كلش كانت مفيدة وممتعة وأتمنى أن الكل يشارك بيها.
كنا نحقن بإيدينا ونعمل الأشياء بإيدينا، كان كتير مفيد بصراحة، ويعني الواحد باخذ خبرة أكتر وقوة أكتر.
دورة الأستيتيك جاينيكولوجي كلش كانت مفيدة وممتعة وأتمنى أن الكل يشارك بيها.
كنا نحقن بإيدينا ونعمل الأشياء بإيدينا، كان كتير مفيد بصراحة، ويعني الواحد باخد خبرة أكتر وقوة أكتر.
كورس الانفيرتيليتي اند اي في اف بصراحه كان كثير مميز وحلو ومرتب، المعلومات متسلسله، الاساتذه كثير يعني ساينتفك بالشرح تبعهم.
صراحه كورس كان شامل كل حاجه، الماده العلميه كويسه جدا، اساتذه المحاضرين.
كورس الانفيرتيليتي اند اي في اف بصراحه كان كثير مميز وحلو ومرتب، المعلومات متسلسله، الاساتذه كثير يعني ساينتفك بالشرح تبعهم.
صراحه كورس كان شامل كل حاجه، الماده العلميه كويسه جدا، اساتذه المحاضرين.
Association course Infertility and IVF بصراحة كان كتير مميز وحلو ومرتب، المعلومات متسلسلة، الأساتذة كتير يعني ساينتفك بالشرح تبعهم.
صراحة كورس كان شامل كل حاجة، المادة العلمية كويسة جدا، أساتذة المحاضرين.
كورس Infertility and IVF بصراحة كان كتير مميز وحلو ومرتب، المعلومات متسلسلة، الأساتذة كتير يعني ساينتفك بالشرح تبعهم.
صراحة كورس كان شامل كل حاجة، المادة العلمية كويسة جدا، أساتذة المحاضرين.
كورس Infertility and IVF بصراحة كان كتير مميز وحلو ومرتب، المعلومات متسلسلة، الأساتذة كتير يعني ساينتفك بالشرح تبعهم.
صراحة كورس كان شامل كل حاجة، المادة العلمية كويسة جدا، أساتذة المحاضرين.
كورس Infertility and IVF بصراحة كان كتير مميز وحلو ومرتب، المعلومات متسلسلة، الأساتذة كتير يعني ساينتفك بالشرح تبعهم.
صراحة كورس كان شامل كل حاجة، المادة العلمية كويسة جدا، أساتذة المحاضرين.
IVF بصراحة كان كتير مميز وحلو ومرتب، المعلومات متسلسلة، الأساتذة كتير يعني ساينتفك بالشرح تبعهم.
بصراحة كورس كان شامل كل حاجة، المادة العلمية كويسة جدا، أساتذة المحاضرين.
Association كورس Infertility and IVF بصراحة كان كتير مميز وحلو ومرتب، المعلومات متسلسلة، الأساتذة كتير يعني ساينتفك بالشرح تبعهم.
بصراحة كورس كان شامل كل حاجة، المادة العلمية كويسة جدا، أساتذة المحاضرين.
Association كورس Infertility and IVF بصراحة كان كتير مميز وحلو ومرتب، المعلومات متسلسلة، الأساتذة كتير يعني ساينتفك بالشرح تبعهم.
Hello, everyone. Come back again from the short break. I know it's short, but actually there's a lot of lectures and a lot of topics so important, I know. So we must continue. There is a link here in the chat box to get your certificate. So please fill it to get your certificate after finishing the hub. And now we'll start our hub with Professor Mahmoud Sliman. He will speak about multiple pregnancy. So I'll let you with Professor Mahmoud Sliman. And now we will know more about multiple pregnancy topic. So let's see.
مساء الخير جميعا. أنا الدكتور محمود سليمان، أستاذ مساعد أمراض النساء والتوليد بكلية طب القصر العيني جامعة القاهرة، ومبسوط جدا في مشاركتي مع البريجننسي كومبليكيشنز هاب. واحدة من الهاي ريسك بريجننسي الحقيقة مواضيع اللي بنقابلها كل يوم في عياداتنا وبقت كتيرة جدا هي التوين بريجننسي، ودي تعتبر من الحاجات الهاي ريسك، ولازم تكون انت ككلينيشن فاهم كويس جدا ازاي هتعرف تدايجنوز وتتعامل مع المواقف المختلفة، وخصوصا في المالتيبل فيتال بريجننسيز. احنا هنمشي كده كبريف هيستوري كده او حاجة بسيطة جدا نفهم هو التوين بريجننسي دوت ايه انواعه، يعني كريفرشمنت للمعلومات بتاعتنا. لازم نكون فاهمين ان احنا 2 ل 3% of pregnancies twin pregnancy، وخصوصا الفترة اللي فاتت زادت جدا مع وجود الاكزي بروسيجرز. التوين pregnancies بقت عالية جدا، ولازم نكون فاهمين ايه الانواع بتاعتها. في منها الدايكوريونيك وفي منه المونوكوريونيك، طبعا اختارهم هو المونوكوريونيك. الاي في اف زود مواضيع الدايكوريونيك، ولكن ده لا يمنع ان التعامل مع الامبريو ممكن يريتيت ويسبلت على نفسه، ينقسم على نفسه، ويبقى بعد كده حاجه اسمها المونوكوريونيك. فعشان كده هو الاخطر المونوكوريونيك، وهو ده الهدف، انت لازم تبيك اب المونوكوريونيك. طيب سريعا كده، هو ايه الفرق بين الدايكوريونيك والمونوكوريونيك؟ هو ببساطه شديده التو سبيرم فيرتلايزد 2 اوفا هيؤدي الى 2 امبريوز سيبلينجز، اخوات، يعني ممكن يبقى ولد وبنت، ممكن يبقى ولدين مش شبه بعض، ممكن يبقوا بنتين مش شبه بعض، وده اسمه الدايزايجوتكس. لكن المشكله دايما بتقابلنا لما يبقى في 1 سبيرم فيرتلايزد 1 اوفم وهيديني 1 امبريو، والامبريو دوت لو سبلت as early as possible في اول 3-4 ايام ده هيديني دايكوريونيك داي امنيوتيك. المصطلحات مهمه جدا ككلينيشن تبقى انت totally understand الموضوع دوت، وازاي تقدر بالالترا ساوند ومتابعتك للحمل تقدر تبيك اب حاجه زي كده. طب لو السبليتنج حصل بعدين، ده الثيري، يعني بعد 5 ايام 6 ايام 7 ايام، ده هيؤدي الى مونوكوريونيك داي امنيوتيك. طب لو بعد 8 ايام لحد 12 يوم هيؤدي الى مونوكوريونيك ومونو امنيوتيك. يبقى اول 4 ايام هيبقى مونوكوريونيك دايكوريونيك داي امنيوتيك زيه زي التو دايزايجوتكس، اكنه 2 سبيرم و 2 اوفم، بس طبعا هيبقوا ايدنتيكال توينز. لو عدى ال4 ايام والسبيرم ابتدي يفرتلايز الاوفم وحصل السبليتنج من 4 ل 8 ايام هيبقى مونوكوريونيك داي امنيوتيك. ولو ابتدى يوصل ل 8 ايام فاكثر وانقسم هيبقى مونوكوريونيك مونو امنيوتيك. طب لو عدى ال 12 يوم هيبقى اللي هو الكونجوينت توينز. طيب ازاي نشخص؟ دايما بعد 6 اسابيع، يعني نقدر ندي الكونكلوجن بتاعنا بعد 6 اسابيع. according للانترناشونال سوسايتي بتاع الالترا ساوند اوبيجاين في 2016، هو البيست ديتنج للتوين بريجننسي دايما لما يبقى كراون رامف لينس زي ما احنا شايفين كده من 45 ل 84 ملم، يعني تقريبا 11 اسبوع، ده البيست ديتنج. ونحسب الديتس بتاعتنا على اللارجر كراون رامف لينس should be used. وبعد ال 14 اسبوع مش هنعتمد على الكراون رامفلنس، لو العينه كانت اول فيزيت ليها هنعتمد على حاجه اسمها الهيد سيركمفرنس، وناخد اللارجر برضه هو ده اللي هكالكليت عليه. طب لو هي عامله اي في اف بنحسب من الديت اوف ريتريفل او من الديت بتاع الفيرتلايزيشن الامبريو ترانسفير، ونشوف عدد الفيرتلايزيشن ديتس بتاعه البيبي قد ايه، وبنكالكوليت عادي جدا زي اي في اف بروسيجر كالكوليشن. يبقى في البدايه انا محتاج اقدر اعرف العينه دي توين بريجننسي ولا لا، اقدر اديت ازاي، اقدر ابقى فاهم هي عمر قد ايه، ان انا هحتاج الكلام ده كله بعد كده ليتر اون في ايه، ليتر اون محتاجه علشان اقدر اشوف البيبي ده الجروث ريت بتاعه ماشي بشكل سليم ولا مش بشكل سليم. طيب ازاي نديفاين كوريونستي؟ طبعا فيتال جينيتر، يعني ازاي اقدر ده مونوكوريونيك ولا داي اكوريونيك، ازاي اعرف لو في ديفرنت فيتال جينيتر، يعني لقيت ولد وبنت خلاص ده دايكوريونيك خلصت، يعني ده ما حصلوش سبليت، ده مش مونوزايجوتكس ده زيجوتكس، يعني لو في ديفرنت جندر خلاص يبقى انا كده حليت المشكله من البدايه. او النمبر اوف بلاسنتال ماسز، يعني ايه نمبر اوف بلاسنتال ماسز؟ يعني كل بلاسنتا واخده اتجاه خلاص. او نشوف الممبرين بتاعنا اللي ما بين البيبي الاولاني والتاني هو الانسيرشن بتاعه عامل ازاي. لو ثيكند انسيرشن عامل زي كده نازل على واسع نسميه حاجه اسمها لامدا ساين او تي ساين. الانسيرشن اللامدا ساين يبقى ساعتها نقول ده ثيكند بارت ان لسه ما حصلش فيوجن ما بين الكوريونيك والامنيوتيك، وبالتالي نقول ده على طول دايكوريونيك. اما لو نازل تي ساين اللي هو نازل حرف التي كده نازل بالنص، ساعتها هنقول ده فيري ثين وممكن يكون مونو كوريونيك وشيرنج ذا سيم بلاسينتا. كارثتنا في التوينز تاني هو المونو كوريونيكس، الكومبليكيشنز كلها في المونو كوريونيكس. انا متفاهم طبعا ان التوينز ليها مشاكل تانية على مستوى الماتيرنال، اوكي، منها الانكريز ريسك اوف بري تيرم والانكريز ريسك اوف بري كلامسي، عشان كده محتاجه متابعه قويه جدا، والانكريز ريسك اوف جستيشن دايابيتس. ولكن البيبي برضه ده ريسك، ده جزء من الهاي ريسك، ان الهدف من الاساس من الحمل هو ايه؟ ان الام تقوم بالسلامه هي واولادها. فلازم نقدر نبيك اب as early as possible اي مشاكل تحصل للبيبي زي ما بنحاول نبيك اب المشاكل اللي ممكن تحصل للام. يمكن دي رسمه توضيحيه كده، شايفين اللي هنا ده، هنا ده داي كوريونيك داي امنيوتيك، ادي تو كوريونز تو بلاسنتي، وادي ده ليفين بريم، ده ممبرين، ده بيبي وده بيبي وخلاص. دوت مونو كوريونيك they are sharing the same placenta مع two different amnion sacs. اما ده مونو كوريونيك ومونو امنيوتيك، يعني نفس البلاسنتا ونفس الامنيوتيك ممبرين. شايفين اللي انا كنت لسه بتكلم عليها من شويه؟ ادي اللامدا ساين، شايفين اللامدا ساين ديت؟ شايف نازله واسعه ازاي؟ شوفوا بقى التي ساين رفيعه جدا، ان لسه ما حصلش فيوجن بين الكوريون والامنيون، فقدرنا نشوفها بشكل واضح جدا. ولما نشوف المنظر اللامدا ساين بتوين التو بيبيز نقول على طول ده كوريونيك، على الرغم ان هي واخده شيرنج ذا سيم بلاسنتا الماس اهي، يعني دي كل دي بلاسنتا. لكن هنا دي النهارده لما اشوف المنظر ده في السونار لا خلاص دي كوريونيك وابقى مطمن نوعا ما. اما ده لا، ده زي ار شيرنج ذا سيم بلاسنتا، دي بلاسنتا واحده اهي، دي تي ساين ان هو نازل رفيع جدا very thin layer ما بين التو بيبيز او تو توينز. ليه بحتاج اشخص؟ طبعا الاكريسي بتاعنا يبقى قبل 15 اسبوع من الحمل، يعني دايما نحاول نجيب العينين دايما. عشان كده متابعه الحمل يا جماعه هو اهم حاجه يا دكاتره، ان احنا نتابع الحمل دايما بدري، يعني ما نحاولش ناخر متابعتنا في الالتراساوند، ان طبعا السنسيتيفيتي بتاعتنا والسبيسيفيستي قبل ال 15 اسبوع زي ما انتم شايفين 94% و99.5% اشخص ده كوريونيك، وده مهم جدا بالنسبه لي. طيب هل محتاج اشخص امنيوستي؟ طبعا محتاج اشخص امنيوستي، لازم يكون اعرف هي في قد ايه امنيوتيك ساكس. نعرفها ازاي؟ من السكند يوك ساك على فكره. لو انت في الاول لو هي مونو امنيوتيك هتبقى 1، كنت شايف 1 يوك ساك ان number of the yolk sacs reflecting number of amnions. خلاص، يعني لو لقيت في الكيس جواه 2 يوك ساك يبقى دي غالبا هتطلع داي امنيوتيك. لكن لو لقيت كيس كان فيه 1 امنيوتيك يوك ساك وبعد كده لقيت في المتابعه لقيت بعد كده بيبي سبليتنج، انا اشك على طول هو في مونو امنيوتيك. دي صور كده انا يعني حاططها لكم للفرجه، يعني شايفين ده بيبي ده 1 يوك ساك، شايفين التو بيبيز دول شيرنج ذا سيم امنيون ساك اهي، خلاص شكرا، ده مونو امنيوتيك. ده هنا 1 بلاسنتا وانذر بلاسنتا، دي ايه دي بقى؟ دي اللامدا ساين، فده دايكوريونيك. طب ليه تراي امنيوتيك؟ ان انا عندي امنيون وامنيون وهنا في خط رفيع جدا بس مش باين ان ده حصل له سبليتنج، فبقى في تو بلاسنتا مونو او داي سوري كوريونيك مع 3 امنيونز. ان ده تريبلت، ادي 1 ادي 2 ادي 3 بالبلدي كده يعني. في 2 بلاسينتا بتغذي البيبي ده لوحده بالامنيون ساك بتاعته، وواحده بلاسينتا بتغذي البيبي ده وتغذي البيبي دوت مع 2 امنيون. فده مونو كوريونيك هنا للبيبي دوت مع داي امنيوتيك لو اعتبرنا ده مش موجود. اما لو ده موجود يبقى ده اسمه داي كوريونيك، ادي 2 بلاسينتي مع ايه؟ تراي امنيوتكس. احد الحاجات برضو اللي ممكن اشخص بيها هو الجندر زي ما انا قلت، يعني دي فيميل وده ميل، وانت مغمض على طول ده ايه؟ ده دايكوريونيك، وانت مغمض ده دايكوريونيك. ده 2 بلاسنتي. ليه؟ ان دول غالبا داي زيجوتكس، يعني ده كل واحد زيجوت كان لوحده. طيب في قاعده بتقول نمبر اوف يوك ساكس اللي هتشوفها هي نفس النمبر بتاع الامنيوسايتس، يعني لو كان في 1 يوك ساك فده مونو امنيوتيك، لو كان 2 يوك ساكس يبقى ده داي امنيوتيك. وده الايزيست واي، ده الايزيست واي عشان تشخص الايه؟ المونو امنيوتكس. شايفين دول ايه؟ قبل 6 اسابيع تقريبا، شايفين 2 يوك ساكس، فدي غالبا هتطلع داي امنيونز اهي، كبروا بعد كده ادي 2 يوك ساكس خلاص. وادي الممبرين رفيع اهو عند الخط الاصفر ده. طيب مش معنى ان انا ما شفتش الثين امنيون ان انا اقول عليه مونو امنيوتيك، دي لازم تكون قاعده. داي امنيوتيك if one of the لقيت 2 بلاسينتا يبقى ده داي امنيوتيك وانت مغمض. لو لقيت في different sex، لو لقيت الممبرين السي، لازم تشوف واحده من الثلاثه دول عشان تشخص داي امنيوستي. لازم لو انت شفت العينه متاخر لازم تتاكد ان في 2 بلاسينتا مع different sex مع ممبرين السين in between. مهم جدا الحاجات دي ليه؟ علشان في الاخر احنا هنشخص حاجات complications later on في المتابعه. طيب دايما ايه مشكله المونو امنيوتكس؟ يمكن هي اشهر مشكله هي الكورد انتانجلمنتس، يعني الكوردز يلف حوالين نفسهم. بنعرفها ازاي؟ بنحط كالر دوبلر على الامبيريكال كورد، ولو لقيت فيه 2 different فيتال هارت ريت ويفز بنقول ده كورد انتانجلمنتس. وده ممكن يحصل طبعا ان البيبيهات تلف حوالين نفسها، وممكن يحصل فيتال ديمايز ان فيري ايزي واي. شايفين زي ده مثلا، ده لف حوالين نفسهم. شايفين الكورد انتانجلمنتس ممكن تلف ازاي؟ يبقى تشخيصي بدري للحالة يخليني أقدر أعرف أتوقع إيه، وأقدر أتابع العينة دي. العينة دي consider high risk pregnancy وليها complications كتيرة جدا على ناحية البيبيز وعلى ناحية الأم زي ما اتفقنا ال higher incidence of preeclampsia and hypertension and diabetes وبريتيرم. شايفين المنظر ده؟ ده cord entanglements. كل الكوردز لو عملت كرر دوبلر هنا هلاقي ده فيتر هارد ويف مختلف عن فيتر هارد ويف عن هنا. طيب انا بحاول بس اعمل ريفرشمنت للمعلومات عشان نخش على الحاجات الايه الاساسيه. الجايد لاينز بتاعت الكوريوناستي لازم تترمد قبل 13 اسبوع زي ما اتفقنا، وبنعتمد على الايجنج على الكراون رامفلانس، ولو عدينا ال 14 اسبوع هنعتمد على الهيد سيركمفرنس. هشخص ازاي؟ بالممبرين ثيكنس، لامدا سايد او تي ساين، او number of placental masses. لكن لو عديت ال 14 اسبوع هعتمد في الديتنج على الهيد سيركمفرنس، لكن different sex هو ده الحاجه الوحيده اللي هتقدر يعني تقول لي ان ده داي كوريونيك. عشان كده دايما نحاول نشخص قبل 14 اسبوع according للجايد لاينز. طيب الامنيوستي should be determined برضو. وإن case of doubt the absence of inter-twin membrane confirmed by transvaginal ultrasound. يعني إيه؟ يعني لو أنت عملت سونار على البطن وما لقيتش الانتر توين ممبرين بعد ال 14 أسبوع اعمل فاجينال التراساوند. لأن دايما عارفين إن الفاجينال التراساوند بيكبر الصورة أكتر بكتير من البلفيك التراساوند. خلاص. والكورد انتاجلمنت طبعا بنخاف منها، نعرفها ازاي؟ ده طبعا لو شفت كورد انتاجلمنت تحلف على طول ده مونو امنيوتيك، يعني عايشين في امنيون واحد. اوكي. طب ليه محتاجين بقى نكون؟ هو ده الكلام الاساسي بقى. ليه محتاجين نكون الكوريونست؟ ان نشخص ان في كام كوريونيك؟ ليه؟ تخيلوا بقى، بصوا بقى الميس كارج قد ايه؟ في الداي كوريونيك 2%، لو مونو كوريونيك 10%، يعني 10 الحالات هتسقط. برينيتال ديث انتوا متخيلين بعد 23 اسبوع 2% في الداي كوريونيك، 4% في المونو كوريونيك. فيتال جروس ريستريكشنز 20%، 30%. بري تيرم 5%، 10%. ميجور ديفكتس 1%، 4%. مين اكتر؟ المونوكوريونيك. يبقى انا النهارده لما اشخص العينه دي داي كوريونيك يبقى متابعتي في الحمل ليها هتبقى زي المونوكوريونيك بالعقل. طبعا المونوكوريونيك هيبقى متابعته ادق واعلى، ان المشاكل هتبقى ايه؟ اكتر بكتير. طيب المشاكل في المونوكوريونيك مالفورميشنز اكتر اللي احنا اتكلمناها، انا يمكن بجري بسرعه، وهو ده الكونديشن ريليتد بلاسنتال فاسكولار انستموز، هو ده الاساس اللي هي توين ترانسفيوجن والسلكتيف انترتراين جروث ريتارديشن والتوين ارتيريال بوليسيستميك سيندروم، انيميك بوليسيستميك سيندروم. دي من الحاجات الشهيره جدا اللي ممكن تحصل مع المونوكوريونكس. congenital anomalies اللي بتزيد طبعا ممكن في سي ان اس، ممكن يبقى فيشل، ممكن يبقى في الجي اي تي، ممكن يبقى في الهارت. كل دي مشاكل ممكن تحصل في البيبيهات، ودي برضو مش شغلتك، ده هيبقى شغلة الفيتال ميديسن. لكن انت كدكتور قاعد في عيادتك بتتابع عينة توأم، يبقى انت فاهم محتاج تشخص ايه، عشان انت فاهم هتشوف ايه او متوقع تشوف ايه او هتعمل ايه. اوكي، تعال نشوف كده. ده مثلا ده مثال للمونوكوريونيك، شايفين فيري ثين، انا بحاول اوريكم صور بس. شايفين دوت في لامدا ساين تخين جدا، لا ده دايكوريونيك وانت مطمن. طيب مهم جدا في كل مره ان احنا نعمل حاجه اسمها ليبلينج اوف توين فيتسز. يعني ايه؟ يعني لازم اكون فاهم الفيتس ايه فين وفيتس بي فين، ونعمل مابنج ليهم ونشوف الكورد اوف انسرشن بتاعهم، علشان في الاول وفي الاخر ده هيفيدني بعد كده في المتابعه بتاعتي. فما تنسوش دايما وانتوا في عياداتكم تعملوا ليبل للتوينز، توين ايه كان كذا وتوين بي كان كذا، ونعمل دوكيمنت بالكلام دوت. طيب ومن هنا بقى جه الريكومنديشنز بتاعت الرويال كولج في الروتين سكريننج. شايفين الدايكوريونيك الروتين سكريننج كل قد ايه؟ لو خدت بالكم الانترفلز، انتوا متخيلين كل كام؟ كل 4 اسابيع. انت في بطنك نوعا ما بطيخه صيفي، انت مش قلقان، انسنس المشاكل قليله بالنسبه للبيبيز، بالعكس هي متابعات حمل عاديه. وخلي بالكم بقى في النقطه ديت بتاعه السيرفايكال لينس، اللي انا لازم هتكلم عليها، موضوع السيرفايكال لينس ده. اوكي، شايفين بقى المونوكوريونيك متابعه كل قد ايه؟ every 2 weeks، كل اسبوعين لازم العينه تكون عندك، لازم العينه تكون عندك. ليه؟ علشان المشاكل كتيره لازم بيك اب. واحد الحاجات المهمه ان احنا لازم نبص على ايه؟ شايفين يقول لك كل مره ديتيلد اناتومي وبايومتري، والديبست فنتركل ايه بوكيت، لازم اشوف الامنيون ساكس اخبارها ايه، اعمل يوتراين ارتري دوبلر وميدل سيريبرال ارتري دوبلر بيك سيستوليك فيلوسيتي عشان ابيك اب اللي بيهت الانيميك، ونشوف برضو السيرفايكال لينس عند ال 20 اسبوع. انا جاي بتكلم شايفين الفيتال جروث ريت لازم اتابعه ايه؟ كل اسبوعين. يعني العيانه اللي هتشخصها مونوكوريونيك اقول لها كل اسبوعين اشوفك، والعيانه دايكوريونيك انا اقول لها كل 3 4 اسابيع اشوفك. انتوا متخيلين بس فكره ان انا اشخص بدري عشان المشاكل اللي ممكن تقابلني في المونوكوريونكس. women with uncomplicated dichorionic twins، شوف فيرست ترايمستر سكان وسكند ترايمستر سكان ومتابعه كل 4 اسابيع، انت مش قلقان، ده فيري لو خلاص. لكن الانكمبليكيتد مونوكوريونيك ده كل اسبوعين، ولازم اتابع بشكل يعني كل مره الزيارات، اتابع الدوبلر فلو بتاعها، اتابع الجروث شارت بتاعها، لازم عشان ابيك اب المشاكل اللي ممكن تحدث من المونوكوريونكس. شوف لازم اشوف الفيتال بايومتري واشوف الاميونيتي فوليوم، ولازم اتابع الامبيريكال ارتي دوبلر بعد 20 اسبوع، واشوف الاكسبكتد فيتال ويت، ولازم احسب البيك سيستوليك فيلوسيتيز عشان لو في الاوردر تو سكرين اللي هي التابس اللي هي توين انيميك بوليسايسيميك سيكولي. هنفهم الكلام ده بعدين المشاكل ديت، بس خلينا يبقى فاهمين الكونسبتس. ان انا فكرتي كلها ان انا اعمل بس برين ستورمنج ليكم، بس تفتكروا موضوع التوينز بيحصل ازاي، ايه انواعها، ايه المشاكل اللي انا عينيا لازم هتبقى ايه مركزه معاها وانا بتابع في العياده، ان دي واحده من الهاي ريسك بريجنسيز. طيب في المونوكوريونيك دايامنيوتيك توينز الامنيوتيك فوليوم لازم برضه اقيسه، والسيرفايكال لينس، ودي اللي انا هتكلم فيها دلوقتي حالا، وارجوكم ركزوا معايا في الحته دي. الحقيقه ممارسه السيركلاج عمال على بطال التوينز دي مال براكتس. يعني according للجايد لاينز كلها ان cervical lens as long as there is no history of incompetent cervix، يعني واحده برايمي عملت لها IVF في اكتر من كده وحملت في توينز او تريبلتس حتى ايفن، طول ما السيرفايكال لينس اكتر من 2.5 سنتيمتر no rule for cerclage. خلاص اقل من 2.5 سنتيمتر نبتدي نكونسيدر السيركلاج. ليه بقول الكلام ده؟ لان احنا لازم نكون فاهمين الانسيدنس اوف بري تيرم ليبر للعيانين المالتيبل بريجنسيز هو انسيدنس عالي، و 50% من الاسباب طبعا unknown، لكن خلينا في المعروفين 90% من الاسباب المعروفه is related to infection. طيب انا النهارده لما احط خيط جوه عنق الرحم جوه السيركلاج بقى جوه السيرفكس وبعمل سيركلاج، ده انا عملت سورس اوف انفكشن، انا باريتيت اليوترس اكتر، اوكي. والعينه لو كان عندها انسيدنس ال 10% ان هي تخش في بري تيرم ليبر، انا بالسيركلاج خليتها 50%، ان انا خليت فيه مصدر عدوى. سيركلاج is not a routine practice is not a routine practice for any multiple pregnancies fetal pregnancies، مش routine practice. سيركلاج will be done لو في indication for that، لو الانديكيشن بتاعنا short cervix اقل من 2.5 سنتيمتر، او العيانه نفسها عندها history of incompetent cervix بالكرايتيريا بتاعت الانكومبتنت cervix، اللي هي البينلس كونتراكشنز وتنزل بيبي بسرعه، وعنق الرحم بيفتح بسرعه، وينزل بيبي ليفنج بالساك بتاعته بكل حاجه. يعني لازم يكون ليها الكرايتيريا بتاعت الانكومبتنت cervix. لكن عينه جالي برايمي حامل في توينز وما عندهاش اي هيستوري، او جالي حتى بحمل تاني او تالت ما عندهاش اي هيستوري، السيركلاج مؤذي. عشان كده الريكومنديشنز لو احنا قريناها في الرويال كولج في المتابعه يقول لك قيس سيرفايكال لينز، مالكش تعمل سيركلاج. انتوا خدتوا بالكم من الحته دي؟ عند ال 20 اسبوع 18 اسبوع قيس سيرفايكال لينز، وانا بقيس عند 16 اسبوع مثلا، قيس عند سيرفايكال لينز، والله اقل من 2 سم ونص كونسيدر سيركلاج، اكتر من 2 سم ونص لا، نو نيد فور سيركلاج. بالعكس انت لو عملت لها سيركلاج هتاذيها وهتدخلها بريتير ليبر، ودي نقطه من النقط المهمه في متابعه العينين دول.
Hello everyone, this is Dr. Sen.
اوكي. طيب condition related to placental vascular anastomosis، ايه المشاكل بقى اللي عندنا؟ هي دي تاني مشكله عايزين نطلع منها. ليه انا شخصت كوريونستي؟ علشان انا عارف كويس جدا ان مشاكل المالتيبل بريجنسيز واحده للام، لكن البيبيهات مختلفه. بيبيهات مختلفه ايه؟ ان انا عندي ريسك للتوين ترانسفيوجن، عندي التابس، عندي السلكتيف الجروس ريستريكشن، عندي الديس اوف كو توينز، عندي التراب سيكولي. لازم الحاجات دي تكون فاهمها. دي هتحصل مع مين؟ مع الانستموزز. يعني ايه انستموزز؟ يعني يحصل مع المونو كوريونكس. اوكي. فلازم نمشي بسرعه. هنمشي بسرعه كده بسرعه. سيلكتيف اي جي ار. السيلكتيف اي جي ار يعني ايه؟ سيلكتيف اي جي ار يعني في بيبي واحد كويس وفي بيبي تاني كبير، في بيبي صغير ريلاتيفلي في ديسكوردنس في الجروس بتاعه، وده بيبقى اخف انواع الديسكريبنسي بين الكوريونستي، بيبقى فيه منيوت انستموزس بين البلاسنتي، بيخلي بيبي تاني يوصل له ايه؟ اقل دم، اقل من الايه الاولاني. يعني بيبي واخد بلاسنتا اكتر من التاني. هي دي الرسمه اللي انا عايز تعرف. والسيكولي بتاعك كويس بس اعمل فول اب. سهله كده. يبقى اللي هي اول حاجه سيلكتيف اي جي ار، دي بلاسنتا، هي بلاسنتا، ده بيبي خد بلاسنتا اكتر من البيبي التاني، فطبيعيا البيبي ده ايه؟ هيحصل له جوس ريستريكشن، لكن مش هيحصل له اوليجو هيدرامس. مش هيحصل له ايه؟ اوليجو هيدرامس. هو هيبقى بس في ديسكورتنس في الجراث، وده انتبه عادي جدا طول ما الامنيون والدوبلر فلو بتاعه كويس. اوكي. ان ده بيبقى ارتيريال انستموز فيري سنجل بس ارتري. طبعا في منه كلاسيفيكيشنز كتيره جدا، تايب 1 و 2 و 3، وده بيعتمد على الدوبلر فلو بتاعنا، اللي هو لو كان بريزنت او ابسنت او ريفرسد على حسب تايب 1 و 2 و 3. لكن في المانجمنت هو فول اب، مش محتاج اعمل حاجه الا في تايب 3. لو انا شايف ان البيبي دوت ممكن اعمل ليزر كواجيليشن زي توين ترانسفيوجن، وده اخف انواع المشاكل اللي ممكن تحصل مع الكوريونستي. مانجينج ذا سرفايفنج توين افتر ديمايز اوف اتس كو توين، ودي بتحصل لنا كتير. بنشوف في عياداتنا بيبي مات وبيبي عايش، هتصرف معاه ازاي؟ الحقيقه هتصرف مع السرفايفنج توين لازم ابقى فاهم ان الانسيدنس بتاعت المونوكوريونكس اعلى برضه من الدايكوريونكس، ولكن خلينا نوصل لنقطه مهمه، ان انا هتابع فول اب. موست اوف ذا كيسز هيبقى فول اب. ليه بقى؟ هي اللقطه اللي انا عايزكم تعرفوها. مفيش حاجه البيبي مات لازم اولد دلوقتي، احسن البيبي التاني يحصل له برين دامج. ليه؟ ان surviving twin may lose part of its circulation volume to the dead twin, potentially severe hypotension is survivor hypoperfusion. يعني ايه الكلام ده؟ يعني لما البيبي مات حصل severe hypotension للبيبي اللي عايش، انه كان بيعتمد على السيركيليشن بينه وبين بعض، فحصل دامج اوريدي عقبال ما تكتشف ان البيبي ده ديمايزد. البرين دامج للبيبي الاولاني خلاص حصل، لو كان حصل، لو كان السيكولي حصل. اوكي. فالهايبوبرفيوجن اوف ذا برين اند ذا اذر اورجانز which can cause brain damage or death. وبالتالي الريكومنديشن دايما ام ار اي، ان ايه؟ ان has of in if surviving twin suffers any neurological harm, this has often already happened by the time the death has been diagnosed. يبقى اول ما البيبي ده يموت اصلا انت اصلا هتكتشفه متاخر، هيكون حصل هايبوبرفيوجن، هيكون حصل برين دامج. فالترمينيشن immediately لازم يكون بالعقل. هو الترمينيشن دوت هينقذ حاجه؟ ما هو اوريدي لو في دامج حصل ما هو حصل، ومش هنكتشفه غير بام ار اي بعد 4 اسابيع يكون شفنا السيكولي بتاع البرين سيلز دامج. وبالتالي الكونزرفتيف مانجمنت از ذا ريكومنديشن. يبقى لو انت بتعمل ولقيت بيبي ميت وبيبي عايش، تشوف البارامترز البيبي العايش ده اخبارها ايه، والدوبلر فلو بتاعه اخباره ايه، والى اخره، ولكن مش محتاج immediate termination. دي النقطه المهمه. نتابع عادي جدا، ونتابع بقى الميدل سيبر ارتي دوبلر فلو بتاعنا، كل الدوبلر انديسيس بتاعتنا، وممكن نكونسيدر البيبي ده بام ار اي بعد 4 اسابيع وهو في بطن مامته، نقدر نشوف لو في برين دامج. خلاص، لو لقينا برين دامج ترمينيت، ما هو كده كده خلاص يعني ممكن بي كونسيدر، لكن طول ما هو ما وصلش للترم دونت ترمينيت. طيب التوين توين ترانسفيوجن طبعا اغلبكم حضراتكم عارفينها ان حصل كومبليت انستموزس بين بيبي وبيبي، بقى في بيبي دونر وبيبي ريسيبينت. البيبي دونر والبيبي ريسيبينت يعني في بيبي بيدي دمه وفي بيبي بياخد الدم ده. الدونر هيبقى انيميك، الدونر هيبقى اورجا هيدرامنس، البلادر بتاعته فاضيه. التاني ده يقول لك عليه حاجه اسمها ستاك بيبي. اما البولي هيدرامنس ده بيبي كبير، ده بيبي سوري الريسيبينت ده بيبي عنده بوليسايسيميا، بيبي كبير، بيبي الميه حواليه كتيره جدا، وممكن يخش في هارت فيلير، ممكن يخش في كارديو ميجالي وهارت فيلير بسبب هايدروبس. شايفين ده بيبقى اهو. علاجه ايه؟ خش بالفيتوسكوب ايكوال انستموز ما بين الايه، ما بين التو بيبيز. هو ده علاجه الوحيد. خلاص، لو ما عندكش الاوبشن ده هتضطر تعمل كونزرفتيف مانجمنت، لان كل شويه هعمل ايه؟ امنيون ريدكشن. شايفين الانستموزس بين الدونر والريسيبينت. خلاص، يبقى ايه الديسكوردنس توين جراس؟ ممكن يبقى سيلكتيف اي جي ار، وممكن يبقى دوت. الفرق بينهم ازاي؟ بولي هيدرا ده جود امنيون، ده هتلاقي فيه اوليجو هيدرامنس. طبعا في صور كتير جدا للستاك توين. ستاك توين يعني هو بقى سيفير اوليجو هيدرامنس. unpredictable طبعا ان احنا نشخص ده. طبعا في حاجه اسمها الكوينتيرو، كلنا عارفين ستيج 1 و 2 و 3 و 4 و 5. مش هتفرق معانا كتير قوي ان احنا نشخص ان البيبي ده فيه توين توين ترانسفيوجن عشان نقدر نتحرك بسرعه ونعمل فيتاسكوبي ونشوف المانجمنت according to the stage. طبعا لو اقل من 18 اسبوع نفضل نستخدم الليزر، او بعد 18 اسبوع ممكن نستخدم الباي بولر. ده شكل الفيتاسكوبي، ده شكل الفيتاسكوبي. اوكي، دي كذا داتا. شايفين ده بقى نورمال بلاد فوليوم بين التو بيبيز. طب الدونر والريسيبينت نفس البلاد بس البلاد فوليوم هنا اعلى، بس نفس الكونسنتريشن. ده هنا بقى اللي هي توين انيميا بلاسيميا سيكولي، ان البيبي بيدي دم بتاعه للريسيبينت للتوين بتاعه. ده اسمه تراب، او سوري تراب ايه تاب سيكولي. تاب سيكولي اللي هي توين انيميك بوليسايسيميا سيكولي، يعني بيبي بيبقى انيميك والتاني بيبقى بوليسايسيميا، بس نفس الفوليوم موجود، بس الار بي سيز هي اللي اختلفت. الفرق هنا ان ده ميجور كوميونيكيشن، ده مينيوت كوميونيكيشن. ده اسمه توين انيميا بوليسايسيميا سيكولي. وبرده المانجمنت بتاعته عن طريق الفيتاسكوبي، ونقدر نتابع طبعا عن طريق الميدل سيربرال ارتري دوبلر بالبيك سيستوليك فيلوسيتيز. طيب، واخر حاجه توين ريفرسد ارتيريال برفيوجن سيكولي، ان بيبي بيبقى بامب لبيبي تاني، بس بيبقى كاردياك، يعني ده ما عندوش قلب، البيبي التاني هو اللي عليه قلب بيدي للبيبي دوت، وده بيبقى فيه شويه اورجنز التراب دوت، وده بيكتشف بدري جدا ان بلاقي بيبي انكفالي ما عندوش راس تراب سيكولي. يبقى مشكلتي كله في المونو كوريونكس. شايفين المنظر ده؟ بيبي هو من غير راس ومن غير قلب، وبياخد البيبي من البيبي اللي بيديله، وده طبعا بيبقى عنده مشاكل كتيره. دي مناظر كلها كتيره جدا للامورفس هيدز بالتراب سيكولي، والاوت كام بتاعه طبعا بيبقى فيه ديمايز، وعلاجه الوحيد ان انت تعمل فوتو كواجوليشن او ليزر كواجوليشن او كورد اوكلوجن قبل 18 بعد 18 اسبوع، عشان نمنع البامبنج ان البيبي ده يزق الدم للبيبي التاني. في كونجوينت توينز طبعا كلنا عارفينهم، وده بيتشخص برضو بدري جدا. ده بيبقى سبليتنج بعد 13 يوم من الدوت، وبيكتشف عن 9 اسابيع. وطبعا عندهم مشاكل كتيره جدا وعملياتهم كتيره جدا وليها كلاسيفيكيشنز كتيره جدا، لكن اهميه الحاجات دي كلها مهمه ليه؟ عشان نوصل لنقطه ان انت تشخص وتعرف تعمل بروبر كونسلنج للمرضى اللي بيتابعوا معاك في الهاي ريسك. دي منظر كونجوينت توينز. هرجع اقول تاني المتابعه بتاعتنا لازم تبقى كل اسبوعين، وفهمنا ليه دلوقتي احنا ليه بنعمل دوبلر، عشان نقدر نشخص الديفرنت سيكولي بتاعه الكومبليكيشنز اللي ممكن تحصل من المونوكوريونكس according للار سي جي. طبعا في الجايد لاينز هي دي اللي انا عايز اوصل ككونكلوجن. اي woman with monochorionic twins should have the timing of birth and an offered elective delivery عن 36 اسبوع. اي عينه مونوكوريونيك ترمينيت عن 36 اسبوع. لو مونوكوريونيك داي امنيوتيك ما عندهاش اي كلينيكال انديكيشن فور سيزيريان سيكشن، ممكن ادي فاجينال بيرث اوبشن. اما لو هي مونو امنيوتيك عند 32 ل 34 اسبوع as long as انت عندك حضانه كويسه. in pref موضوع توينز ده هو هاي ريسك. اي عيان بتحمل توينز مع الريتس اللي عندنا كتيره جدا دي ممكن يحصل التوين بريجننسي. احنا بنتكلم في نقطه مهمه جدا قبل ما اسيبكم في المحاضره اللي بعديا، هي نقطه ان انت تبقى فاهم انا محتاج اشخص الكوريوناستي very important عشان المونوكوريونيك سيكولي ليه مشاكل كتيره زي التراب، زي التي تي اس، التوين توين ترانسفيوجن، زي السلكتيف اي جي ار، ممكن يحصل conjoints، ممكن يحصل cord entrapped around other baby في المونو amniotics. الحاجات دي كلها مشاكل ممكن تقابلني. الريكومنديشنز واضحه، تابع كل اسبوعين، ما تعملش سيركلاج. لو شخصت العينه مونوكوريونيك لازم هتكونسيدر ترمينيشن 36 اسبوع. لو انت شخصت العينه مونوكوريونيك مونو امنيوتيك هترمينيت عند 32 ل 34 اسبوع على حسب الكونديشن. الفيتاسكوبي حل حاجات كتيره جدا، بس محتاج طبعا تيرشري هوسبيتالز بناس بتوع فيتال ميديسن شاطرين، بس انت قاعد في عيادتك، فانت لو مالكش في الفيتال ميديسن قوي انت بيبقى فاهم على الاقل السيكولي اللي انت المفروض هتكونسل فيها البيشنت اللي بيعمل معاك فولو اب. اتمنى تكونوا استفدتوا من المحاضره ديت، وان شاء الله نلقاكم في محاضرات اخرى. شكرا جزيلا.
Hello and welcome back. Thank you, Professor Mahmoud, for this amazing lecture. And now we will know more about one of the most interesting topics that all of us we are interested about, like anemia in pregnancy topic, with our beloved Professor Rihab Bushama, Associate Professor. I let you with this amazing informative lecture. And if you have any question, just write in chat box, and when Dr. finishes her lecture, we'll answer about all your questions. And let's start. And please fill the attached link of certificate. If you wanna get your certificate, just fill it to get it after finishing the hub. Have a nice day. Hello and welcome, Professor Rihab. How are you? Everything is clear now? Okay, for doctors that ask about the certificate link, actually, I sent it again on the chat box. So please check the chat box and fill the link to get your certificate. Dr. Rahab will be with us within a few seconds. Okay. Hello and come back. Dr. Rahab will be with us after a few seconds. We'll speak about anemia in pregnancy. And there is a lot of people ask how it. There is another lecture. Yes, for sure. We will speak about the first and second trimester bleeding that happen during this period. Also, we will speak about renal disease in pregnancy from nephrologist perspective. We will have Professor Ahmed Sulaiman will speak about renal disease in pregnancy. He is nephrologist. Actually, as you know, that we know more about renal disease in pregnancy from Dr. Haneen, but that's from gynecological perspective. So what about nephrological perspective? And now Dr. Rihab Ushama with us.
Hello, how are you,
Dr.
Mariam?
Rihab Ushama, she's associate professor and gynecological at Fayoum University Hospital. Hello, Dr. Rihab. Do you hear us?
Yeah, I hear you well.
It's an honor to have you, Doctor, and thank you for your valuable time to join your knowledge with other doctors.
Hello, Mariam. Thank you. I really appreciate this opportunity to give such information, important one, to my colleagues. Assalamu alaikum wa rahmatullahi wa barakatuh. I hope you are all well. I am Dr. Rihab Abdelhamid Abu Shama, Assistant Professor of Obstetrics and Gynecology. I will just talk to you today for anemia in pregnancy, for screening and clinical management strategy. الأنيميا من أكثر المواضيع المهمة جدا بالنسبة لكل البريجنسي. We are all having antenatal care, okay, for everybody. Antenatal care, one of the most important things to discover anemia, discover early complication for the patient and the fetus. Our agenda today: introduction, definition and the prevalence, pregnancy changes, iron deficiency anemia as it is the most important and the most common one, the investigation needed, and other type of anemia. Introduction. Anemia is one of the most common hematological abnormalities with the reduction of the concentration of the erythrocyte or the hemoglobin in the blood. It is defined by the VIGO to be less than 11 grams per deciliter at any time in pregnancy, or defined by CDC Center or Center for Disease Control and Prevention, or WHO or the American College of Obstetrics and Gynecology 2029 to be hemoglobin less than 11 during the first and the third trimester, or less than 10.5 in the second trimester. So it is mainly 2p less than 10.5 in every trimester. Severity of anemia is defined by the grade of the hemoglobin concentration. Mild degree is from 10 to 10.9, moderate degree from 7 to 10 grams per deciliter, severe less than 7, very severe degree of anemia less than 4 grams per deciliter. It may lead to congestive heart failure, maybe maternal death. It's very important so to diagnose anemia and to treat it early. First, here in Africa and Asia, in low and middle economic countries, it's found to be 50 to 80% of pregnant women having anemia. But with pregnancy, there is always physiological anemia. There is a normal change that occurs during pregnancy. We should distinguish maybe mild thrombocytopenia found in pregnancy. Physiological anemia. Increased by 33% only. So the difference between the 50 and 30% make a dilutional physiological anemia start from 7 to 8 weeks, maximum to be 32 weeks, and it doesn't go below 11 grams per deciliter. To increase infection as severe of anemia less than 4. Postpartum hemorrhage as it lead to impaired uterine contractility. Anemia lead to increase in blood loss, maybe lead to maternal death, puerperal sepsis, postnatal depression for the woman that can't do any work, weakness, failed lactation. يعني بالمعنى العربي ان العيانه بتاعتنا بتبقى صحتها صغيره على قدها جدا، تعبان، fetal risk upgrade of neonatal anemia, perinatal mortality, and impaired cognitive and language development. But there is no evidence at all that increased risk of congenital malformation or congenital anomalies of offspring. So anemia, there is no risk for the fetus to be congenitally malformed. Causes of anemia during the pregnancy. One of the most important causes
Hello. Hello again. Dr. Hab will be with us after 1 second. Just the just technical issue. We will solve it just 1 or 2 minutes, and Dr. Hab will join us again and complete this informative lecture. Hello again. There is some questions in chat box. I'll answer about it. How can we get the lectures? Actually, after finishing the lecture, you will find this hub, pregnancy-related complication hub, on the YouTube. If you miss any lecture, you will find it again, but for short term. And actually, then we will release it again in the specific time. So if you wanna see this hub or another hubs, actually we made a series of hub about one hub about IVF EGRI, and another one for laparoscopic. So all these hub, actually you can find it in our YouTube channel or our website. Also, we re-release these hubs again, so just follow up the Facebook the page and you will know the dates. And actually there's a lot of medical representative will reach you and give you all updates. That's it. If anyone has any questions until Dr. Rehab joined us again, you can write in the chat box. And I'm here to answer any questions that you want. Okay, there is a question here, told me how can we join other hubs. Actually, we have a lot of hubs. There's hubs on YouTube channel, and we made a lot of hubs, and we made re-release for it again. Actually, we made the re-releasing from few days. So just follow up the American Association page to know when we will release other hubs and the previous hubs. And all hubs that you will attend, you will get certificates. If the webinar ended or begin now, actually the webinar began from 12 p.m. And now we just take 1 to 10-minute break until Dr. Rehab get the internet connection again. Okay, I think that I answered about this question. How can we get the certificate? Actually, I sent you a lot of the link for the hub. You can this link for certificates, you must fill the link, and actually you will receive your certificate via mail. Okay. If any doctor has any question, that's your time now. I'm here with you to reply about all your questions until Dr. Rehab get restored again her connection.
Okay. Okay, sorry for interruption. The two most common causes of anemia in pregnancy are iron deficiency anemia and acute blood loss. So iron deficiency anemia, it is one of
Hello, how are you? Sorry for internet issue. We will continue our lecture. The two important causes of anemia is iron deficiency anemia and the acute blood loss. I think you heard it more than once from me. Now we are going to iron deficiency anemia. It is responsible for 95% of anemias during pregnancy. So it is very important to diagnose it. During the first half of the pregnancy, the iron requirement is not increased significantly, but in the third and the second, it is increased approximately to have the requirement of the pregnancy. Causes of iron deficiency anemia: physiological, during the pregnancy and during childhood, or due to blood loss, menorrhagia, inflammatory disease, peptic ulcer, GIT malignancies, blood donation, as increased demand, as the body need more iron to form the heme product of the hemoglobin. Poor intake, vegetarian diet, poor absorption, the patient who have gastric bypass to decrease the body weight, gastritis and GERD, Helicobacter, antacids, and proton pump inhibitor, high caffeine consumption, one that decrease the availability and decrease the absorption of the iron. So iron decrease or increase the demand, one of the most common causes for iron deficiency anemia. The requirement during pregnancy: 1,000 grams is needed during the pregnancy, 300 only for the fetus and the placenta, 500 for the expansion of the maternal hemoglobin as the red blood masses increase, 200 is lost during the gut and the urine and the skin. So all of the component is 100 grams needed through all the pregnancy. Requirement: the patient should have taken iron 3 milligram per day in single term pregnancy and 16 milligram per day in twin pregnancy, 13 milligram elemental. This is the daily vitamin requirement during the pregnancy: calcium and iron and iodine and colchicine, vitamin A, vitamin C. The iron here is written to be 27 milligram. Daily requirement elemental to be really absorbed in the body. It can be taken from meat and fish, dried beans. It is better to be taken from red meat. The clinical manifestation of iron deficiency: it may be asymptomatic. It can be missed well in any patient. The symptom may be vague, non-specific, including pallor, easy fatigability, headache, palpitation, tachycardia, and dyspnea. We could say it as normal pregnancy symptoms. ممكن طبعا ناخدها على ان هي pregnancy symptoms العاديه جدا بالنسبه لاي حامل، وما نبقاش عارفين ان كانت هي الفيرست symptom of anemia or symptom of the pregnancy. Angular stomatitis and glossitis and spoon nails may be present in long-standing severe anemia. So the same symptom may be found when there is a low serum ferritin, when the patient is not anemic. So hemoglobin concentration should be done and measured routinely at the first booking appointment at 28 weeks. So it is important to do during antenatal care, first appointment to do CBC. لازم نعمل لكل عيانين في الفيرست antenatal care first CBC عند 28 أسبوع نعمل CBC جديد. This is by the Royal College and the American Association of Obstetrics and Gynecology 2029, one of its recommendations. The standard test for anemia, it includes complete blood count. We will find a low hemoglobin, low mean cell hemoglobin, low cell volume hemoglobin, low hemoglobin concentration. The peripheral mean, we will find microcytic hypochromic red blood cell, and we will see it in the picture now. Serum ferritin will be low. Total iron binding capacity will be high. Serum ferritin less than 13 nanogram per millimeter indicate reduced storage of the iron. This is the standard test for the diagnosis of iron deficiency anemia. This is the lab. This is the cell. We will find that here, presented by the arrow, hypochromic microcytic cell, microcytic hypochromic. Serum ferritin less than 15 microgram, transferritin saturation less than 16%, one of the most common causes, one of the most common lab finding in iron deficiency anemia. How to prevent this anemia? How to prevent complication of anemia on the fetus and on the mother? Correct way of intake: empty stomach, an hour before meal. We can take vitamin C as it increases its absorption. Avoid taking with antacid. Heme iron, it is one of the most common iron that be absorbed well. Red meat, fish, vitamin C. Avoid iron absorption inhibitors. All the pregnant women should take intermittent supplementation of iron, at least 13 milligram per day, starting from the first antenatal The management will begin with iron oral therapy by the ferrous sulfate. It is the most common form of iron supplementation, or parenteral iron intolerance or refractories to iron therapy, or erythropoietin in addition to erythropoietin to iron therapy to increase and rapid correction of the anemia. Lastly, pipe blood transfusion in patients with such operative delivery or postpartum hemorrhage or woman with evidence with active bleeding should have a blood transfusion. Hemoglobin less than 10, iron deficiency anemia. This diagram will tell us what to do in a patient with hemoglobin less than 10 or anemic patient. Oral iron therapy, inadequate response to oral iron therapy, inadequate in compliance, oral therapy intolerance. When the hemoglobin less than 8, need a more correction by intravenous iron therapy. Management. Ferrous sulfate is preferred than ferric, as it is more absorbed easily than ferric sulfate. The available form: ferrous fumarate, ferrous sulfate, ferrous gluconate. Parenteral ferrous fumarate 210, it gives us 65 milligram elemental iron. Ferrous gluconate, it will give us 35 milligram elemental iron. Ferrous sulfate, it will give 65 milligram elemental iron for the patient. So we will choose the form that will be available for the patient to treat its anemia according to its severity. Treatment duration. We will have to ask the patient about the response, improve the feeling of well-being, decrease weakness, appetite change. Hemoglobin rises slowly within 1 to 2 weeks, and it will be rise 2 grams over the 3 weeks. Hemoglobin deficit will be halved, inshallah, in 1 month. Return to normal by 6 weeks. Tongue change improve in weeks. Limitation to iron supplementation or side effect. Between 10 and 40% taking oral iron supplementation, gastric intestinal disease, constipation, and gastric irritation and nausea. Some of the patient doesn't continue the treatment because of this side effect, disturbed bowel function, the gastric irritation, the metallic taste, the constipation. So the course will not be completed and the patient will not be compliant to the oral therapy. So we'll have to go to the IV therapy. Once the hemoglobin, if the patient is good response, once the hemoglobin is normal, continue an oral iron for 3 months until the last 6 weeks postpartum to replenish the store. يعني معناه بالعربي ان احنا بنبدا التريتمنت اورال للمريضه بتاعتنا. Once she's feeling good, we will continue on the treatment for at least 3 months as the stores of the iron will replenish after 3 months, inshallah. If the patient doesn't comply with the treatment and she can't withstand the complication of the side effect of the gastric sensation or the constipation or the side effect, we will go into oral IV therapy. If no response, we will go to another treatment. Failure of the iron therapy, non-compliance, malabsorption, coexistent folate or vitamin B12 deficiency, or copper deficiency, medication interfering with the absorption like antacid tetracycline. Patient is not iron deficiency like thalassemia. It is not the cause. Inflammatory disease, allowing to decrease its absorption even though she is taking the treatment well. Contaminant malignancy, bone marrow suppression. It is the main cause of aplastic anemia. So renal failure or malignancy, one of the causes that have to failure of the oral therapy. So after that, after failure of the oral therapy, you can give parenteral iron. No preparation FDA approved, as it may have a great complication for the patient if it is not used in the hospital. Mainly used if severe anemia, hemoglobin less than 8. Diagnosed iron deficiency anemia by 134, and we need to deliver the patient. When confirmed iron deficiency anemia. Failure of compliance, inflammatory bowel, she can't absorb. She is taking the treatment, the bowel will not absorb the iron. Chronic kidney disease, decreased erythropoietin, cancer patient, heart failure, chronic blood loss, she will need a rapid anemia treatment. Contraindication of parenteral iron therapy, history of anaphylaxis, serious reaction to parenteral iron therapy, First trimester in the pregnancy, iron overload. The patient is thalassemia and I didn't diagnose it well. So it is contraindicated to give parenteral iron. Acute and chronic bacteremia, decompensated patient, asthma or eczema or atopic allergy, as it will be allergic to parenteral iron, more liable to allergy or anaphylactic shock with IV iron. Preparation, there is a lot of preparations found in the market. Ferry engine, أو monofare, cosmofare, one of the most common ones is dextran, iron saccharose, venofare. One of the most common complications is anaphylaxis. So all IV iron preparation should be administered in a setting in a hospital, in a place where there is a resuscitation facilities. Trained staff are present. The patient should be observed for the adverse effect at least for the first 13 minutes. When the patient comes to you in the clinic and say, I will have iron in the home, tell her no. The iron IV will be taken in the hospital. Resuscitation place is very important. Even though the first time, if she have taken before, there is no anaphylaxis, the second time she can have anaphylaxis. بمعنى أصح إن المريضة ممكن تبقى خدت حديد قبل كده, أي IV iron supplementation, and she didn't have any allergy أو anaphylaxis, any side effect, she can have it in the second time. So it is preferred to be in the hospital, not in any place. How to calculate the iron dose? The maximum single dose will be 20 milligram per kg or 1,500 milligram, whatever is lower. The total cumulative effect is the limit divided by 2 doses. هنحسب الدوز بالنسبة للمريضة, الماكسيمم دوز بتبقى 20 milligram per kg. Then if it is more than 1,500, it will divide it in 2 doses. وناخد البارت بينهم 1 week, not like other doctor do, 1 ampoule every 1 another day. It will not efficient for the patient. بنحسب الجرعة totally, then divided it لو هي أكتر من 1,500 milligram for the patient. Main causes of chronic anemia. We have just talking about iron deficiency anemia. It is called nutritional anemia. Then there is another, folate deficiency and chronic hemolytic disease. It is the most common causes in pregnancy. Folate, it is, and coplamine deficiency. Microphthalmic anemia, elevated iron, indirect bilirubin increased, LDH increased, reticulocyte is increased. Occasional megaloblastic cell. The cell like this one, it is large, hyperchromic cells. Macrocytic, mean volume of the cell, أكتر من 100. Treatment of this patient is folic acid 1 milligram per day and vitamin B12 1,000 milligram per day. It will be good for the patient for the treatment. Hemolytic anemia. What is meaning of the hemolytic anemia? It means shortening the red blood cell survival. It means destruction of the red blood cell. It means that it lives than 100 days. It is similar response to acute blood loss. Hemolysis means incompletely hemolyzed red blood cells, which lost some of this membrane. It changes the shape, it changes the component of the red blood cell. It includes sickle cell anemia, thalassemia, which may be alpha and beta thalassemia, red cell membrane disorder, hereditary, like spherocytosis, hereditary spherocytosis, and hereditary exocytosis. This is the types of the hemolytic anemia. It may be inherited membrane defect, hereditary spherocytosis, one of the most common one, enzyme defect, G6PD, hemoglobinopathy like sickle cell anemia, autosomal recessive disease, or acquired immune-mediated alloimmune hemolysis أو autoimmune hemolytic uremic anemia أو non-immune-mediated anemia. Character of the hemolysis: rapid onset of pallor and anemia, jaundice, history of pigmented gallbladder stones, splenectomy, the patient have a previous history of splenectomy, presence of circulating spherocytes, increased serum lactate dehydrogenase, direct antiglobulin test, COMBIS test is positive, increased reticulocytes, indicating that bone marrow response to the anemia. Some of these patients are well known to be thalassemia or sickle cell anemia. It is diagnosed before pregnancy. Some of them is not diagnosed if it is just a triad or a carrier patient for thalassemia, it will be diagnosed during pregnancy. Thalassemia or hemolytic disease or chronic hemolytic disease, it is mostly diagnosed during infancy and childhood. So the patient know that she's thalassemia, سواء beta أو alpha thalassemia, أو sickle cell anemia أو spherocytosis. Even though some of them, they are not discovered except if we are treating anemia and it will not respond only. Diagnosis will be on CBC, it will be microcytic hypochromic, and also in serum ferritin, we will find it a very high serum ferritin. Also, hemoglobin electrophoresis is one of the most common ways to diagnose type of hemolytic anemia. Hemolytic anemia treatment. No generic treatment for hemolytic anemia. Treat the underlying cause, transfusion if the anemia is severe. Anemia. Anemia due to hemorrhage. Hemorrhage during labor. Hemorrhage during early third trimester, early first trimester. If the patient is still in risk, give packed red blood cell, even if the hemoglobin is less than 10 gram per deciliter. No risk of bleeding. Packed red blood cell will be given less than 8. يعني معنى كده ان العيانه لو هي in bleeding now وهيموجلوبين بتاعها 10, give her blood transfusion as she will continue and the anemia will appear later. If the patient there is no risk of bleeding now, we can give blood transfusion less than 8 gram per deciliter. Role of blood transfusion during pregnancy. Routine prophylactic blood transfusion, it is not recommended during the pregnancy for women. If acute exchange blood transfusion is required for sickle cell complication, is appropriate to continue the regimen of the treatment. Blood transfusion should be matched for the patient, and it is for acute bleeding or disturbing the life of the patient or the baby. Screening for anemia. It is recommended by the American College of Obstetrics and Gynecology from the first trimester, complete blood cell count. Based on the initial result, we will have to do a clinical management and subsequent investigation for the another causes. A second screening is recommended between 24 to 28 weeks of the pregnancy by the American College of Obstetrics and Gynecology. Thank you.
Hello and welcome back. Hello and welcome back, everyone. Thank you, Dr. Rehab Abu Shama, for this informative lecture about anemia in pregnancy. I know that's one of the most important topics. Now, if anyone has any question related to Dr. Rehab, can ask her and she will answer. And now we will continue our hub. Actually, we are nearly to close the hub, but there is two important topics that we will speak about. First and second trimester bleeding. Bleeding during first and second, third trimester, that will be introduced by our beloved Professor Ibrahim Fauzi. And the last topic that we will speak about, the renal disease in pregnancy from nephrologist perspective. So I'll let you now with one of the most important topics, the bleeding during the first, second, and third trimester. So let's start our lecture.
Good afternoon or good evening, doctors, according to when this will be recorded. My name is Dr. Ibrahim Fawzi. I'm a lecturer and the consultant of obstetrics and gynecology at Cairo University. I'm honored to be a part of this beautiful scientific hub, and I want to thank the American Association for allowing me to participate in it. My talk will be in about 20 minutes, I think. We will talk about bleeding in pregnancy, and we will focus on bleeding in early pregnancy. What is bleeding in early pregnancy? It means any abnormal bleeding in the first 20 weeks of gestation, in the first half of pregnancy. Basic knowledge, bleeding could be due to a non-pregnancy related cause or a pregnancy related cause. Non-pregnancy related causes could be a non-gynecological causes or a local gynecological causes at the genital tract. Non-gynecological causes including any bleeding tendency in general or defect in the coagulation profile or defect in the platelet function or number of the patient. Local gynecological cause means that there is a local cause in the genital tract that causes the bleeding. For example, cervical erosion, polyps, or cervical cancers. What we are going to focus upon are the pregnancy complications that lead to early pregnancy bleeding, which are miscarriage, ectopic pregnancy, aka extrauterine pregnancy, and gestational trophoblastic disease, whose older name was molar pregnancy. Of course, some pregnant women may experience slight recurrent bleeding at the time of blastocyst implantation. It's called Hartmann sign, and it's perfectly normal as the pregnancy in some animals. This happens. The pregnancy complications that lead to bleeding in early pregnancy, the first and the far most common is the miscarriage, or the previous name that was called abortion. It means pregnancy loss before viability, and the age of viability is the age at which there is a reasonable chance for the fetus for subsequent extrauterine survival under favorable conditions. And the age of viability depends mainly on the facilities provided by the ICU, by the neonatal intensive care units at the establishment that we're working in. And the age of viability is determined in the country, in each country. In developing countries, it ranges between 24 to 28 weeks. And in the US, it's about 20 weeks of gestation, at which the fetus will weigh about 500 grams. The term abortion means induced termination of pregnancy, whereas the term miscarriage is used for spontaneous pregnancy loss. So when we are describing the spontaneous pregnancy loss, we're using the term miscarriage, and when we are describing an induced termination of pregnancy, we will be using the term abortion. And the American College of Obstetricians and Gynecologists in 2019 described a newer name or nomenclature called early pregnancy loss, which means a non-viable intrauterine pregnancy within the first 12 weeks of gestation. This non-viable could be an empty gestational sac or one with an embryo or even a fetus without a fetal cardiac activity. And what is the definition of the recurrent pregnancy loss? It means repetitive miscarriage. Some guidelines mention that 2 repetitive miscarriages, and some guidelines mention that the recurrent pregnancy loss is defined as 3 subsequent miscarriages. And basic knowledge again, the spontaneous miscarriages, they are categorized into 5 main categories: threatened, incomplete, complete, missed, and inevitable miscarriages. And what is meant by septic miscarriage or septic abortion? Any of the above of the previously mentioned ones could be complicated by infection. What is the incidence of miscarriage? About 12 to 15 of the clinically recognizable pregnancies, which means that 10 to 15% of women who knew that they are pregnant, their pregnancy will end up in a miscarriage, which means that the incidence itself is a bit higher in women who had no idea that they were pregnant in the first place. Although some cases of the spontaneous abortion are symptomless, the main symptoms of miscarriage, and the classic teaching told us that the combination of bleeding and pain which happens earlier. The bleeding happens first, and then comes the pain. Unlike what we're going to discuss in the extrauterine pregnancy. What are the main causes of spontaneous miscarriage? The first and the far most common cause is chromosomal abnormalities within the embryo itself. It constitutes more than 50% of cases, and it happens in a sporadic way and not in an inherited way. So the first cause and the far most cause of spontaneous miscarriage is the fetal chromosomal anomalies. And aneuploidy is the most common chromosomal anomaly that leads to miscarriage. Other causes could be an inherited disorder or a fetal structure anomaly that could be major enough to cause fetal death. Certain fetal congenital infections can even cause fetal loss. What are the maternal causes of miscarriages? Either uterine causes, immunological causes. The most common is the antiphospholipid syndrome or any other immunological diseases at which antibodies are formed against the fetal tissues. Severe trauma, whether external or internal, and the least common is the maternal chromosomal factor. Sometimes the maternal or there are chromosomal anomalies or chromosomal abnormalities in one or both parents that could lead to miscarriage, and in that case, it will lead to a recurrent pregnancy loss. Lastly, some drugs are teratogenic. This is a diagram showing how aneuploidy happens. The number of chromosomes. The problem is the number of chromosomes, either monosomy, which is like a chromosome missing, or trisomy, which is a chromosome extra chromosome. This is how they are inherited. And unlike the chromosomal abnormalities in the mothers, where it happens in a repetitive way that causes recurrent pregnancy loss. What are the types of spontaneous miscarriage? As we said, the categories. The threatened miscarriage basically means that the woman has pain and bleeding while the cervix is closed and the pregnancy itself is intact. I mean that the pulsations or the cardiac pulsations are still evident. It happens in a very high percentage of pregnant ladies, almost 25 to 50% of ladies. And we diagnose threatened miscarriage via the ultrasound and just expectant management, and they assured the lady 50% the pregnancy will continue, and 50% it might end up in full miscarriage. Inevitable miscarriage, basically the cervix is open. So the main difference between them is whether the cervix is opened or closed, and you can identify if it's opened or closed. The classic way was by the digital examination, but recently with the advances in the ultrasound and the imaging techniques, the transvaginal ultrasound approach can be much more helpful in determining whether the cervix is opened or closed. What is an incomplete miscarriage? It means that the part of the products of conception are expelled, and there are still remnants of conception inside the uterus. And you can diagnose it by ultrasound and also by digital examination. Complete miscarriage is a miscarriage that happened already, and when the lady presents to you or presents to the clinic, you will find the normal uterus, and the uterus is empty, and the cervix is closed, and nothing more to be done. And of course, the most common type of miscarriages, which is the missed miscarriage, it means that there happened a death of an embryo or fetus, but it is retained within the uterus without expulsion, and the cervix is still closed. The condition may be symptomless at the start, but after some time, some vaginal brownish discharge will happen, and it could turn into an inevitable miscarriage later on. Septic miscarriage basically is any type of miscarriage that's complicated by infection. The most common organisms to cause septic miscarriage are beta hemolytic streptococci, staphylococci, and Clostridium welchii. If you suspect a septic miscarriage, you have to isolate the patient. You will diagnose it from the history, from the pain, the bleeding, and the fever. By examination, the uterus will be tender, subinvoluted. By investigation, the lab results would show signs of bacterial infection in the form of increased total leukocytic count and elevated C-reactive proteins. And by ultrasound, you will find the retained products of conception. What should be done in a septic miscarriage? First and foremost important is to isolate the patient, start the antibiotics, and then after that, you can use either medical or surgical methods of evacuation. What we should learn from this point is that you have to use both arms at the same time, the antibiotics and the ecbolics. If left untreated, septic miscarriages could lead to septic endometritis, which could lead to infertility later on, and the septic focus itself could lead to septic shock and spread of infection elsewhere, which might end up in mortality. So the general considerations in the miscarriages: an inevitable miscarriage with excessive blood loss and signs of hemorrhage should be managed by immediate resuscitation. You should not just focus on the miscarriage itself. You should focus on the lady as a whole. An incomplete miscarriage that is infected, aka septic miscarriage, could lead to death. A prolonged second trimester intrauterine fetal death, or first trimester if the death of the embryo or the fetus was diagnosed since like more than a week. You should follow up the patient with the fibrinogen degradation products, the INR, and the coagulation profile in order to know early evidence of any coagulopathy. And point number 4, any non-sensitized Rh negative patients whose husbands or whose partners are H positive, they should receive immunoglobulin, anti-D immunoglobulin. The doses are different according to the age and according to the actual circumstances of the miscarriage. But the idea is that you should always put in mind to test for the Rh of the lady in order to give her the anti-D in the proper time. Always post-abortion or post-miscarriage counseling should be offered to all couples. Miscarriage can be devastating, both physically and emotionally, to couples. So they need proper counseling. You should talk to them. You should tell them what are the options, what happened, and what to expect later on. Diagram showing the difference between the inevitable and the threatening miscarriage. If the cervix is open, it's inevitable, or if it's closed, it's a threatening miscarriage. The difference between incomplete and complete miscarriages and miscarriages. And of course, you can have the presentation upon asking. To diagnose miscarriage, there are different techniques. This is a diagram for an endometrial cavity with the produce perception, an incomplete miscarriage. Another one with no fetal pulsation, the embryo the cardiac activity is absent. Basically, in order to diagnose, the first thing you have to do no harm, as we all did our Hippocratic oath. So you can miss or you can postpone a diagnosis for miscarriage, but you cannot diagnose a healthy pregnancy as being a miscarriage. And the guidelines, both the Royal College guidelines and the American College guidelines, state that in order for you to diagnose a miscarriage at the initial visit, you have to see a mean sac diameter, a gestational sac, and its mean sac diameter is more than or equal to 25 millimeters, with nothing inside. Or if the embryo or the fetal pool is evidence, the crown lump length should be more than or equal 7 millimeters without evidence of fetal heart activity. And if your findings are close to boundaries, you can ask a second opinion, or you can just repeat the scan after 7 days, as most clinicians do. You see, this is a sac more than 25 millimeters. You can diagnose the miscarriage or early pregnancy loss at the initial visit. And if the crown lump length is more than 7 millimeters, you can diagnose the miscarriage at the initial presentation of the lady. But if they do not meet the criteria, for the case on the left side, the sac is still less than 25 millimeters, and on the right side, the crown lump length is less than 7 millimeters. What is the diagnosis? It's called intrauterine pregnancy of uncertain viability. It means that you cannot be certain if it is viable or not. The second cause of the early pregnancy bleeding. The pregnancy-related causes, of course, is the ectopic or extrauterine pregnancy. Basically, it's defined as implantation outside the normal endometrial cavity. The most common place is the fallopian tube, and the most common place within the fallopian tube is the ampullary part, because this is where fertilization happens. And with the advances in the assisted reproductive techniques and the advancement of maternal ages, the incidence of ectopic pregnancies increased in the last years, and you can see some special places where the extrauterine pregnancy could happen, including the ovarian, extrauterine pregnancy, the cervical, the abdominal, and cesarean scar pregnancies. And the most common place, as we said, is the fallopian tube itself. But with the increase in the rate of cesarean scars, we can see we are now seeing cesarean scar pregnancies. The incidence of them is getting very high. And the presentation of the ectopic pregnancy is very close to that of the of miscarriage, but classic teaching said that pain happens first and then bleeding. Unlike miscarriage, where bleeding happens first and then pain. Because in the miscarriage, the sac or the embryo or the fetus is detached from the endometrial cavity and then expelled, whereas in the ectopic pregnancy, the cause of the pain is usually when it is disturbed, and then bleeding happens after the expulsion of the residual cast. How to diagnose extrauterine pregnancy? Classic teaching says that extrauterine pregnancy or ectopic pregnancy its diagnosis is based mainly on suspicion. You need to have a high index of suspicion in order for you to diagnose it properly. So it's a mix of both clinical and laboratory investigation, and of course imaging. What is used is the quantitative beta HCG level, and there is something called the discrimination zone. It is above a certain zone determined by the establishment that you're in, which is 1,500 milli international units per milliliter for the transvaginal sonography, and 6,500 milli international units per milliliter for the transabdominal. This is called the discriminatory zone, above which you should always see an intrauterine pregnancy. So if the level is more than those levels, and you cannot see an intrauterine pregnancy, it's called a pregnancy of unknown location, and you have to look with the ultrasound machine where the pregnancy is happening. And if you cannot see it, then you will go for laparoscopy in order to find the exact site of the extrauterine pregnancy. If the level of the beta HCG is below the discrimination zone, you have to repeat the level again after 48 hours and see how the level is changing. Or it could be either falling down and this is a miscarriage, or it could be doubling and it's a healthy pregnancy, early healthy pregnancy, or it could be increasing but in less than 66%, which means that it's an unhealthy pregnancy, aka extrauterine pregnancy. So, can ultrasound diagnose all types of ectopic pregnancies? The answer is definitely no. It can these findings can be seen in certain percentages of extrauterine pregnancies only. You can see an inhomogeneous adnexal mass in 60% of cases, an empty gestational sac, it's called the Bagel sign or a Donald sign, or you can see the sac itself with a cardiac activity, but only in 20% of cases. On the figure on the left, you can see the inhomogeneous mass, and the right, you can see the Bagel sign. It resembles a bagel or a donut, and if you use, it's a bit risky. If you push the transvaginal probe between the ovary and this mass, you'll find that they are not moving together. This mass is not originating from the ovary itself. You will have something called a positive sliding sign, but this could be dangerous because you can actually lead to a disturbed ectopic pregnancy. And this shows hemoperitoneum or an internal hemorrhage within a lady whose pregnancy test is positive, because you should always be suspecting disturbed ectopic pregnancy. On the left, you can find this. You can see the sac itself, and you can see the different echogenicity from the ovary. And on the right side, you can see the endometrium, which is empty and surrounded by blood or free fluid. The management depends on many aspects. You can either do expectant management if the beta HCG level is falling down, you can do a medical management with methotrexate or a surgical intervention. When to do which, it's a matter of perspective. So basically you want to save the tube unless it is permanently damaged. So if a disturbed ectopic pregnancy, it means you have to go for surgery. But if it is a non-disturbed ectopic pregnancy, you can have all the options. There are no certain criteria or certain factors that indicate you want to use the medical management. But of course, there are certain parameters that, if found, can lead to higher success of the methotrexate. Methotrexate is basically a chemotherapy, a chemotherapeutic agent. It prevents the mitosis or division of cells based on the purines and the pyrimidines and the division. As you can see here, there is no actual limit, but if the sac is closed or the mass is small and the level of beta HCG is low and there is no fetal cardiac activity, the success rate of the methotrexate is higher. The regimens of the methotrexate, either single dose or multiple doses, depending on the follow-up of the beta HCG level. And if you're going to do surgery, you can either do it laparotomy or laparoscopy. But since the development in the laparoscopic skills of most surgeons now, so the first line is definitely laparoscopic management in the surgical part. Some of the special cases of ectopic pregnancies are the cervical and cesarean scar pregnancies. Cervical ectopic pregnancy, if you attempt to evacuate it, you will get an incredible amount of bleeding, which could lead to the patient's death. You should diagnose it well before any intervention. And options for management, either medical management or transcervical aspiration or even hysterectomy if the ectopic pregnancy its size is big. It could lead to life-threatening vaginal bleeding. In the cesarean scar pregnancy, either medical management with methotrexate as well, or you can do it laparoscopic management or hysteroscopic management, and even hysterectomy is the final resort if needed. The image of the cervical pregnancy, you see the endometrial cavity on the left side is totally free, and the cervical cavity or cervical canal is dilated, and you can see the sac implanted within it. Same case on the right side, different images, all of them are very, very, very evident. You should always be doing the transvaginal examination yourself, should evaluate it properly, shouldn't be underestimating it. And if the main differential diagnosis, if it is a cervical miscarriage or a cervical ectopic, you can either use the Doppler technique or you can slowly slide or push against it, just very slowly. If it is sliding, so it's an ectopic pregnancy that is about to be expelled. If it is sliding, I mean it will be a miscarriage case. If it is not sliding, if it is adherent, then it is definitely a cervical ectopic pregnancy. This is the case for which hysterectomy is done. And with the laparoscopy, you can see all different types of ectopic pregnancies, and the laparoscopic view is quite fascinating. The third and the last cause of the early pregnancy bleeding causes that is related to pregnancy is definitely the gestational trophoblastic disease. Classic teaching used to tell us, or professors used to tell us, that it was called just molar pregnancy. But with the updates and the recent development, the newest classification of the gestational trophoblastic diseases that was published in the American Journal, it is divided into molar pregnancy or molar diseases or non-molar diseases. Molar diseases, they are either complete mole or partial mole or invasive moles, and non-molar pregnancies, which is basically the gestational trophoblastic neoplasia, including the gestational choriocarcinoma, the placental site trophoblastic disease, and the episerioid trophoblastic disease. Each type is histologically different than the other, and all of this entity, they produce the human chorionic gonadotropin. which can be used as a tumor marker, and it can be used also as a surveillance method after termination or after management. The main difference between a complete mole and a partial mole is how the pathology itself is generated. With a complete mole, it's basically either one sperm that can fertilize an ovum at which the chromosomes are not functioning, so the chromosomes of the sperm itself can multiply, or two sperms within one ovum. In a partial mole, the chromosomes of the ova are functioning, so when two sperms fertilize it, you get a triploid number of chromosomes. What is the main difference between them histologically? And you can see the difference in the follow-up and outcomes. The rate of the subsequent gestation trophoblastic neoplasia in a partial mole is much less than in a complete mole. The level of the beta HCG in the complete mole is definitely higher than the partial mole. In a partial mole, you can find fetal tissue, but in a complete mole, there are no fetal tissue. As we said, the complete mole is formed by the duplication of the DNA of one sperm, resulting in a 46XX karyotype, or two sperms that could be a 46XX or a 46XY. Whereas partial moles, they are formed by fertilization of one normal ovum by two sperms. You can see them, they're like grapes, the chorionic villi. And how do they present? Definitely, they present by bleeding. And with the advances in the ultrasound and the imaging techniques, most cases of the gestation trophoblastic diseases can be diagnosed very early in pregnancy before even complications happen. Partial mole, basically a vesicular mole or a molar pregnancy with a structurally abnormal fetus. This is the image of the partial mole and the complete mole. The classic teaching says that it has the snowstorm appearance. Look at the placenta, you can see the cystic changes within them. And it is also evident in the complete mole as well. The level of the HCG, which is very high, can cause the ovaries to produce thecal lutein cysts, and they will resolve on their own after the proper management of the disease itself. So the first and the foremost line of management for the molar pregnancy is to evacuate that uterus before complications happen. What are the types of complication? Different types of complication can happen with molar pregnancies, including hypertension, preeclampsia, hyperthyroidism, hyperemesis. You name it, and it will happen with a molar pregnancy. So the sooner you evacuate it, the better the outcome for the patient. And you should be always evacuated with suction evacuation and not with the surgical one, in order not to perforate the uterus itself. A bit sophisticated point, there is an immunohistochemical stain called P57KIP2, which is a nuclear protein that is only maternally expressed. So it's expressed only in any tissues that contain maternal chromosomes. Complete moles do not have maternal chromosomes, so they will be negative for that protein, whereas incomplete moles and normal tissues will be positive for it. The thecal lutein cysts, they are basically, they resemble the ovarian hyperstimulation cysts, and they will resolve automatically after evacuation or after management of the molar pregnancy. The complications are catastrophic for if this pregnancy continues. So you have to diagnose it early, you have to diagnose it as early as possible, and you have to manage it as early as possible. In England, there are certain centers for gestation trophoblastic diseases for which you can refer your patient if she already has a molar pregnancy, or she has a twin pregnancy with a complete mole or a partial mole, or she has history of choriocarcinoma or any gestation trophoblastic neoplasia. A question that came to us: how is surveillance? How do we do this surveillance for the cases after evacuation? It was mentioned in the Royal College guideline that was published in 2020 for a complete molar pregnancy. If the human chorionic gonadotropin level is reverted to normal within 56 days of the pregnancy, follow-up will be for 6 months from the date of the uterine removal or of the suction itself. If the level did not revert within normal at 56 days, then the follow-up will be for 6 months after normalization of the level. This is the main difference. If the level got normalized, then 6 months from the evacuation. If it is still higher, then 6 months after normalization. Follow-up for partial moles is much less than the complete moles. Women who did not receive chemotherapy do not need any further HCG level measurement afterwards. The management of the gestation of plastic neoplasms are out of the scope of this session, so we can talk about them later on. Thank you. Have a lovely day, and may the other and this session be of any value for all. Thank you so much.
Hello. Thanks a lot, Dr. Brahim Fawzi, for this lecture. And now we reached to the last lecture in our hub with Dr. Professor Ahmed Sulaiman. He will speak about renal disease in pregnancy from a nephrologist perspective. So I'll not take a long time and speak. I'll let you with this informative lecture.
Today we are going to talk about the renal disorders in pregnancy. I'm Dr. Ahmed Sulaiman, a professor of internal medicine and nephrology, School of Medicine, Cairo University. The renal disease can affect the outcome of pregnancy if the patient is a pregnant woman. Actually, it's not a patient. If the pregnant woman caught a renal disease, it will affect the course of pregnancy, and even the pregnancy itself can affect any female patient has a renal disease. So, any patient has a kidney problem and think about getting pregnant, there is a risk of developing more insult for the kidney or more deterioration of the kidney, and vice versa. The renal system even itself undergo many physiological and anatomical changes during the normal pregnancy. In brief, there is a dramatic dilatation of the urinary collecting system in the pregnancy, and the renal blood flow, plasma flow rises up to 80% in the second trimester. Then it starts to decrease to 50%, yet still it's higher than the normal. And lastly, the GFR itself increased significantly and maybe up to increasing of the creatinine clearance by 50%. And this will reflect in urea and creatinine level that we are going to find it in the lower range. Protein excretion itself may increase to 300 milligram in 24 hours, so there is a risk of increased proteinuria during pregnancy. And many of the women that develop edema during pregnancy may be due to sodium retention. Actually, the main illness that we face during pregnancy in any female patient, it's one of the next main items, which is urinary tract infection with all its types, or chronic renal disease, or acute renal insult, and lastly, pregnancy and renal transplant recipient, and there will be a specific talk about this in few slides. Urinary tract infection in any woman may be due to asymptomatic bacteriuria, or maybe she has acute cystitis, and lastly, acute pyelonephritis, which is a more aggressive form of this illness. Asymptomatic bacteriuria, it means that the patient is passing bacteria in urine, but she has no symptoms. And it's range actually from 2 to 10% of most of the patients has urinary tract infection during pregnancy. And the patient who develop symptomatic urinary tract infection from the asymptomatic group is about 40%. And the patient that developed asymptomatic bacteriuria may develop later cystitis or acute pyelonephritis of pregnancy. Most of the organs is related to E. coli, probably getting from the large bowel, or there is a colonization of the E. coli itself, and it is considered ascending infection from perineum or during sexual intercourse. The diagnosis of symptomatic bacteriuria may be patient will say that maybe dysuria, finding some non-specific pain, but when you make the urine sample, you find that the midstream urine sample, there is a colony exceeds the amount of 100,000 of colony bacteria per midstream urine. And the management, we always choose antibiotic depending on the culture and sensitivity. And the main antibiotic we use probably either be ampicillin, amoxicillin, augmentin, or cephalosporins. They are very safe during pregnancy. And the treatment should be continued at least for 2 weeks in first instance. And we are going to make a regular check for the urine sample in midstream samples. The second entity with acute cystitis, and its incidence is not that much, it's 1% of all total pregnancies, and the patient is coming with urine frequency, dysuria, hematuria, and suprapubic pain, and we diagnose it by the midstream urine by finding significant bacteria. The management is similar to asymptomatic bacteriuria, and we advise the patient to make non-pharmacological maneuvers as recurrent passing urine, increased fluid intake, especially emptying the bladder after sexual intercourse. Lastly, the acute pyelonephritis, and it is complicate 1 to 2% of pregnancies, and it's common in pregnant, especially during the woman phase in pregnancy, because there is dilatation physiological in the renal tract. The patient coming with fever, low pain, abdominal pain, vomiting, proteinuria, hematuria, rigors, so all these symptoms, the patient coming with it, and you start to investigate for the reason. The patient who developed this kind of illness, especially who has immunosuppression, that on steroid therapy, or has abnormal anatomy as polycystic kidney, or urinary tract calculi, there is stones that bacteria superimpose on it, or diabetes. When the patient coming, acute pyelonephritis is something you cannot elicit easily, but we put a big differential diagnosis, especially the patient if come with a high grade fever, you put all kind of causes of high temperature like pneumonia, viral infection, acute appendicitis if there's abdominal pain, severe abdominal pain, placenta abruption, whatever gastroenteritis, the most common reason of the abdominal pain. In this case, we make a full blood count and the blood culture to know the diagnosis. Management, 100% must be hospitalized, giving penicillin or cephalosporin, and they are considered as the first choice of antibiotics. Chronic renal disease, actually, it has effects on pregnancy. The pregnancy itself may affecting the patient with chronic kidney disease in the following maneuver, making accelerated decline in renal function. GFR start to decrease dramatically, rising hypertension, and if the patient has proteinuria, it may worsen the proteinuria. Chronic renal disease in pregnancy may include the following things like miscarriage, maybe has preeclampsia, increase the risk of preeclampsia, intrauterine growth retardation, even up to fetal death. So any patient with chronic renal disease may have any of these problems. The factors influencing the outcome, as we see in the previous slide, it may be up to end the death of the fetus. You have to know the degree of the renal impairment, severity and degree of proteinuria, and the chronic renal disease the reason of it, because if you have any preventable disease or you can make any intervention for this patient to improve the kidney, it will be great. The degree of renal impairment, this is mild renal impairment, moderate renal impairment, severe renal impairment. It depends on the plasma creatinine, but by the way, it is in millimole, not the milligram per deciliter. In general, the woman with hypertension or renal impairment before conception maybe have, and patient don't have anything, no hypertension, no renal, no any other medical problem, may develop after pregnancy and have chronic kidney disease, and this may affect the progression of the kidney disease later. There is a specific types of renal disease, especially glomerulonephritis and reflux nephropathy, diabetic nephropathy and lupus nephritis and polycystic kidney disease. This all kinds of illness has specific treatment, and you have to pay attention if the patient get pregnant, and you have to pay attention for any kind of this illness, so as you can give the appropriate treatment. Management, as I say, it depends on the reason, but you have to be aware that chronic renal disease or renal impairment, you have to make both doctors, physician, and obstetric. You make assessment of the renal function and blood pressure must be done, especially before being pregnant. Patient who has increase of preeclampsia risk must receive aspirin. And those who has a big risk of developing worsening more renal problem must receive also aspirin. Careful monitoring of the blood pressure is very important, and follow-up proteinuria. The fetus also should be monitored with regular ultrasound assessment or Doppler assessment to check the circulation inside to avoid intrauterine fetal retardation and up to this. And you have to admit the patient, especially if there is a resistant hypertension or deteriorating renal function, or even eclampsia, preeclampsia, or eclampsia itself. So we have to admit these kind of patients. Acute renal failure, the rate of pregnancy is, as we say, is very low, and the clinical picture is anuria, oliguria, urea creatinine start to rise, and decrease of GFR. The causes, infection as septic apportion or peripheral sepsis, blood loss as in case of postpartum hemorrhage or abortion, if there is a volume contraction as preeclampsia, eclampsia, or hyperemesis gravidarum, there is a big loss of fluids, or there is ureteric damage or obstruction in post-renal causes. There is a specific type which is HELLP syndrome, which occurs as a 7% of the acute renal cases that we see, and there is thrombocytopenic purpura, hemolytic uremic syndrome. They also have acute renal incident, and the management it depends on the cause. This is next 3 or 4 slides. It depends. Talk about pregnancy and renal transplant recipient. As we know that patient once start to make renal transplantation, his physiology, his hormonal start to return to normal again, ovulation, menstruation, everything. Women during pregnancy are advised to wait about 2 years after transplantation to start thinking about the idea of being pregnant. Actually, pregnancy has probably no adverse long-term effect on the graft, and renal allograft will adapt to pregnancy, but maybe 15% of the women develop significant impairment, and about 40% may develop proteinuria. The chance of successful outcome is up to increase to 90%. What means if I make 10 patients get pregnant of the renal transplant, 9 of them will successfully. هو كده كده الريكورد ما تقلقش، هو كده كده الريكورد شغال. انا ما اعرفش اصلا انا طلعت ازاي. اصلا كانش انت كنت شايف او حد شايف؟ دي لا 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 احنا كده كده بنبان، بس كده انت هتبدا من دي كانها بدايه سلايد جديده. So in pregnancy, the chance of successful outcome is about over 90% of the cases, and it is due to 70% if the complication occurs by before the 28th weeks of gestation. And the complication is increasing and higher in diabetic patients. Women should be managed jointly by nephrologists and obstetrics, especially to monitoring the blood pressure and assessment of the renal function test regularly, and the 24-hour urinary protein included, and there is liver function test and blood glucose level as well, and anemia as well, and we are making duplex for assessment of the fetus to avoid growth retardation or any problems, even anomalies in the fetus. The immunosuppressive therapies that we use during pregnancies, we use prednisolone, azathioprine, and cyclosporin A. This is the most preferable during the pregnancy. Cesarean section should only be required if there is obstetric indications. We're giving prophylactic antibiotic even in episiotomy, and we may need prenatal steroids to cover labor if any patient taking steroids at maintenance dose. The neonatal problems that may have during mothers that has renal transplant kidney, the most common is thymic atrophy, transient leukopenia or thrombocytopenia, and decreased or depressed hematopoiesis or hemopoiesis. And this is related maybe to the immunosuppressive treatment and during the passage of medicine in the circulation of the fetus. Actually, I like to thank you for attending today. Hopefully that we make a sum up for the most common kidney disease that we face any woman during pregnancy, and thanks a lot for attendance today.
Thank you, Professor Ahmed Sulaiman. Actually, Professor Eki that will present postpartum hemorrhage lecture has had accident. I don't know, actually he can't attend today, but he told us he will record the lecture of postpartum hemorrhage. So we will upload it in our website page, and we will put it in YouTube channel to can find it again. Now we reach it to the last thing in our webinar, pre-pregnancy related complication hub. So dear instructor and attendees, on behalf of our organization, American Association, I'd like to express my sincere gratitude for your participation in the webinar. Your presence and active engagement made the event insightful and successful. To the instructor, thanks for sharing your expertise and delivering a captivating presentation. Your knowledge and passion were evident. Also, your ability to convey complex concepts in a clear, engaging manner was truly commendable. To attendees, thank you. Thank you for this participation and thoughtful contribution. Your management sought questions, comments, and discussion enriches the learning experience for everyone involved. Once again, a heartfelt thanks for instructor and all attendees for your invaluable contribution. We look forward to the future opportunity to contact, learn, and grow together with us in series of hubs. Just follow us in our page. Thanks for everything. Okay, I can send the link again of a certificate. I'll send it for the last time. And actually, you can find it in the chat box. If you scroll down and scroll up, you will find the link of certificates. You will get your certificate within 1 month. Actually, thanks. It's an honor to be with you today. I'm Dr. Mariam Riz, a medical coordinator and the trainer here. And thanks for all team. Thanks for IT manager, Mr. Sher. Thanks for all participants and medical reps. And see you soon. Bye-bye.